Good morning, everyone, and welcome to the Occupational Safety and Health Administration's informal rulemaking hearing for occupational exposure to COVID-19 in healthcare settings. My name is Kayla Thompson from Apt Associates, contractor to OSHA. Before we begin, we'd like to go over some logistics for today's public hearing. As a reminder, all attendees are muted automatically. If you are speaking today, you will receive a notification on your screen that you are being promoted to the panelist group a few minutes before your time to provide testimony. Once promoted to the panelist role, you will be able to unmute and turn on your camera. We ask that you do not unmute or turn on your camera until your name has been called and you have been asked to start your testimony. Speakers connected by telephone should unmute their phones when called to testify. If you have submitted a presentation in advance, we will share the file and advance the slides. Please cue us verbally by saying next slide when you need us to advance. If you have a presentation to submit for your testimony this afternoon or for a future date, please send it to both public_hearing@aptasoc.com and ets@dol.gov. Presentations submitted at the time of your live testimony will be submitted to the public record but will not be shared on screen during the testimony. If you are having technical difficulties, please send an email with your name and phone number to public_hearing@aptasoc.com. I will now pass the floor to our administrative law judge to call the hearing to order.
Good morning, everyone. We are on the record now, and the hearing will come to order. This is the third day of an informal public hearing on the Occupational Safety and Health Administration's proposed rule on the COVID-19 healthcare standard. The proposed rule was published on June 21st, 2021 in volume 86 of the Federal Register, beginning at page 32,376. I am Associate Chief Administrative Law Judge Carrie Bland, and I will be presiding over this hearing today. The purpose of this hearing is to receive from interested parties oral testimony as well as other information pertinent to the proposed rule. After this hearing and the post-hearing comment period have closed, OSHA will review the entire record in determining the content of the final rule. My role as the presiding judge will be limited to conducting this hearing to assure that a complete and accurate record is made, and that all interested parties receive a fair hearing and have an opportunity to submit their information. The hearing schedule and OSHA's procedure governing this hearing are available on the website for this hearing. These documents were sent to people and organizations who filed a timely notice of intention to appear at this hearing. I'd like to say a few words here about the nature of this hearing. Despite the informal nature of the hearing, it is governed by rules, both OSHA's rules governing hearings at 29 CFR Part 1911 and the hearing procedures issued specific to this rulemaking. These rules are meant to assure that everyone has a fair opportunity to speak and express an opinion about the proposed rule. To that end, they also allow me to hold witnesses to their allotted times, limit undue repetition or excessive argument, and generally keep the hearing on schedule. Any written comments you have submitted to the docket are already part of the record in this rulemaking. In the rare case where witnesses wish to provide any other documents that have not already been entered into the docket, they should provide them by email to ets@dol.gov before the witness begins their testimony so that they can be entered as exhibits in the record. Because all pre-submitted documents are already part of the record, your oral testimony should concentrate on presenting the highlights of your written comments or clarifying your written submissions. Stakeholders may also submit additional evidence or statements for a period of 21 days from the end of the hearing, which will be May 23rd, 2022. At that point, the record for this rulemaking will close. Today, after each speaker or panel of speakers completes giving oral testimony, OSHA representatives will have an opportunity to ask questions of the speaker or panel. When OSHA has finished asking questions, there will be an opportunity, as time permits, for persons who filed a timely notice of intention to appear to question the witness or panel. Each individual will have an opportunity to ask one question today. This is the process I intend to follow. After OSHA has finished asking questions of a panel or witness, I will ask participants who wish to ask questions to identify themselves by pressing the raise hand button in WebEx or *3 on their phones for those who have called into the WebEx. Based on the hearing schedule and the number of participants who wish to ask questions, I will determine the order in which participants will question the particular witness or panel and any time restrictions on that questioning. If there are more questions than we have time for today, it may be possible to ask additional questions on Monday afternoon after the conclusion of the final witness's testimony. I would also like to remind you that this proceeding is being recorded and transcribed by a court reporter. To ensure that the reporter is able to provide an accurate record of all the testimony, questions, and responses, please try to remember to provide verbal responses to all questions. The court reporter may not see you if you nod or shake your head in response to a question. In addition, please remember to identify yourself before beginning your testimony and before asking or answering a question. And do not worry, I will remind you or pipe in if you don't do so. The transcript of the hearing will be uploaded to the hearing docket on regulations.gov approximately 2 weeks following the hearing. This morning, we will have 2 panels of speakers, after which we will take a lunch break. I expect that lunch will run from approximately noon to 1 p.m. Eastern. Now, unless there are any further announcements or other housekeeping matters, I believe that we can proceed with the public testimony. The expected speaking order is currently displayed on the screen. I will be introducing each speaker in turn. Speakers, please speak slowly and clearly so our court reporter can record these proceedings accurately. The first panel of speakers will be from the American Federation of Teachers. Will the contractor please promote the speakers to be panelists?
They have been promoted.
Right. And beginning with Kelly Nedrow. Apologies if I have not pronounced your name correctly. Please state your name and affiliation for the record.
Kelly Nedrow, American Federation of Teachers.
And Mr. Calzia, if you could go down just quickly down the line of who will be speaking today.
My name is Matt Calzia. I'm with the Oregon Nurses Association.
All right. And is Ms. Dayton here, and Ms. Mount, and Sean Bob, and Sarah Markle Elder?
Sherry Dayton's here.
Sean Bob is
Hi,
here.
but Cheryl Mount is here.
Sarah
Markle is here.
Right, Ms. Ned, did you begin?
Thank you, Judge Bland, and thank you to Secretary Walsh and to OSHA for this opportunity and for reopening rulemaking on this critical matter. I'm Kelly Nedrow, and my background includes union and legislative representation of healthcare workers, executive staff for 2 of the country's largest state nurses associations, a licensed attorney in multiple state and federal jurisdictions, and also a president and CEO in a Medicare participating healthcare facility. Today, I testify in my current capacity as Senior Director for Health Issues, working for President Randy Weingarten at the American Federation of Teachers, where I oversee the AFT's program on occupational safety and health, as well as our healthcare division, which is comprised of over 200,000 nurses, physicians, and other healthcare professionals working in all settings where care is delivered, but mostly in acute care settings. And I speak in support of OSHA's promulgation of a fully protective permanent COVID standard to protect workers in healthcare settings. The record is already full of comments and testimony describing the hardships the pandemic has imposed on the healthcare workplace, and our amazing witness panel will enrich the detail with their compelling knowledge and stories today. There are some interest groups, some representing our employers, who would suggest that a permanent standard will force undue burdens on healthcare employers, that alignment with guidance and recommendations from other federal agencies should be the measuring stick for worker safety, and that more flexibility is needed. Some even claiming these positions are warranted because the pandemic is winding down, and that COVID should be treated as a more established infectious disease in the healthcare workplace. But the public health emergency enacted in January 2020 was just extended earlier this month, an extension that was called for by those very same groups. In fact, President Weingarten requested an extension last fall of the healthcare COVID ETS. She underscored requirements of some of the critical protections that our healthcare workers have relied upon during the pandemic. Things like requirements that employers assess risk for their facility and implement a written plan based on that assessment. Provisions encouraging worker input and stipulations for paid time off for workers to receive and recover from COVID-19 vaccine. The ETS included a requirement for respirators and other personal protective equipment, ventilation, and training. Most critically, perhaps, the ETS obliges the employer to notify workers of exposure and includes requirements for medical removal, wage, and whistleblower protections. These layered mitigations work together and in combination with exposure for healthcare workers and ongoing spread in communities. We've been able to do training with our members on workplace protections afforded through these OSHA protections, as well as supporting them in efforts to enforce their rights, because our members have needed to use the machinery of OSHA enforcement to keep employers toward doing the right things to keep them safe. And we have seen many of our employers cited by OSHA for safety infractions. Most American healthcare workers, however, are unrepresented and do not have a union watching their back like this. Union density in the United States is not high, and in the still predominantly female professions in healthcare, it is definitely not high. So our best hope for most workers is that they know how to find out what their rights are and that the protections are there for them to enforce their right to be safe at work. While we know there is little evidentiary value in telling you how it felt to healthcare workers when the healthcare ETS was revoked, it is important context to understanding why a standard is necessary. And the revocation of the ETS put workers into a position where employers could fall back to a lower, more routine level of protective policies for workers. But the fact of the matter is that delivering patient care over the past 2 years has been anything other than routine. And I might add, the extension of the public health emergency indicates we still are not in routine times. Our members still show up in these emergent times, and we need OSHA to protect them. Over the course of the pandemic, we have shared with OSHA that the healthcare workforce has largely been on their own to make things work in hospitals. In some cases, no managers on site to serve as a resource or a backup. In even more hospitals, workers not having appropriate respiratory protection and being forbidden to use their own, but still being required to deliver care for patients. Patient care areas where infection control precautions seem to be thrown to the wind. We had hospitals where most of the respiratory therapists, for example, were out because they contracted COVID at work, making conditions for the few who were able to work very hazardous. We've heard of hospitals telling workers to come into work with COVID as long as they weren't too sick to deliver care. And even in some cases, in a hospital in Alaska, for example, where a manager actually told a worker to not tell anyone that she had contracted COVID and let that nurse care for an HIV patient, putting that patient and her coworkers at risk. We've had healthcare workers living in campers in their driveways or staying in hotels to protect family members because their employers weren't protecting them. They couldn't Zoom into meetings like many of us. They kept going to work every day in spite of the hazards because they felt a sense of duty to their patients and to their communities. We all rely on them to do this, yet most employers did not reciprocate with the same sense of duty to them, only required more, pushing our healthcare workers to the point of utter and complete exhaustion. We understand the burden of healthcare employers being accountable to multiple regulatory structures at the state and the federal levels. We understand the arguments in favor of more flexibility and perceived simplicity that would come with alignment of OSHA standards with standards and recommendations from CDC and CMS. These sorts of arguments aren't new, however, and they certainly aren't unique to this pandemic. In fact, healthcare corporations invest a great deal of money into becoming quite adept at navigating these structures, as evidenced by the norm of multi-million-dollar executive compensation packages. These complexities are routine in healthcare. All corporations entering the healthcare industry understand this as a part of doing business. What is not routine is workers in healthcare settings have quite literally been pushed to the brink. Many have left clinical care deciding the hazards and stressors are not doable any longer. And sadly, many of our healthcare colleagues have fallen to COVID or even some to suicide because they couldn't take the pressure anymore. We now find ourselves in a staffing crisis, which we don't expect OSHA to solve, but it is relevant because the instability perpetuated by the staffing shortages dangerously compromises safety in the healthcare workplace. And let's not forget that employers were given a great deal of flexibility at the beginning of the pandemic by OSHA on many requirements like fit testing. They were told to try their best. What happened? Workers died. We have a legitimate fear that a standard with flexibility, like a safe harbor for healthcare employers who adopt CDC guidelines, amounts to a per se hazard for workers in those facilities. The workers who we are advocating for are not millionaires. They cannot fall back on protected leave of the ADA or FMLA to ensure they're safe at work. In fact, I've heard so many times from nurses and others who were pressured to return to work sick because of inadequate staffing, or to not take time off at all because their COVID symptoms weren't severe enough for the employer to want to excuse their leave. This is what undue hardship looks like. These workers can't zoom into work like their bosses. Medical removal protection remains essential to keep all workers and their patients safe. We implore OSHA to adopt a standard that does not cede its mission to another agency. CMS, for example, exists to protect beneficiaries of Medicare and Medicaid, and the mission of CDC is certainly protection of public health. But the mission of OSHA is clear and necessary: to ensure safe and healthful working conditions for workers and setting and enforcing standards. We need a standard that has expansive coverage in healthcare workplaces. Workers in ambulatory settings cannot have no control over the fact that traffic in their workspace includes people who've been free to walk in other parts of a hospital facility. Trigger of precautions by an outbreak is going to be too late. Workers need to be guaranteed time off when they get sick so that they aren't pressured to come in and infect their coworkers. Vaccination advances continue to evolve, and we need employers to remain obliged to give workers paid time to be vaccinated. These protections have been crucial to keeping workers safe and to keeping many of them at the bedside, and these sorts of protections should not be viewed as an infringement of state law. Consolidation among healthcare corporations has meant businesses span across states and even national borders. For many reasons, it's understandable that healthcare companies have needed to find ways to cut costs, but too often those cuts are made at the expense of the workers. We simply cannot support dilution or even the absence of a standard to keep healthcare workers safe from COVID-related hazards in their workplaces. We need OSHA to promulgate a permanent standard, one that will keep healthcare workers alive and safe at work. Thank you for your time and attention.
Thank you for your testimony. Next, we will hear from Matt Calzia.
Thank you, Judge Bland and OSHA staff, for this opportunity to speak to the challenges that we frontline healthcare workers have faced during this pandemic. My name is Matt Calzia, and I've been a registered nurse and a member of the Oregon Nurses Association for almost 11 years. I've been on staff at the Oregon Nurses Association as a nursing practice consultant for about 3 years, and continue direct care nursing at a local hospital on a per diem casual basis. Having bedside experience coupled with my consulting work with direct care nurses across the state provides me with a unique and comprehensive vantage point to make my assessments. In the early stages of the pandemic, we were met with overwhelming fear and ever-changing guidance from the CDC and our state hospital regulator. The Oregon's hospitals often told frontline nurses, the CDC is just guidance, it's not regulation, and it's changing so frequently that we're just doing the best that we can. This has been throughout the pandemic, because that guidance from CDC has been changing quite frequently. And this has exacerbated our anxiety at the bedside. We felt that it left us no path to accountability when we would raise our concerns around the safety for us, the workers, and then we know that safety it impacts the care that we deliver and the safety of our patients who come to us for safe care. At one point where I work, administration refused to allow nurses who were performing nasal swabs for COVID-19 infection to wear an N95 or better respirator while performing those swabs. When we challenged the hospital and we held up the CDC guidance stating that we should be wearing this level of PPE, we were told that no, you can't have that level of PPE, and that there's a spectrum of appropriate PPE designated by the CDC. And so they did not allow us to wear the highest level of protection. They refused. This, again, brought a lot of anxiety as we're trying to serve our community and test all of the people who are having symptoms and trying to slow the spread of COVID-19 in our community. We also knew that the hospital was reserving many of the N95s for non-urgent elective procedures so that they could continue those revenue streams. Another situation that I encountered working as a nursing practice consultant is a colleague who was working at the premier academic medical center in Oregon, arrived to work one day and found a used N95 mask in their locker, a locker that they shared with another nurse. This caused a significant amount of anxiety, and the nurse escalated these concerns to their manager, who the manager then claimed this was a safe practice. The nurse persevered and escalated this to the highest levels of the institution using the chain of command, and at each level their concerns were dismissed, and she often faced insidious forms of retaliation for raising these concerns. Management asserted the practice fell somewhere in the spectrum of CDC guidance on reuse of PPE, but when the nurse called OSHA and asked for some guidance about this, OSHA confirmed this was an unsafe practice, but there were no regulations at that time in our state around it. And but when the hospital did see the email communications between the nurse and OSHA, they immediately changed their practices, but there was no accountability. Ultimately, the nurse had to leave this unit because she was retaliated against for blowing the whistle. She had prolonged, hostile, and insidious ramifications that impacted her work, and she had to move on to a different area within that institution to provide care to patients. In the fall of 2021, the Delta variant overwhelmed Oregon's healthcare system. Hospitals were over capacity, and we had to discharge patients to home health services in high numbers. A home health nurse member of the Oregon Nurses Association was not allowed to wear N95s for every patient contact. They were told only if the patient had tested positive or had some symptoms, which we know during Delta, asymptomatic spread was one of the most detrimental features of that variant. The patient was told that it was unnecessary, and this was early in the Delta surge. Later on, this same healthcare system told the nurses that they must wear N95s when going in to meet patients. The nurse contracted COVID-19 and was out of work for 8 weeks and still has some prolonged long-haul symptoms. And the employer denied this nurse medical removal benefits and claimed it was not a workplace exposure, and actually asserted it was a community exposure. By definition, this nurse works in the community. While they were going to people's homes to prevent them from going to the hospital, the nurse was actually even going and seeing patients in their tents, seeing unhoused patients who were sleeping in tents. And they were told, this nurse was told by the employer, you got this in the community, we're going to deny the medical removal benefits. This is no way to treat frontline healthcare workers who are supporting the medical system and who have been revered as heroes. This pandemic has devastated the nursing profession, leaving us with severe shortages and a workforce that is mentally and physically fatigued. The fatigue is the result of feeling undervalued and unprotected. In the beginning, I remember the beginning of the pandemic, we shared funny memes with each other. And we would have these, a meme is, where you have, it's like a picture that you send each other on text or in social media, but it would have a picture of a nurse or a healthcare worker in another country wearing a P100 respirator eye protection, a full bunny suit, and then it would have another picture of us in America, you know, going in with like a paper gown and a small mask. And while this humor helped us deal collectively, it was just a sign of the anxiety that we were feeling and how we were feeling unprotected by our healthcare system. And this was occurring while we knew that healthcare colleagues across the world were dying, and we were terrified and continue to have a lot of concerns about the unpreparedness that our employers demonstrate. So now we are entering another phase of the pandemic, and Oregon's hospitals are rushing to get back to normal, the pre-pandemic normal. Dedicated COVID-19 units are being dismantled, and COVID-19 patients are being placed in the general population. Home health agencies, who are mostly free of regulations around this, are resorting to the broad guidance of the CDC again, picking and choosing which guidance to follow as it suits the business model. We are in a better place, but without clear rules and regulations, we are left vulnerable to the next surge or the next emerging disease and the whims of hospital administrators. If there are key things to learn from this pandemic, it is that hospitals will remain woefully unprepared for public health emergencies and will only adhere to clear regulations. They'll pick and choose guidance, but they will adhere to regulation. And as it was previously mentioned, hospitals operate in an environment of immense regulation that is their duty, and they know how to do it. In conclusion, all I can say is front care healthcare workers deserve better. Thank you very much for your time.
Hey, thank you. I'll just note that to keep on track, please limit your comments to approximately 7 minutes. So Sherry Dayton, please identify yourself and who you represent and begin speaking.
Hi, thank you for this opportunity. My name is Sherry Dayton, and I'm an emergency room nurse at a community hospital in Connecticut. I've been a healthcare worker for 30 years, a nurse for 16 of those years, and for the last 10 years, I've worked in an emergency department. I am my local union president for the last 4.5 years, and I am healthcare divisional vice president in my state union for almost a year now. As the pandemic started, it was immediately apparent to us that we needed to fight for equal standards to protect healthcare workers. Doctors were getting to wear full face shields and hospital scrubs, but other healthcare workers had gotten denied them and told wearing masks would scare patients. We were not allowed to wear masks until 2 weeks after the first COVID patient began to arrive. Later, we were allowed to wear N95s, but only for aerosol procedures. Transporters at another hospital were taking COVID patients into elevators, but denied N95s. A patient care tech at a different hospital was infected after being denied an N95 while caring for COVID patients. It was apparent that my hospital and others were not prepared. In April 2020, pregnant women started to come from New York to Connecticut hospitals to give birth. And it wasn't until we had COVID positive patients and babies that my hospital started testing these patients and giving N95s to the labor and delivery staff. A psych hospital in Connecticut was cited by OSHA for having no respiratory protection program at all after an outbreak among staff and patients. The supply of N95s was low. We were required to wear them until they were visibly compromised. We did not get to decide when they were visibly compromised. A manager determined when we could get a new N95, and the supplies were locked up. During this period in 2020, when we were reusing N95s for many days and storing them in brown paper bags, we had multiple staff outbreaks in the operating room, aggressive care unit, and A3, our COVID floor. During this time, Elva Graveline, a 53-year-old employee at L&M Hospital who had worked there for 23 years as a patient care technician, died of COVID. She worked on the COVID floor. She was having to reuse her N95 and go in and out of that brown paper bag to get it. In nursing school, we learned that these were disposable one-use items. Best practice today is the same as it was when I was in nursing school. To not infect yourself, you had to don and doff your equipment in certain procedures, and it was never to reuse an N95. We had several members develop long COVID. In one of the outbreaks, a nurse with diabetes got infected and took it home to her elderly mom and her 2-year-old child. She now has long COVID. Another nurse who was disciplined for complaining about N95 policies was infected. She was flown to a tertiary hospital and intubated. She still has not been able to return to work since October 2020. One of our critical care nurses, who were in her mid-20s, was diagnosed with MS very shortly after having COVID. Since then, we have seen some studies showing that COVID-19 can activate some autoimmune disease. In her mid-20s, she has now been denied an ADA accommodation to continue working in her dream profession of critical care nursing. In our critical care unit, they work 12 hours and frequently mandated to 16 hours, and she just cannot sustain that. I myself contracted COVID in December of 2020 after being exposed to 2 patients while only wearing a surgical mask. It was the sickest I've ever been in my adult life, and I had symptoms for up to 6 months after it. My healthcare organization covered my medical bills, but they denied my workers' comp. More and more healthcare workers are seeking mental health services for moral injury, PTSD, and burnout. COVID has called healthcare workers to lose their love of serving the public health needs. This stress has increased unhealthy coping mechanisms. We had to fight for protections we got. We ended up going on strike in October 2020. And as a result, we finally gained the right to decide for ourselves when we needed a new N95. However, we are still reusing N95s to this day in April 2022. In January of this year, shortly after the ETS ended, a quarter of the patients in my hospital were COVID positive, and 110 nurses were mandated to work a 16-hour shift in that hospital that month. These days, my employer has weakened isolation and testing policies that would protect workers and patients. We are not notified of exposures. Patients with COVID symptoms wait in waiting rooms and with other patients. They are not placed in negative pressure rooms. COVID patients are sometimes placed in hallways with only a curtain separating them from everyone else. People coming to the facility for outpatient procedures are not tested. The hospital allows visitors who are COVID positive to visit loved ones who are on comfort measures and dying. But there is no effort to ensure that these COVID positive people avoid getting into elevators with others or going to the cafeteria. We know of several cases of COVID positive visitors lying to screeners. We still have not returned to a one-time use of N95s. It was hard for me to write this testimony. I don't ever want to go back to this reactive, crisis-driven way of handling this pandemic. No healthcare worker does. It costs healthcare workers their quality of life, and for some, it costs them their life. We need to have a proactive approach, and to do this, we need your help with an enforceable COVID-19 permanent standard. Thank you very much for your time.
Thank you for your testimony. Next, we will hear from Cheryl Mount.
Hi, my name is Cheryl Mount. I've been a bedside nurse for the last 37 years, with most of that time spent in critical care in the cath lab. Presently, I work in a post-anesthesia care unit. I'm also the president of HPAE Local 5105 in Southern New Jersey, right across the bridge from Philadelphia and about an hour and 15 minutes south of New York City. We are celebrating 25 years as a strong, educated, and mobilized local with approximately 740 RN members working in a rapidly growing South Jersey healthcare system. Our members work in various settings, include outpatient surgery, a high-volume OR and recovery room, cardiac rehab, infusion centers, an extremely busy emergency room, inpatient med-surg units, critical care units, maternity services, pediatric services, and an inpatient behavioral health unit. It's hard to put into words what it's been like working as a bedside nurse through this pandemic. I get emotional talking about what has transpired over the last 2+ years. I equate it much like being in a war zone. Never in my 37 years of nursing have I been so horrified to be a nurse, and at the same time, so proud to be a nurse. In most nurses' eyes, there's been 4 COVID-19 surges, and each surge has had its own unique set of challenges. I remember thinking during the first surge, if we just make it through this with none of our members dying, we'll be lucky. Well, we made it to the third surge when we lost a beloved RN from the OR. We've had over 75% of our members testing positive at one point during this pandemic. Many members were seriously ill, hospitalized, and some are still recovering with long COVID symptoms. I've watched my coworkers develop post-traumatic stress disorder in real time. I believe the understanding, the lived experience of healthcare workers will provide a unique lens through which to view what we've endured during this global pandemic. It serves as a historical starting point to reap the benefits from the lessons learned from our experiences. It was a daily battle, not only to care for our patients, but to hold our employers accountable for our workplace safety. We went from being hailed as heroes to being utterly overwhelmed by the constantly evolving policies, procedures, and guidelines regarding COVID-19. We wanted a voice in these policies and guidelines, but were ignored and told, just do it. Some of the issues we had to endure and fought for better protections for include PPE shortages, fake and faulty PPE, much confusion around decontamination of N95 respirators, the lack of adequate and accurate fit testing for staff providing direct patient care to COVID-19 patients, ever-changing rules regarding PPE and isolation procedures, the lack of adequate testing for patients and staff, numerous staff exposures and COVID-19 infections, severe staffing issues and lack of ancillary support staff, poor and confusing communication and education regarding COVID-19, numerous and confusing policy changes with no staff input, and lastly, the feeling of being disposable with unmeasurable moral injury. The ETS did make a difference for us. Our local was supposed to start contract negotiations in March 2020. We held an emergency meeting instead, and we proposed weekly meetings with our employer to discuss COVID-19 pandemic preparedness issues. The employer rejected our request for these weekly meetings, which left us constantly in chase mode to get any and all COVID-19 issues addressed in real time. We just wanted a proactive voice in our workplace in these unprecedented times. We did get to the bargaining table virtually during the short lull between Surge 1 and Surge 2 the summer of 2020. Our local proposed and won language to address our COVID-19 pandemic-related concerns in a side letter, creating a joint pandemic preparedness committee with our employer. This committee was designed to address PPE supplies, PPE requirements, and the changes to these requirements, COVID-19 communications with our employees, contract tracing and exposure responses, and COVID-19 pandemic training. Our first meeting was in November of 2020. Although we had the opportunity to sit down with management and address our pandemic-related issues, we had no real teeth to force our employer to address our serious safety concerns in real time until the OSHA ETS was issued in June of 2021. We used the ETS requirements to drive our committee agenda. Although it was not perfect, we thought it was a starting place and a recipe for success to finally get all healthcare facilities covered under the ETS on the same page. With the CDC guidelines consistently going downhill and putting healthcare workers at risk, we felt finally someone cares about our safety in the workplace. We used the ETS as a tool to demand transparency regarding our employer's COVID-19 plan and insist on a well-defined process to notify our members of exposure or possible exposure in a timely manner as per the ETS. We openly and proactively discussed PPE supplies and fit testing. We did end up discovering serious issues with fit testing and poor access to N95 respirators on several of our direct patient care units. We attempted to address these issues at these meetings, but eventually had to file a total of 3 formal OSHA complaints. We settled one complaint regarding fake and faulty PPE because management covered their tracks and because many members were too exhausted and intimidated to speak to OSHA. Ultimately, no citations were issued. But because our local filed these complaints, management corrected these issues. Now they know our members will speak up. OSHA emphasized repeatedly that should our members have difficulty finding access to authentic PPE and N95 respirators, they should contact OSHA and initiate another complaint. As a union, we held on to hope that management would respond directly to the union's documentation and complaints, so we did not have to resort to asking OSHA for assistance when our members' safety was at risk. Unfortunately, the ETS expired during the 4th surge in the last week of December 2021. Hundreds of our members, both vaccinated and unvaccinated, developed COVID-19-like symptoms. They were unable to get tested. The employer's hotline for reporting symptoms and requesting testing broke down. They were unprepared, even though there was every reason to believe a surge was coming due to reports of Omicron in Europe.
Ms. Mountain, you have about 30 seconds left.
Okay. I think I'll be done in 30 seconds. Employees experienced symptoms, were unable to get through the hotline, and were being placed on hold for 4 to 5 hours just to schedule the required testing as per hospital policy to report to work. Even when members were getting through, appointments for employee COVID-19 testing appointments were limited and not available for 2 to 3 days. One would think by the 4th surge and close to 2 years into this pandemic that employee COVID-19 tests would be the one thing that would be up and running like a well-oiled machine. Many members, including myself, never were able to get tested and reported to work because our symptoms were not that bad and just thought we could just wear our PPE and social distance. This COVID-19 hotline issue was reported to the employer immediately, but took 2 weeks to resolve the issue. As you can imagine, this failed hotline system also caused a severe staffing crisis because infected workers could not receive instruction on when to report back to work. I want to urge OSHA and employers not to ignore the lessons learned from this global pandemic. We must take these valuable lessons and memorialize them into a recipe for success for future generations to follow and build upon to keep all healthcare workers safe and at the bedside, caring for patients. Many mistakes were made that must never be repeated. Let's learn from them. Thank you for the opportunity to speak for all bedside nursing.
All right, thank you for your testimony. Next is Sean Bob.
Good morning. Thank you for the opportunity to testify this morning. My name is Sean Bob. I am an occupational safety and health specialist for the New York State Public Employees Federation, commonly referred to as PEF. We represent over 50,000 scientific, professional, and technical employees of the state of New York, including frontline healthcare workers and those that work with some of the New York State's most vulnerable populations. Public employees have a high amount of public contact and high density work environments. As public employees, PEF members are covered by the state OSHA plan, the Public Employee Safety and Health Bureau, or PESH, administered by the New York State Department of Labor. The state plan was slow in adopting the ETS and even slower in implementing the standard. PESH made the rule effective on 10/21/21, and it only remained in effect for 90 days until January 18th, 2022. Nurses and other healthcare professionals working in state-operated healthcare facilities were covered by the ETS, but even though PEF and other worker organizations petitioned PESH to expand the ETS to other high-risk work sites, that fell on deaf ears. Because of the short period of time from implementation of the rule by the state plan before the ETS expired, we have little or no data regarding the impact of the ETS. But what we do know is that during the midst of this pandemic, PEF members were confronted with great risk of exposures to the virus, high infection rates, inadequate supplies of PPE, staffing shortages, and improper ventilation. Our members were needlessly put into harm's way. While protections for healthcare workers are of critical importance, workers in congregate settings are also in dire need of protection. These include locations such as correctional facilities, mental health facilities, juvenile residential facilities, and group homes, among others. These workers interact with some of New York's most vulnerable populations who may not be capable of using the measures the average person can use to protect themselves. They may be at high risk with comorbidities themselves. They often have low vaccination rates. They may not be able to social distance, nor know how to use hand hygiene, or understand why their caretaker cannot hug them and drive their chairs. This made it all that more important for these higher level protections provided by the ETS to be extended to those settings as well. During this pandemic, high rates of COVID-19 infections, illnesses, and the number of deaths were recorded among congregate settings in New York State. Some examples include the New York State Department of Corrections and Community Supervisions reported 12,529 staff COVID-19 infections and 18 staff COVID-19 deaths through April 27th, 2022. The New York State Office for People with Developmental Disabilities is responsible for coordinating services for New Yorkers with developmental disabilities. The agency provided services directly and through a network of private agencies. Through April 20th of 2022, OPWDD has acknowledged 24,320 COVID-19 infections and 49 COVID-19 deaths among both its employees and those of the private service providers. The New York State Office of Mental Health reported 4,618 staff COVID-19 infections and 12 COVID-19 deaths through April 26 of 2022. The New York State Office of Children and Family Services reported 637 staff infections through April 21st, 2022. We can reasonably assume these numbers are greatly underreported and lower than what actually occurred. The infections, long COVID, and deaths experienced by PEF members and other workers are not solely a result of the healthcare activities defined in the ETS. PEF members and other employees such as therapists, counselors, direct support assistants, therapy aides, among others, perform their duties within close proximity of clients and colleagues. These hard-working essential employees are required to provide physical therapy and to clothe, feed, and bathe their clients. They are working indoors in crowded conditions and often with poor ventilation, placing them at significant risk for exposure and infection, especially to the more transmissible variants of COVID-19. Now is the time for OSHA to provide these workers with protections they deserve by expanding the scope to include congregate settings. The healthcare ETS was a step in the right direction, but there is room for significant improvement to incorporate into the permanent standard. PEF is recommending the following: broaden the scope to include all workers, especially those in congregate settings and correctional facilities. As stated in the hearing notice, the standard is being developed to protect workers with a significant risk of occupational exposure to COVID-19. My comments have demonstrated that significant risks to workers in congregate settings and correctional facilities does exist. The full participation of the authorized employee representative must be included in the infectious disease program and plan development and review. Do not align the permanent standard with CDC guidance documents. CDC guidance documents have changed often since the start of the COVID-19 pandemic. CD guidance does not provide the protection employees need, and workers benefit from consistent, enforceable standards of protection as has been achieved with other OSHA regulations. COVID-19 is an airborne transmissible disease. Ventilation and filtration are crucial tools for controlling the spread of COVID-19. The standards to specify minimum outside air requirements and requiring air purifiers in areas where minimum outside air requirements cannot be achieved. In congregate settings, it is not unusual to have services provided in outdated buildings with inadequate or no mechanical ventilation. Employers should be required to verify the ventilation is providing the minimum outside air requirements and to share that information upon request to workers and their authorized employee representatives. Require employers to provide medical removal with pay. Many workers are forced to work while sick. This facilitates the spread of COVID-19 in the workplace and lengthens the cycle of infections. Include record keeping for reporting of the presence of infectious disease cases in the work environment, not just for cases that are determined to be work-related. Positive workers may not have been exposed at work, but in turn expose others at work. Accurate and up-to-date reports of infectious disease rates for employees and populations served must be given to the authorized employee representative. The standards should cover employers regardless of their screening procedures. OSHA must recognize that a significant percentage of COVID-19 infected individuals are asymptomatic. Non-employees should be considered suspected COVID-19 until a negative test result is received. Protect employees regardless of vaccination status. Vaccination protection wanes and breakthrough infections occur frequently. Respiratory protection for employees interacting with non-employees who have not tested negative.
You have approximately 1 minute left.
Thank you. Develop a notice procedure for employers that is consistent across industries. Include notice to employees that a positive case was in the workplace, the last date the individual was in the workplace, the general location of the exposure, that workers should monitor for symptoms, and who to contact with any questions. The notice should also be given to the authorized employee representative. Develop a contact tracing procedures for employers that is consistent across industries. Employers cannot abdicate contact tracing to local health departments. These agencies are often backed up and delays will be more exposures at work. The employer contact trace is limited to who the employee had contact with at the workplace. It will not extend to personal contacts. The employer must include contractors in the contact trace and notice procedures, and for purposes of reporting the identification of the positive case to the authorized employee representative. Require all employers covered by the standard to provide access to vaccines and boosters at no cost to the employees in either time or money. Vaccines and boosters should be encouraged through education and training and not mandated. The pandemic has changed so much about what we understood about workplace safety. We've learned so much through trial by fire over the last 2 years, and we're not out of the woods yet. OSHA has the opportunity right now to make real changes for worker protection. This concludes my testimony, and thank you for the opportunity to present today.
Thank you for your testimony. We will next hear from Sarah Markle Elder.
Thank you, Your Honor. My name is Sarah Markle Elder. I work for the American Federation of Teachers in the Health Issues Division. I want to note that my presentation is about 6 minutes. However, I also want to note that Mr. Calzia will have to sign off at 10:45. And so if OSHA staff are planning to ask him questions, he should be first in the queue. Thank you.
All right. Thank you for that information.
Thank you. I want to thank OSHA for this opportunity to share our members' experiences. We have given examples of how the ETS created a safer environment and what happened when that accountability was taken away. We look forward to a permanent programmatic standard for COVID-19 that requires employers to develop a comprehensive prevention program based on periodic exposure risk assessment for all parts of the facility or operation. This site-specific exposure assessment is critical to protecting workers. Community transmission rates are a lagging indicator for infection within a facility. Workers most likely will already be left exposed and vulnerable if increased controls are only activated by an elevated community transmission rate. We recommend weekly assessments of exposure risk. In addition, frontline workers must have genuine involvement in the development and evaluation of the prevention plan. Employers can assess exposure risk by conducting systematic surveillance testing of staff and patients who are admitted to facilities or who enter for outpatient procedures. With 50 to 80% of COVID infections being asymptomatic or pre-symptomatic, screening alone is a weak control that must be combined with rigorous universal testing protocols for staff and patients. We have heard far too many cases of healthcare workers being exposed and infected after treating patients who were admitted for other needs. Surveillance testing is a feasible control that can be done in multiple ways, including weekly pooled testing for staff. OSHA can offer a programmatic approach for employers, but the standard must require exposure assessment. The infection rate must be recordable and reportable to OSHA, to workers, and to the authorized collective bargaining agent. The standard should require employers to include their testing protocols and any updates in their written plan. The standard should emphasize the need for a set of layered mitigations ranked by the hierarchy of controls. Written plans must demonstrate overlapping controls, including isolation, ventilation, testing, and ready access to fit-tested respirators and eye protection, in addition to vaccination and screening. OSHA should require evidence of efforts to apply multiple mitigations within written plans. Higher requirements for ventilation and filtration in all covered settings are critical elements that will help to demonstrate robust overlapping controls. The standard must require hospitals to adhere to ASHRAE 170 and ASHRAE COVID-19 guidance. Ventilation maintenance plans and protocols should be included in the written plans. OSHA should incorporate ASHRAE COVID-19 guidance for outpatient clinics, congregate facilities, and other settings covered by the standard. And I fully support my colleague Sean's call to cover all of these facilities. OSHA should hear those figures again. Those were really high rates of infection and death. Because enhanced ventilation is not possible in home health settings, these workers must be provided with fit-tested respirators. We have heard of many cases of home health nurses being denied face masks as well as respirators. Surveillance testing should apply to home health settings as well. The standard should require employers to demonstrate preparedness planning for surge conditions. Sherry and Cheryl have both described facilities that were unprepared and reactive. There is no reason for this to ever happen again. OSHA must promulgate a standard that requires employers to develop capacity for surge conditions. This includes investing in and maintaining PPE stockpiles. Hospitals can invest in elastomeric respirators or PAPRs and CAPRs as a feasible means of maintaining and storing a sufficient supply of respirators. Elastomeric respirators are inexpensive to buy and maintain. Adding training on use and disinfection of elastomerics to the existing respiratory protection program is a feasible means of being prepared for surges. Many hospitals attempted to enhance ventilation or create temporary airborne infection isolation rooms with portable HEPA filtration units. As Nancy McClelland of AIHA explained yesterday, permanent ventilation solutions are best. However, we recommend that OSHA incorporate NIOSH's evidence-based approach for temporary expedient isolation rooms for surge conditions. NIOSH has created guidance and instructions on creating temporary airs and ventilated headboards. NIOSH's evaluation shows that expedient isolation rooms can be as effective as permanent airs, which cost approximately $30,000 more than traditional patient rooms. Ventilated headboards have been shown to successfully remove 99% of infectious-sized aerosol in NIOSH's laboratory testing. NIOSH provides detailed instructions and videos on their website. The devices are cost-effective and can be stored in normal times. They are a highly feasible and evidence-based engineering control that any hospital or critical access hospital can employ, and they should be required to plan for it. OSHA should require evidence for surge capacity plans. AFT developed webinars on these temporary isolation controls and on elastomeric respirators. We will submit the materials into the docket for your consideration. Thank you for this opportunity.
Right, and thank you. We will now move to the questioning portion for this panel, and we'll begin with the OSHA panel. I'll ask, in light of the information about Mr. Calzia, if any questions that are directed towards him go first.
Thank you, Your Honor. This is Jessica Schifano from OSHA. I do have one question for Mr. Calzia. Do you have some experience that you could discuss with us today about variation between employers, as a contract employee, in implementing their policies for worker protection, like paid sick leave, training, access to PPE, or others?
I think we, and I think we could see this trend across the country, but we did see variation, and it could, I think, be often delineated by the financial wealth of the institution or the environment. So our larger medical centers were able to provide better safety for their employees. And if you start to go down or start to look at the entire healthcare spectrum, the more vulnerable populations, so our long-term care facilities and congregate living areas, the employees are often more marginalized, as are the patients and the clients who are living there. And we saw that those were some of the biggest struggles. And then that impacts O&A members who don't typically work in those areas, but we see that then increase infection rates. The Oregon Health Authority did track outbreaks in these areas, and we can see that then impacts the hospitals because we see increases in COVID-19 patients going there. So I think that's where we could see some of those bigger disparities where, and I think we saw this across the country, well-funded healthcare systems were able to provide a little bit better protection, but they also then have that within their own institutions, the conflict of trying to look at the procedures and the areas that are going to make money, like your operating rooms, non-urgent cases that you want to get done, versus some of the other areas like your ICUs that might not make as much.
Thank you.
Answered it.
Thank you. Any differences you've experienced or others have experienced between rural and urban healthcare facilities?
Yeah, we really saw that because in Oregon, the rural facilities got hit a lot harder, a lot sooner. They had lower rates of compliance with masking, social distancing, and vaccination rates. And they also have the critical access hospitals are less funded and had more difficulty obtaining PPE. And they also are older institutions often, so they don't have the air handling capabilities that some of our newer hospitals had. And so what we saw there were our members were put in really extreme situations in these COVID units where they were having to double up on inpatient rooms where normally you might only have one patient. They didn't have negative pressure rooms or any kind of air handling. And then they were reusing PPE. So we also saw the rates of infection of our own members go up, but we saw that their working conditions really, they declined rapidly during the surges.
Do you think it's possible for the healthcare settings in rural areas to implement all of these controls and they just weren't doing it? Or is there a concern that they're not able to do it for any number of reasons?
I think they are able to, and I think we still have this kind of fragmented healthcare system, and so even in light of going in now 2.5 years into a pandemic, it's still, our healthcare system is often based on competition, and so we don't have the same sharing of knowledge and resources between, say, the academic centers down to those rural agencies, and they don't have the same access to the knowledge base and the technology. So if we had more regulation with more directives so that sharing is mandated, and that we get to a point where I think they have the capability to do it. It's a matter of being compelled to do it is I think a big factor.
Thank you, Mr. Calzia. I have one more question that your testimony touched on a bit, but maybe for the whole panel. So a number of the panel members mentioned the differences that they saw between what employers' approach to worker protection was while the ETS is in effect, and after it was withdrawn. So do any of you have additional specific examples of controls or practices that employers no longer implemented after the ETS was withdrawn? And this can be part of your response to the question today, as well as in follow-up materials that you would submit during the post-hearing comment period.
I would just say that from my discussions with Sherry, Cheryl, Matt, it's very apparent that hospitals have stopped isolation policies. COVID patients are mixed in the general population. They're sitting in the waiting room with other patients. Sherry mentioned that they're sometimes stored in hallways with a curtain around them. That's inexcusable. It's just mind-boggling.
Thank you for that. And we would welcome any additional examples that you have. I did have a follow-up question on the point of COVID patients and other non-patients that are permitted in the facilities who have or suspected to have COVID. And Ms. Dayton's testimony did touch on the fact that COVID wards are being dismantled. During this time where this is happening, how are healthcare workers being notified about what patients have COVID or are suspected of having COVID?
I can speak to this. Being an emergency room nurse, we don't always get the COVID result back while they're still in the emergency room. Matter of fact, frequently we do not. The results doesn't come back until they're up on the floors. And I can tell you that we do not get notified. We do not. So if they come in as a patient on an investigation, meaning they have, COVID symptoms, then we are using our N95s and all of that. But if they come in as like a cellulitis or something like that, and we swab them and they happen to come back positive COVID once they get up on the floor because we did their admission swab, we do not get notified of that. That's not happening.
Thank you.
And when we had, during the height of COVID, we were screening anybody who came into the hospital, even for like outpatient procedures. And now they have totally done away with that. So as we know, at least in my experience in the emergency room, the Omicron variant has like sometimes very mild symptoms, which could be like basically, here we are in spring in New England, and it really could kind of be like allergy-like symptoms, like nasal congestion, sore throat from like maybe postnasal drip type stuff. And people are saying, oh, it's I have an allergy. Like I can still have surgery. I'm not sick. I'm just having an allergy problem. I can't. And a lot of those people really have COVID, especially if they're vaccinated, they may only have that, but that doesn't mean they can't spread it or give it. And they are not testing any outpatient procedures anymore.
And are all of the things that you described typical, and maybe some of the other panel members can describe their experiences of, both the notification piece as well as the screening piece of admitted patients and outpatient procedure patients?
I mean, I'll let the other panel speak for their states, but because I am divisional vice president for healthcare in Connecticut, I do get an opportunity to talk to a lot of the local union presidents across the state. And it is typical in Connecticut across the different the bigger healthcare organizations, Harvard Healthcare, Yale, and Nuvance and stuff that are doing this now. I can't speak for other states, but I can tell you that it's typical in Connecticut.
Thank you.
Hi, this is Cheryl from New Jersey. I can tell you what New Jersey's doing. And the thing that I guess stands out to me the most is we're all doing it different. And that's what has really kind of blown my mind to this, that we all can't get on the same page and find one right way to do it. So in my facility, unvaccinated patients, we still test, and vaccinated patients don't get tested. And that makes zero sense because we all know that unvaccinated and vaccinated can get, especially the new strains that are coming out. And just down the road in another facility, we're hearing that they do test all patients. So we get very envious of what they're doing. We try to tell our employer, hey, look what they're doing. Shouldn't you be doing that too? Because, we're only 10 miles down the road and, it falls on deaf ears. So, like I said, the biggest thing that sticks out to me the most is we should find the way, a good way to do this. And I think, that a standard would solve this problem.
I can totally concur with that. As far as like visitor policies across the state of Connecticut, they are like so different. Like, New Vance Danbury Hospital is requiring people who are coming in to visit to show their vaccination card or a test within like 72 hours of visitation. And then my hospital, like COVID positive people can come in if they wear their mask, and and they'll put N95s on these people to go into people who we know are positive COVID and they're not fit tested. And so it's that the visitation policy is totally different across the state of Connecticut. No one's doing it the same, which is confusing for people that are visiting people in the hospital.
Mm-hmm.
I would agree. There's just a lot of variability, differences of interpretation going on in facilities. And I wanted to just circle back on something you had asked around the expiration of the ETS and point out that Oregon has a COVID standard. And I think one thing that I heard today that was really shocking and concerning was when Ms. Dayton mentioned they're still reusing respirators. So there's no shortage anymore. So that is a choice that is not being, that's a very concerning choice that the employer is making. And that is not occurring here anymore. And I think it's because we do have that standard in place that prevents that. And so I think we can see there's a reason that we need this, right? Because employers are going to take it too far, and there's no more shortage of respirators. There's absolutely no reason that Ms. Dayton's employer can say that you have to reuse or extend use of a respirator. That's just unacceptable. And with that, I have to go, and I really appreciate the time today. Thank you very much.
Thank you so much for taking the time to share your experience with us. We appreciate it. I'd like to get back to some questions about screening as well. And I just want to clarify the position of AFT, if there is one, about what your recommendations are for screening both of patients and visitors and non-employees, as well as employee screening. You mentioned surveillance screening. Is that for everyone? Is it for people with symptoms? Is it for people with exposure? For employees, how often is that? And again, is it based on symptoms, exposure, or just a frequency that would be recommended to ensure that COVID positive employees are identified quickly and removed from the workplace?
We recommend universal testing, and I think that weekly testing is probably best for staff. Dr. Harrison spoke a bit yesterday about protocols that have been done at UCSF, and I think there could be an argument made for semi-weekly or twice a week. OSHA will need to make a determination on that. I think that hospitals can do testing very, very inexpensively. I mean, obviously, when you're talking about a large population of workers, the cost will add up. However, they have the capacity to do this, and I think that there will be an economy of scale. You know, an individual goes to CVS and buys their own antigen test off the shelf, is paying $20, $25, but hospitals can do this a lot less expensively, including pooled testing. For patients, I think it's really incredible because of the high rate of infection from people who are pre-symptomatic or asymptomatic, that any patient coming in, whether they are an inpatient admitted, you know, through the emergency department or for a scheduled procedure, or if they are coming in for an outpatient procedure, or if they're in an ambulatory care setting, things like colonoscopies, same-day surgeries, those are high-risk settings. And I think that all of those patients should be tested.
Can you elaborate a little bit more about the settings outside of the hospital or for admitted or outpatient procedures? Like for ambulatory care, any patient coming in, would you recommend screening and home care every time someone's going into the home, having everyone in the home screened, the patient screened? Any recommendations on those?
I think that it would be admirable if OSHA would require family members or visitors in home health settings, because we've had a lot of infections. We represent in New York State, and Sean represents a lot of home health staff who, you know, were denied face masks for a while and are, I believe, still denied respirators. I don't know if Sean, if you'd like to speak to that part.
There was we had significant difficulties getting our members face mask, not face masks, but respirators, N95s. It took us a very long time, a lot of work, a lot of hard work, a lot of advocating to convince the agencies that these members in these congregate settings deserve to have respirators also. Again, a lot of CDC guidance didn't really advocate for these workers to have a respiratory protection. And often the agencies would fall back on the CDC guidance, just completely ignoring the fact that their members are literally face to face with their clients, providing services to these clients, and putting them at a significant risk of exposure. But the CDC guidance documents didn't address that, so they were using that as an excuse not to provide, protection.
I can actually speak to this a little bit also. At the beginning of the pandemic, from March when it started till probably around that summer, August 2020, I was working for a visiting nurse association here in Connecticut. And one of the reasons I left that job and went full-time back into the emergency room, I was always per diem in the emergency room at that point, but was because of the lack of protection of PPE. I was spending probably $150 a month on buying my own KN95s because I could not get an N95. I think it's important to remember when you're a home health nurse, you're going into people's homes. One, you don't know what the ventilation is going to be like. It's not like it's their home. So, it's apartment complexes sometimes where there's not good ventilation. There's, maybe you can't open the windows. It's like, and people at that time, in the shutdown were home. So there was like kids running around and aunts and uncles and all these people like always around, and you can't police a mask in somebody else's home. So it was very difficult. That's why I left visiting nursing. I could not get the PPE and feel safe at that job.
Just to follow up on that, for Ms. Dayton or anyone else on the panel, is it your position or suggestion that every home health care provider needs to be in a respirator at all times? Does it matter whether you're providing services somewhere else in the house or if you're just providing direct care to the patient?
I feel like there could be some standards on that as far as policies and procedures. Like, we tried to implement different things like, the family members, if they weren't, willing to wear a mask or anything, that they, had to be in another room with the door shut. If I'm in the room with this patient, but I think that the safest practice would be to always wear a N95 respirator, because you never know with the asymptomatic spread and with the, particles, there's been studies that said that particles stay in that air for 3 hours. Like, they're walking around that home forever. And if it's like all shut up and then you walk in and you have a surgical mask on, you're really not protected.
Thank you, Ms. Dayton. I'm going to turn it over to my.
This is
Okay,
Kelly.
yes.
We'll clarify our position on all these
Okay.
questions in our post-hearing submission. Thank you.
That would be very helpful. Thank you.
Thank you.
I'm going to turn it over to my colleague, Robert Stone, to ask a couple questions.
My video is not starting.
Mr. Stone, I would just recommend that you go. We can hear you fine. So if you
Okay, that's fine.
go ahead.
All right, thank you. My name is Robert Stone. I'm an economist at OSHA. And I want to thank everyone on the panel for testifying today. My question really is geared toward Kelly Nedrow, or anyone else actually on the panel. It has to do with information we've been receiving on labor shortages throughout this pandemic, but with a focus on healthcare settings. And I'm curious to know what your experience has been with the effect of the ETS on these shortages, whether in fact the ETS has helped keep your membership and other workers on the job. Thank you.
That's a great question, Mr. Stone. Thank you for the question. I will be completely honest with you and say that there are so many factors at play with the current staffing shortages, and we honestly have not made the connection between the ETS, but we will do that and address that in our post-hearing submission.
Thank you.
Yes.
Anyone else?
I'll add a little bit. This is Cheryl from New Jersey. I have to say, as far as workplace safety, when we were in negotiations between Surge 1 and Surge 2, the highest thing up on the list, even before wages, was workplace safety. And that's how we got our pandemic preparedness committee, because our employer knew that our members wanted this. And I think that is very important to keep nurses at the bedside. It's for them to know that they are safe and that their employer has their back when it comes to their safety. So to have a voice in that is going to keep nurses at the bedside, and to have a standard to keep our employers accountable for this is also going to keep nurses at the bedside. Many have left because they do not feel safe, and they feel that our government agencies do not have their back.
Thank you. Anyone else?
I can add a little bit to that too. I read an article recently saying that 100,000 healthcare professionals, nurses, left the bedside in 2021. And in Connecticut, I know there's a 25% people who can work as a nurse who are not working as a nurse currently in Connecticut. We were in negotiations of October 2020, and so I was in constant communication with the nurses in my hospital on what their issues were. We had done surveys, and one of the big survey questions that came back answered was not feeling safe at the workplace. So though I don't have exact numbers about what the ETS did. I can, as a nurse myself working in emergency department and someone who has access to nurses on a regular basis, and talking to them, I know safety is a huge issue right now. Anybody at the beginning of the pandemic who could retire, retired. Anybody who could go per diem went per diem, just trying to negate the exposure as much as possible to their family. Like one of the other panelists said, you know, I isolated away from my family for a whole month at the beginning of the pandemic until it got too depressing. And I'm not, as an emergency room nurse, I don't cry. We don't have that pleasure of being able to give into our emotions on a regular basis. Because, you know, you're taking care of somebody, you're doing CPR on that dies, and then you have to go and take someone who's mad at you because you didn't get them ice chips for a sore throat. So you have to just go in and out of these situations and keep your emotions in check. There were many, many days that I went home and cried in the shower afterwards. So I can tell you safety was a huge issue. We were getting undressed in our garages, and it was scary to go around your family. So again, like I said at the end of my thing, like I don't want to ever go back there. And I know from talking to healthcare professionals, none of us ever want to go back there. And I feel like we were unprepared, and having a standard in place. We know there are going to be these respiratory pandemics. I think having a standard in place would just put healthcare workers at ease to know that there's something there in place that is holding them accountable, so we don't ever go back to that.
Thank you, Sherry. I wonder, is it possible that you or others on the panel could submit that survey or any other evidence pertinent to this question?
I could try to find the results of that survey. It was October 20. Well, actually, it was probably before that. It was a little bit before that when we screened our. But I can try to get those results.
Thank you. And again, if anyone else has any other evidence that relevant to basically easing the healthcare workers' mind as a result of the ETS or helping them stay on the job, we'd appreciate anything you could contribute. Thank you very much.
Are there any further questions from the OSHA panel?
Just one follow-up question, Your Honor.
Okay.
We have heard that staff might leave if they think there are too many regulations. Can folks on the panel describe their experience and knowledge with that?
I'm gonna be 100% honest with you. When I read that, it was infuriating to me. I don't understand it. I don't know that anyone who, all I can think of is whoever wrote that has never walked into a COVID room, because I talk to nurses all the time that are literally going through PTSD. A lot of my CCU nurses, we have had almost a total turnover in our CCU, and currently are being pretty much staffed by travelers in our CCU right now, of healthcare workers who were just devastated because of the safety concerns and what they have witnessed. So I can't imagine in what world anyone could say making these healthcare workers feel safe would be what would make them leave or get upset. Because my phone blows up on a constant basis with my members, and I know my other local union presidents are constantly bombarded with their members texting them and asking them to advocate for safer workplaces. So my mind was blown when I read that was suggested to be an issue.
This is Kelly Nedrow. I would just add that every single thing that happens in patient care is driven by regulations. The things that they document, the frequency of documentation, the way they order and administer medication, everything is driven by regulation. Granted, most of that regulatory process is geared toward reimbursement and not worker safety, but there's not a single thing that happens in clinical care that is not driven by regulation.
Thank you so much.
I would also like to add, I said, this is Cheryl, I said earlier about all being on the same page. I think a lot of what happened during the pandemic was the confusion around the ever-changing rules. You know, if healthcare workers had a set of rules that everyone knew and everyone followed and every facility was doing the same, then there would be no confusion. We would go to work and get the job done. And that's what we're there to do, and we would be safe doing it. So I'm not sure what too many regulations to keep someone safe would look like, but you know, I agree with Sherry on her comments that I'm pretty confused by that, honestly.
Thank you so much, Ms. Mount. Thank you so much to the whole panel for sharing your experiences with us today. We appreciate it, and no further questions from OSHA, Your Honor.
All right, thank you. Now we have two questions from attendees, and I will first ask for Mr. Allen to be unmuted. Theo Allen, I'll just, to all attendee questioners, please remember that this is a time to question, not testify. I will say that at the beginning of each one. So Mr. Allen may ask his question.
Thank you, Your Honor. And I'd just like to ask if you could help make sure people speak into the microphone because I've been having some problems. And my question is a follow-up on the previous one. Specifically, does conflicting guidance with the CDC from OSHA, would that cause you or any of your colleagues anxiety or stress?
If any panel member would like to take that, they may or may reserve.
Yeah, I could say something about that. So I think the CDC guidelines were definitely anxiety producing, and it continued to be anxiety producing up until the last guidelines, because one, they changed so fast. But in our eyes, the virus is the virus, and it's been the same virus, even though it's like has variants. So like it's confusing because it seems like it's based on supply chain, it's based on maybe political stuff, it's based on staffing shortages, not based on what's evidence-based to protect workers from an infectious disease. So yes, it definitely has caused healthcare professionals anxiety because it doesn't seem like it's based on the science of keeping people from spreading this infection. It seems like it's based on a lot of different things, and that's why it changes.
All right, thank you. We will, if any other panel members wish to respond, because we're running a little light on time, I'd ask that you do it in your closing briefs. Next, we have questioner Rebecca Reindell, I believe is how we pronounce it, if she could be promoted to ask her question.
You have been promoted.
All right, you may ask your question. Rebecca Reindell?
Can you hear me?
If that's Rebecca Reindell, yes.
Yes, sorry, I was talking, but I guess it wasn't coming through. Rebecca Reindell, my question is for anyone on the panel who would like to answer it. You talked a little bit about COVID patients being mixed with non-COVID patients or unknown patient status. And I'm wondering if you can elaborate a little bit more on if you can isolate COVID patients in emergency rooms and other areas of the facilities. And it sounds like since they stopped that practice, I'm wondering if you can better describe how COVID patients can be isolated and any ventilation practices that are helpful in doing that as well. Thank you.
I can speak to the emergency department since that's where I work, but for a period of time, we did have two different waiting rooms. We had, I mean, it was the same room, but they were separated by distance. So one side of the waiting room was COVID symptoms, and the sick waiting room, and the other one was like non-sick, like if you came in for a sprained ankle or if you came in for stitches or something like that, like something we knew was not COVID related. That doesn't happen anymore. We never, during the ETS put patients in the hallway. We never just had them with a curtain on the hallway. If they had COVID symptoms, they had to be in a room at least that we can shut the door. We never had the capacity to put all of them in negative pressure rooms, but and at one point they did try to have some air scrubbers and wait 30 minutes between that room, then get it cleaned and all that stuff, but all of that has pretty much gone out the window. Like currently, if we do have a patient in a room and they have COVID symptoms and whether we rule them out or not, they get discharged or they get admitted, housekeeping goes immediately in there and cleans the room, and then we just put another patient in there. There's no ventilation or air quality procedures at all at this time. I don't know if that answered it completely, but that's what's going on.
I'd just like to follow up with that on, just getting back to some of the congregate settings that we have. For example, we have group homes, and you may have an individual who has COVID in their group home, and they're not sick enough to be hospitalized, but they still have COVID. There's really no particular special ventilation for those type of environments. These workers and these patients are still not even, I won't even say patients. You have mental health facilities, you have the correctional facilities. So you have these facilities where the workers and the positive cases are not really separated by any, there's no real special ventilation that's protecting the workers. So that is a significant issue.
Thank you for the question and for the panelists' answers. We have one last questioner, M.K. Fletcher. Could M.K. Fletcher be promoted, please?
They have been promoted.
All right, M.K. Fletcher, please come on camera if you're haven't so far, and please ask your question.
Hi, thank you so much. And thank you everyone for testifying today. I'm MK Fletcher with the AFL-CIO, and my question is for anyone who wants to answer. The ETS had excluded non-hospital ambulatory settings if patients and visitors were screened for symptoms. And the agency has asked for comment on other areas that could be excluded from a standard if those areas maybe have fully vaccinated staff or patients were screened. Can you speak to how effective the symptomatic screening and other criteria like vaccination status has been in your experiences at keeping COVID out of the facility and preventing further infections?
Okay, well, I would like to take this opportunity to just say that screening, especially for symptoms, is not effective, right? We know that a significant number of people are asymptomatic. As somebody mentioned earlier, I believe mentioned earlier, you have people who have mild symptoms who may think they have, the cold or the allergies or something of that nature. We have facilities where screening is done, but it's just screening for symptoms. We still have instances where we have workers who or locations where the employees the inmates or the clients have no exposure except through the workers or visitors, and we still get outbreaks in these facilities. So screening for just symptoms alone doesn't work.
I could speak a little bit to this. This is Cheryl from New Jersey. Like I said earlier, some facilities do screening well and others don't. At my facility, they rely on you just to be honest And when you walk into your workstation, there's an attestation that you click, I'm well enough to work today. So there was really no screening done. Other facilities that I've worked in, there's people at the employee entrance with a thermometer, taking your temperature, handing out masks. So, you know, some do it well, some don't.
I like to add just a couple comments on that. I can't say much about the outpatient screening per se, because I don't have much access to understanding of that. But as far as I guess I do some as far as like infusion centers and stuff. I do have members there that I've spoken to. So for example, like they take our temperature with the non-touch thing on your hand, forehead, and it'll be like 95, and they'll be like, oh, you're fine to go into work. And if my temper is really 95, I'd probably be a patient in CCU, and the next person comes in and their temp is 98 with the same thermometer. Does that mean they have a fever? Because my temp is probably around 98.6 because I don't have a fever, and then they have a 98. Does that really mean that they have like 101? You know, because, and I have done this, like patients have come in and they have that infrared thing they stand in front of after coming outside, and their temp will be like 96, and then I'll take them back and they'll be 102. Like, you know, so I don't think that is very adequate screening. I just don't think that, and I've had patients who've had COVID who've never had a fever, so that's not, you know, adequate. The other thing is that, you know, we know that the honor system doesn't work for things. You know, when stores were saying, you know, you don't have to wear a mask if you're vaccinated, people are lying. They have their own beliefs and things, and you know, and they won't wear it. And like she was saying, as far as the testing for coming into work, my attesting that I'm well enough to work that day is literally if I swipe my badge to get into the hospital. So that means that I don't have a fever and I don't have any COVID symptoms, and so there's nobody's really regulating that anymore. And different places did it better than others at the worst of it.
Any further answers from the panel? All right. That is our last questioner. So I'd like to take the opportunity to thank all of the panelists for testifying here today, and thank you to the questioners. Right, the next on our schedule is the Communications Workers of America. If they could be promoted, please.
They have been promoted.
All right, we have three speakers during this segment. I'd ask the speakers to please keep track of your time and testify for you have approximately 10 minutes to testify. And we will begin with Mickey Siegel de Hernandez.
Thank you, Judge. Good morning, and thank you for this opportunity to testify. My name is Mickey Siegel de Hernandez, and I am the CWA's National Deputy Director for Occupational Safety and Health. I have worked for CWA for over 20 years and have been in the field of occupational safety and health for over 30 years. For our panel, I'm going to begin with an overview to cover what we need OSHA to do and some of the serious problems that we are seeing currently. I'll be followed by two of our CWA healthcare workers, Robert Andrusko and Frank Juergens, and I will give them a more proper introduction when I turn the floor over to them. First, CWA represents workers in many, many different industries and sectors, and healthcare is one of those sectors. In our healthcare sector, we represent over 50,000 members in healthcare settings in the private sector and the public sector across the country, with the majority of our healthcare members located in New York and New Jersey. Our members work in a range of healthcare settings, both large and small, including hospitals, nursing homes, assisted living facilities, outpatient settings, laboratories, and home healthcare. And our members include registered nurses, hold scientific and professional technical titles, are certified nursing assistants, housekeeping, and environmental service workers. There is no question that we need OSHA to promulgate a comprehensive standard for COVID-19 in healthcare settings. There is a need for protection for all workers as well, but today I will be focusing on healthcare only. Let me begin by saying that there is still a significant need for workplace protections and significant risk. The pandemic is not over, it is dynamic as, as it always has been, and COVID cases are once again on the rise as measures to prevent the spread are being lifted within healthcare settings and without. OSHA's permanent standard for COVID-19 in healthcare settings must fully recognize aerosol transmission and incorporate the protections that are needed to protect against aerosol transmission, must focus on a full range of COVID controls using the hierarchy of controls, must correct the weaknesses of the emergency temporary standard, and must ensure that all workers in healthcare are protected. So related to all of these items is OSHA's question posed in the notice about whether to incorporate or align with CDC guidelines. Much has already been discussed about this during the hearing. Our answer is no, it should not. OSHA should not incorporate CDC guidance about workplace protections into an OSHA standard. OSHA would be abandoning healthcare workers if they did. The CDC has expertise in many areas, but not about workplace health and safety protections, or about workers and the jobs they do, or the ways in which workers may be at risk. OSHA does have this expertise, and OSHA must use that expertise to develop a strong standard to protect workers in healthcare facilities and settings. CDC guidance is not the gold standard for healthcare or any other worker or workplace protections, and never, ever has been. That's a falsehood. It is the opposite. CDC guidance about healthcare worker protections is not evidence-based. Instead, the CDC has steadfastly clung to the archaic droplet theory as the primary mode of infectious disease transmission, despite the enormous and ever-growing body of scientific evidence about aerosol transmission. This is akin to the flat earth theory, and thank goodness the CDC does not provide guidance about physics. Much of the CDC's bad guidance stems from this false and disproven premise that transmission is primarily caused by droplets of a certain size expelled by a person, then fall out of the air within 6 feet. This has had tremendously negative implication for workers and the public for decades, but never as evident or with such deadly consequences as has occurred during the current pandemic. While CDC has recently recognized aerosol transmission of SARS-CoV-2, they have not updated their guidance to reflect the protocols and controls that are necessary to actually protect against aerosol transmission. We in the union have had to fight against every CDC guideline that has come out throughout the pandemic and try to negotiate with employers for more protective measures. But when the CDC makes a recommendation that is harmful or wrong or such a low bar of protection, it makes any negotiation for real protections that much more difficult and sometimes impossible. Our union has had COVID work-related preventable fatalities where the employer had been following CDC guidelines. This has impacted the outcomes of federal and state OSHA investigations where the employers were not cited because of a lack of a comprehensive OSHA standard, and instead the use of CDC guidelines as a reference point. Here are some ways the CDC guidance, which has ignored aerosol transmission, has undoubtedly led to preventable worker illnesses, hospitalizations, and death. At the beginning of the pandemic, the CDC did not recommend respirators of any kind in healthcare or other workplaces because of a shortage of N95s, which was real, not based on science. CDC misguidance included recommendations to wear bandanas or homemade masks in healthcare, where the risks were the highest. There were instructions for how to make your own mask. This was unimaginable to see on the CDC's website as healthcare workers were facing a growing crisis at work, were getting sick, and started dying. The CDC has consistently promoted the use of surgical masks, which are not respirators, as ample protection in healthcare when respirators are warranted. Surgical masks do not protect against aerosol infectious diseases like COVID-19. CDC has also recommended for decades the use of N95s only by healthcare workers who perform aerosol generating procedures, presumably because that is the only time the CDC believes the virus could get into the air. This is wrong about transmission, and it is a myopic view of the range of employees with different titles performing different job tasks who are at risk of exposure to COVID in a healthcare setting. I just want to note that we have had similar fights about protections with the CDC during other pandemics, including the first SARS pandemic and H1N1. In March 2020, the CDC issued dangerous misguidance for healthcare, recommending that asymptomatic workers who have had close contact and a known exposure to a person with suspected or confirmed COVID-19 be allowed to work instead of being quarantined. This was followed by similar misguidance in April 2020, making the same recommendations for critical infrastructure workers. These two misguidance documents put workers, their families, and the public at risk. In May 2021, the CDC issued misguidance regarding different masking recommendations for vaccinated people than for unvaccinated people. This was an attempt to encourage unvaccinated individuals to get vaccinated. Unfortunately, OSHA had to follow suit and apply these recommendations for the workplace. Outbreaks caused by breakthrough infections in vaccinated people, all predictable, forced the CDC to reverse this misguidance. Current CDC misguidance for healthcare workers whose vaccination status is up to date with a known SARS-CoV-2 exposure who are asymptomatic have no work restrictions. Under contingency planning, a healthcare worker whose vaccination status is up to date with COVID that is asymptomatic or a mild to moderate illness with improving symptoms must isolate for 5 days. And that person does not need a negative test to return to work, even though the CDC does recognize they may still be infectious. And then there are other many commonly accepted elements of various CDC guidance documents that do not protect against airborne transmission and should not be incorporated into an OSHA standard, including guidance to wear a mask within 6 feet of someone, which implies it's okay not to be protected in an indoor space beyond 6 feet. Wear a face shield if a person can't wear a mask. A face shield open on all sides does not protect against airborne transmission. Use of ineffective barriers that do not protect against airborne transmission. The definition of a close contact as within 6 feet only for 15 minutes has failed to recognize countless exposures of all workers who have been exposed in indoor setting. And lumping of all kinds of face coverings into a broad category and oversimplifying the differences. In the CDC's choosing a mask or respirator for different situations, N95s are referred to as special filtering masks, they're respirators, and well-fitting disposable surgical masks and KN95s are lumped together as types of masks offering more protection. Surgical masks, again, are not respirators. KN95s are, although not authorized by NIOSH. These are but a few examples that OSHA should not incorporate into any standard that they finalize for healthcare workers. OSHA has also asked about including a safe harbor provision in the standard. This term is an objectionable euphemism for an unsafe blanket exemption from following the requirements of an OSHA COVID-19 standard for healthcare, which would then allow an employer to follow unsafe CDC guidance instead. The unsafe exemption provision has no place in this or any other OSHA standards. Let me turn to some other concerns. Although SARS-CoV-2 is a novel coronavirus, workplace protections and controls for aerosol infectious diseases are not. In developing a COVID-19 standard for healthcare, OSHA must not only accept the science of aerosol transmission, OSHA must see everything through the lens of airborne transmission as the primary mode of transmission and must enact workplace controls and protections accordingly. OSHA should follow the hierarchy of controls, of course, with an emphasis on controls, protocols, and procedures that can limit or prevent the introduction of COVID into healthcare settings, the use of engineering controls such as various ventilation measures to reduce the risk of airborne spread, and respiratory protection for workers. No one form of protection will completely eliminate the risk of COVID in healthcare settings. Each type of protection or control has limitations and benefits. That is why protection should be layered, but controls are also interrelated. One type of control or a lack of a control can affect the use or the need to ramp up other controls. For example, if there isn't testing to determine whether employees or patients or visitors may have COVID, that greatly increases the need for ventilation controls and respiratory protection. Controls are also not all equal in the degree to which they reduce risk. This is stating the obvious, but what has happened throughout the pandemic is that controls have been presented and selected by employers like a laundry list. For example, we upgraded to a MERV 13 filter, which will not prevent transmission. Check. We have hand sanitizer. Check, and so on. This has enabled employers to pick measures that are easier to implement or less expensive to implement, rather than those that offer the most protection. In a standard, if OSHA presents options, OSHA must also make clear the priorities for controls and how one choice affects another. There will need to be a great deal of practical guidance in this regard to support the requirements and options that may be in the standard. In the ETS, OSHA referred to suspected or confirmed cases as a trigger for certain protections. In a final COVID-19 standard, OSHA must add a category of unknown COVID status. The unknown COVID status of employees, patients, and visitors increases the risk of the spread of COVID throughout the healthcare setting, and that is what we are seeing much more of now. If you don't know, you must protect. For workers, there is a lack of surveillance testing. There is a lack of employer contact tracing when an employee does become sick. And there is a lack of exposure notification to workers when a coworker they may have worked with is positive, or when a worker may have been exposed to a COVID positive patient. Quarantining after an exposure is rare. In some cases, it has never been provided because employers want people at work at all costs. Let me say that no staffing shortage ever has been solved by letting workers get sick or be at work sick. As one of our ER nurses told me last week, when she raised issues with her employer about patients in the emergency department, knowing that some had COVID symptoms, not knowing the status of others, all mixed together, and sometimes on beds in the hallway, she was told by her manager, "You work in the emergency department. You should expect to be exposed." Patients entering a healthcare facility, whether COVID related or for many other reasons, are not being tested for COVID beforehand. They are being sent throughout the facility for procedures or workups without being tested. And in the event they are tested, they are being tested at the end of their visit after potentially spreading COVID. Patients who are going to be admitted are tested, but there is little cohorting now of COVID patients. If you don't test for COVID, patients, visitors, employees, then you must protect workers because of the potential that someone could be infected. You can't turn a blind eye to this risk. This is why, until COVID-19 infection can be ruled out, an unknown COVID status must be treated as a potential COVID case, and workplace protections must be enacted accordingly. OSHA must include COVID testing requirements in a permanent standard. The screening measures that have been in the ETS were completely insufficient. And let me say that the testing should include PCR testing for workers and for patients. Lastly, a permanent OSHA COVID-19 standard must protect all workers in all types of healthcare settings and facilities. There should not be exceptions to this. Of course, nurses providing direct care are at risk and need protection. So do others in healthcare settings who do not provide direct care. Risk can span a spectrum from extremely high risk to comparatively less risk, but rarely, if ever, no risk. What's the cutoff? There isn't any in terms of needed worker and workplace protections, although there may be differences in certain protocols. The point is, all workers in healthcare settings have the potential for exposure, and employers must be required to provide protections and ensure a safe workplace. That has not happened and won't happen until there is an enforceable standard. It still is hard to believe that there isn't yet an OSHA COVID-19 standard to protect workers in healthcare, and we are very happy that that is the direction that OSHA is moving in. OSHA must right that wrong. We urge OSHA to act without any more delay to promulgate a comprehensive standard for COVID-19 to protect workers in healthcare facilities. So with all of that said, thank you. And let me just say a few words about our CWA panelists. First and foremost, they are frontline healthcare workers. Both of them have been through the worst of the pandemic from the beginning, when there wasn't PPE, through surges to the present time. Each panelist also plays a role as part of their local union leadership, CWA Local 1168. So they have knowledge and responsibilities that go beyond their specific work locations and jobs. They work with the membership and with management at all levels, regularly, both informally and through formal bargaining. They know what has worked and what has not, what has backslided in terms of protections, and what is needed now to protect healthcare workers. So with that, I would like to turn this over to Frank Juergens.
Right, Mr. Juergens, you may begin.
Thank you. Thank you, everyone. Thank you, Judge Bland, for presiding, and thank you, OSHA, for giving me the opportunity to testify. My name is Frank Juergens. I'm a senior phlebotomist at Kaleida Health Laboratories in Buffalo, as well as a chief steward at my local CWA 1168. I represent all the technical employees. The technical employees, for example, consist of workers in X-ray, surgical, GI, laboratory processors, histology, couriers, and phlebotomy. I'm going to speak in respect to the laboratory part of it. I work in a patient care center, also will be referred to as a PSC. My location is an outpatient lab that is open to the public to get labs done for their doctor, such as yearly, pre-surgical, medication lab levels. I have 2 draw rooms, and one draw room is right in front of the waiting room. The phlebotomist in that room slides the glass and calls patients in. My waiting room is small. Normally I have 5 to 6 chairs, when social distancing 3 to 4. Some of the issues we had to deal with from the start of COVID to present have been extreme. There has been a lack of information or direction to the problems that have gone on. The COVID protocols that might be followed in the hospital are not followed in the PSC. The issues I'm going to talk about and the issues that are ongoing in my location are also happening in all other outpatient settings that have created unsafe work conditions for the technical employees who work and also the patients. When COVID hit, policies were put in place that were in a hospital setting. For example, the hospital had screening and temperature taking areas before you got into the hospital. The phlebotomists at the PSCs asked the same thing for the same thing and were told they can't do temperatures because they had to be trained to use the temperature gun. When we finally got a screening questionnaire, it was only to be filled out when the patient entered the PSC and after they're waited to be seen. I had an instance where I had a patient come into my PSC, sign the log, sat down, waited to be seen. When the patient was called, she said she was here for a COVID test. I said, we do not do COVID tests. Are you actively sick? She said, yes. She explained her doctor told her to come to this location. Every patient in that waiting room was upset now because we have a potential positive COVID patient in the room. This happened often. We called our lab manager and she said she talked to the doctor's office and didn't know what else to do. As far as PPE, we weren't informed how we could get N95 masks. We were not instructed to get fitted for the N95 masks until we had to ask and ask and ask and ask. When a phlebotomist draws blood, we are 6 inches away from a patient's mouth. I've received no direction from my employer how to deal with the amount of patients I get when my waiting room is so small and I can only have 4 people sitting in the waiting room at a time. I may see 30 patients a day. We do not accept appointments, so I never know how many patients will show up and when. I also do not know their COVID status of the patients coming in. I asked for some direction, and all I got was a sign saying that we do not do COVID testing. No real direction was given, like screening at the door. When we asked, it was always no. We still have not been given direction on whether patients still need to wear masks or not at this point. I asked patients to put a mask on and provide them if they don't have them. Some of the patients do not have the proper paperwork for their labs, and they can spend a great amount of time in my room. 90% of all PSC employees obtained COVID. Our nursing home phlebotomists were extremely negatively impacted. They had no PPE because it was rarely supplied by the nursing home, even though it was supposed to. The phlebotomists were not being told they were drawing COVID positive patients, which they should have been. There was no guidance from management except use universal precautions, which won't prevent you from being exposed to COVID because it's airborne. We also had COVID positive employees who worked in the nursing home come back to work and still are testing positive. They were not allowed to go to the nursing home because of the strict rules in the nursing home setting. Instead, they were told, these COVID positive employees were told to go work at a PSC. And they, again, are 6 inches away when drawing patients' blood. When we brought these concerns to management, we were told to follow CDC guidelines. 97% of our nursing home phlebotomists got COVID. I believe many of these illnesses were work-related. I had COVID, and I believe my case was definitely work-related. No one in my family had COVID, and I brought it home. My daughter, who works in an independent living facility, gets a PCR test weekly. At my workplace, we did not get regular testing ever, and there was no contact tracing done by my employer. Still, as of 4/28, we still are drawing COVID patients without being informed, without the workers being informed. We are told they need to get tested, and there is never any quarantine after exposure. The nursing home phlebotomists still have difficulty getting PPE. They are still drawing COVID positive patients, and there's still a lack of guidance from management. The couriers also have a COVID exposure risk. They go into nursing homes and pick up coolers full of COVID specimens. Some are not sealed, some are leaking. The couriers never even got hand sanitizer. They were told to look at Rite Aid or Target. When the couriers would take specimens to the lab processors, those lab processors had to deal with all the ripped and leaking specimens all day long with no ventilation or hood to work under. There are stories like this all over the technical department. I am very concerned how this is handled and how our lives have been put in danger. I am worried how it will be handled in the future as the pandemic continues. The things I've spoken about are reasons we need workplace protection in healthcare settings and an OSHA standard for COVID-19 and healthcare to require strong protection for all workers. Thank you for the time to speak.
Thank you.
So,
Go ahead if you'd like to introduce.
sure. Thank you, Frank. And I would like to introduce Bob Andrusko also from CWA 1168.
Please go ahead, Mr. Andrusko.
Do I have video ability here?
At the bottom of the screen, Bob,
Okay.
of the whole window. It should be next to the mute button.
No, it's not. So hang on. I don't know why it's not coming up. Well, nevertheless, I'll just begin. Thank you, Judge Bland, and OSHA committee members for allowing us to participate in this hearing today. It's very important, in fact, vital that we do have permanent standards. And I thank Mickey and Frank for their testimony. My name is Robert Andrushko. I'm a registered nurse and Executive Vice President of CWA Local 1168 in Buffalo, New York. We are healthcare local with over 4,000 members in all job titles working in hospitals, long-term care facilities, labs, clinics, and patient service centers at multiple locations throughout Western New York. I've worked as a registered nurse in a hospital setting for 35 years, 28 years in critical care and multiple units, including ER. I currently work in imaging. During the tenure of my practice, I had rarely, if ever, witnessed or experienced anything like what my peers, coworkers, and I have over the past 2 years with the inception of the COVID-19 pandemic. The previous scares were early years of my practice with HIV, and then later the potential Ebola scare of 2014 and 15. We need strong enforceable OSHA standards to protect us against COVID-19 exposure in healthcare settings. There are still failures on so many levels and many gaps in protections and processes. The inception of the COVID-19 pandemic in the early stages in 2020 and subsequent surges in the past 2 years as variants evolved has prompted many questions of safety for healthcare workers and, by extension, their families. The fear and anxiety of the unknown was in the forefront of everyone's mind in early 2020 as information evolved and illness and deaths escalated. We all felt vulnerable, and we were. Protection from transmission and practice standards in the hospital and healthcare settings needed to be scrutinized and reinforced, largely because most were unprepared to deal with the enormity of the COVID-19 pandemic, or for that matter, any widespread infectious calamity. The CDC and government failed us in so many ways by incorrectly defining the way COVID-19 is transmitted, recommending the wrong PPE necessary to protect us frontline workers and our families and the community of patients we serve. Sadly, much of the information provided was in response to a lack of emergency preparedness and a lack of supplies necessary to adequately serve to protect us from exposure and illness. Intense emotions entered into the conversation as insufficient PPE supplies became clearly evident. Protection standards against airborne diseases, which should have been applied to COVID-19 and should have been continued to be applied, that call for utilization of N95s, half-face respirators or PAPRs, gowns, gloves, eye protections, etc., were ignored as the government politicized the issue as supplies continued to dry up. The CDC designated the COVID-19 virus, SARS-CoV-2, primary mode of transmissibility through droplets and recommended droplet precautions, which necessitates far lesser protections, such as the use of surgical mask, for example. A surgical mask is not a respirator and is not enough protection. As a union representative and registered nurse, I recall being actively involved with many others in my local in emergency preparedness, getting daily updates to the spread of the disease, availability of PPE, rules of masking, correct mask to use, what to wear, and with whom. We were planning to be inundated with patients as the first surge was supposed to bring the hospital systems to their knees due to the prospect of our ranks being devastated by illness with the inability to work. Inconsistency with direction and enforcement of quarantines, vaccination mandates, visitor control policies, and PPE requirements in the healthcare settings have provided unnecessary risk of exposure by COVID to patients, healthcare workers, our families, and the community at large. A massive number of healthcare workers and professionals who worked and gave selflessly of themselves through the pandemic became ill. Several died. Others have lasting effects of COVID infection or PTSD related to stress of the overwhelming myriad of issues, along with the deaths of patients they've experienced. When patients come in with COVID-19 symptoms, many times they are and were fast-tracked for diagnostic imaging tests, including CT, echo, MRI. In many cases, the patients are not worked up for COVID-19 until the end. This, after moving through the facilities, needlessly exposing workers as well as other patients. This certainly adds risk of exposure and contributes to the community health issue we're experiencing now. There needs to be very specific and consistent rules and policies that all policies or all facilities follow and include accountability. Patients coming in a hospital are also not always masked, and sometimes we don't have their history and do not know their COVID status. For example, they could be present in an ambulance, they could be bleeding, they could be critical, unconscious, or even ventilated. Patient policies and processes for outpatient screening of COVID-19 were largely inconsistent and poorly implemented, and sometimes changed without widespread notice to the staff in the facilities. In short, the safety net should have provided absolute protections without compromise. At the present time, my employer does not hold visitors to even the most basic of standards to prevent visitors from bringing COVID into the facility. Visitors have carte blanche. There's no info collected about their vaccination status. There isn't screening other than entry temp, taking, and masking is not enforced beyond the point of entry. Visitors who might wear a mask when they enter the facility take off their masks on the floor they are visiting. It is a big problem for our nurses and PCAs to enforce mask wearing. We have had a number of incidences where visitors have gotten angry about being asked to wear a mask. Violence against healthcare workers is always one of our concerns, and it has indeed happened. The area where I work is CT, MRI, interventional imaging currently. We cover multiple different diagnostic and invasive diagnostic procedures. The CT MRI department is located right next to the emergency department. Early in the pandemic, we were relegated to rationing masks and PPE. We were issued one N95 mask per day and instructed to save and reuse. It's important to note the manufacturer designates single use with each mask, as others in this forum have mentioned also and have learned through their practice. The practice continues to a certain degree. If there's a PUI, who is a person under suspicion, suspected COVID patient, we use an N95, gowns, gloves, and eye protection. Availability of PPE is certainly better now than it was, but N95s remain more controlled. During a CAT scan, you need to be very close to a patient, obtaining historical information, transferring, repositioning, and inserting IVs in order to administer our contrast mediums. We see dozens and dozens of ER patients, inpatients, and outpatients every shift. In between patients, we wipe everything down. Cleaning is always necessary and part of our established routine. This has lent itself to another chronic exposure of chemicals like bleach and antimicrobial sprays and wipes, which ultimately will be a problem in terms of chemical exposure. Besides protecting our healthcare workers, we need to prevent COVID exposure at work because of the impact on our families. In one tragic example, one of our union stewards contracted COVID at work. This patient was an example that we utilized early on in the discussion, came from a nursing home, wasn't vetted out for COVID, ultimately had a procedure, and he was exposed. He then transmitted it to his wife at home. His wife also got sick, and his son got sick and died from the illness. He was 24 years old. Such a tragedy. We also have concerns about the long-term effects of COVID, also known as long COVID. I've personally seen memory fog, embolic events, including strokes, heart attacks, pulmonary emboli, deep vein thrombosis in extremities, etc. We're only just beginning to understand the effects of long COVID. It is known that long COVID can occur in people who have asymptomatic or mild COVID, not just severe COVID. At first, there was a 14-day quarantine. We were tested if exposed. Exposure alone used to trigger isolation. The latest CDC guidelines were the weakest. The measures to reduce the spread, such as quarantining if exposed and isolation if sick, all fell apart. People were going to work sick and exposing others. The CDC guidelines got so watered down, and this allowed people to start coming into work while contagious. The CDC could have prevented this mass exposure, but they did not. Take tuberculosis as an example of an airborne illness. There are many protections that the hospitals already have in place when dealing with TB patients. We use airborne protections for TB patients. The TB patients are isolated in airborne infection isolation room. Healthcare workers must wear specific PPE, including N95s, PAPRs as needed, and others. There's a decon room when healthcare workers leave the patient's room. So it's totally feasible to have airborne protections, and they exist, although there would be need for more isolation rooms or temporary isolation rooms for COVID-19 patients. Unfortunately, airborne protections are not implemented for COVID because the CDC does not recommend airborne protections. You have to be able to change the PPE requirements as conditions or procedures change. Here's one example. Early on in the pandemic, we were intubating respiratory patients in distress. Over time, we saw that mechanical ventilation damaged lungs and patients couldn't be weaned, resulting in more poor outcomes and deaths. Since then, practice standards and criteria for intubation have changed, and more treatment regimens switched to high-flow oxygen without mechanical ventilation. With this, there's more opportunity for aerosolization and much higher level exposure to healthcare workers. It is a good thing to recognize different treatment options and to improve treatments, but you also have to look at the additional risk to workers and adjust protections accordingly to make sure they are protected. In other words, hazard assessment has to be ongoing. We have learned many things about the disease over the last 2 years, which should be used to develop best practices, best procedures, best protections, and the best possible OSHA standard that's permanent, that respects the dedication, expertise, and the lives of healthcare workers. I urge you to incorporate the most protective practices possible into an OSHA COVID-19 permanent standard for healthcare facilities and save lives. I thank you very much for this opportunity to speak to you. God bless.
Thank you. Anything further, Ms. Hernandez?
No, that's the presentation.
All right, thank you. All right, at this time, we will hear from the OSHA panelists. If they have questions, I'd ask other participants if you would like to ask a question to please raise your hand or press the *3 if you're on a telephone, and we will take you in the order you come. So the OSHA panel may begin.
Thank you. We do have some questions, and we thank all of the witnesses for their testimony today and taking the time to share their experiences with us. I will start with a follow-up question for Ms. Siegel and Hernandez. You mentioned PCR testing. Is that the only test that you would find acceptable for screening employees or patients or non-employees, or are at-home tests or antigen tests also acceptable for this type of screening?
So I think that there's a more complicated set of conditions to look at for COVID patients who are coming into the hospital who are going to need to interact with our healthcare workers. Then, PCR is the confirmatory testing. For employees, where you certainly after an exposure, for employees who may have symptoms of COVID, and for some type of surveillance testing, then PCR testing would be what we would recommend. I think for visitors, I would have to get back to you with some post-hearing comments. I think it's more complicated.
Okay.
And that may be more appropriate for an antigen type test.
Excuse me one moment. I'm going to ask anyone who is not part of the OSHA panel to mute themselves. We're getting a bit of feedback, and I want to make sure that the court reporter is able to transcribe everything. All right,
But just thank you, Judge. But whatever the testing protocols are, I think that what I had said in the testimony is true, is that you can't, antigen testing does not give you a definitive answer. No testing gives you no answer. And so there is still the need for protections for workers when a person's COVID status is not known. And there are options, again, for patients, there are options. Patients can be tested. I've done this myself before going for a procedure. Patients can be tested before going to a facility. And there's also testing that could be provided at that time. But waiting until a patient has traveled around a hospital or other setting and has interacted with multiple people and departments, as well as other patients, been in the vicinity of other patients without knowing COVID status at this point in time is just not acceptable.
Thank you. And we would welcome any other specifics you would like to provide in post-hearing comments about screening and testing. Another follow-up for you, you mentioned the interplay of controls as being necessary to protect workers. Can you expand a little bit on how a facility should implement controls in that way? I know you gave some specific examples of pairing them in different ways, but how would a facility make the determination and know how to ramp up or ramp down certain controls together?
So I think this all goes back to the need for a very thorough hazard assessment. And the hazard assessment, obviously COVID is the hazard, but the assessment looks at what the specific circumstances are for each separate environment. What's the interaction? What is the work that's being done by the healthcare provider? What is the interaction with the patient or patients? How large is the room? Kind of what's going on in that space? What is being performed in that space? So you have to start with a thorough hazard assessment before you can determine sort of what all of the potential controls are. There may be some forms of controls that are harder to put in place. We've talked about ventilation a lot. There are a number of ways. Ventilation is a very broad category, right? It could refer to an HVAC system, which can vary from area to area in a facility. It could refer to portable air filtration units with HEPA filtration that can be moved. It can refer to rooms that patients are in. We've heard several people talk about the airborne infection isolation rooms, and there may be some temporary rooms that are set up in certain circumstances for patients. So going back to your question, just let me give you an example of how this might play out. In the emergency department, where we have lots of patients, people coming in, COVID status unknown, that would be a perfect area if you're looking at ventilation. Obviously, the risk is high. It's high and it's unknown, just how high. In an area like that, then one, you would want to look at the kind of ventilation that is being supplied by the HVAC to that area, so you can potentially increase the air supply. If not, that would be a perfect situation where you may have additional portable air cleaners required. You're still going to need respiratory protection for workers. The PCS that Frank spoke about, and he spoke about the waiting room and also the draw room that he works in. I don't even know if they have an HVAC system in those outpatient locations. Again, a perfect place where you could have portable air filtration units. And if in certain areas, if you had a number of controls to reduce the risk to a certain level, then it may be possible to sort of ease up on certain other protections. We haven't spoken about employee break rooms, These have been treated as like a neutral area, as if no COVID transmission can occur. And these are areas, again, indoor spaces. Nobody is wearing any kind of respiratory protection. So that would be, and people have to eat, right? They have to eat and take a break and rest. That would be a perfect example of where you really needed to amp up the amount of ventilation that is being provided. You may have administrative controls limiting, if you could, the number of people that are in the room and so on. So there's a relationship. As one control is lessened, it may need to mean that others are increased. So there's no one answer, and I think that there isn't one metric, but I think OSHA has decades of experience in looking at sort of plans and controls, and I think that's where I think additional guidance in as well as what might be required in the standard would be appropriate.
Thank you. And Mr. Andrusko mentioned a little bit about ongoing hazard assessment being necessary. Can you guys describe a little bit of how that would be implemented to effectively protect workers?
I can provide examples. I don't know exactly how we would operationalize it. I mean, currently, like with visitor control policies, I think that there should be some level of consistency, not just at the hospital sites, but all the sites. So long-term care out of all the facilities kind of had the tightest constraints on visitors. And there were requirements. Initially, long-term care residents could not have any visitors because of considered their fragile state. And so I would actually probably go as tight as saying that should have been the initial response for the duration of the COVID surges. What's happening now is I would cite examples of, I think that if they're going to require healthcare workers to be vaccinated, then I would say that they should require visitors to provide proof of vaccination also. So it's kind of like it's an inconsistent type of system, but also when you walk into any particular facility, there's a difference in the way and inconsistencies in the way people are vetted out. So temperature taking is different, as one of the prior panelists had indicated. Some are using a wand that's not effective and inaccurate. Now big hospitals have purchased these large screen TVs that basically show you from a distance to have a green light or a red light if your temperature doesn't meet the certain criteria. And the small facilities that we represent don't have the equipment because it's very expensive. They don't have the manpower to do it. But it seems like there has to be some consistent technique that provides safeguards. And some of the surveillance is actually inadequate or really doesn't mean anything. So once you have a fever already and you've been by 5 or 6 people standing in line, because that's what they're doing, they're standing in line, you've already exposed those folks if you have COVID, if you're already COVID positive. So I do know that you had asked a question about testing, and the PCR testing is the most effective. And there's a Cepheid machine that does multiple testings now in a short order, so they can have results in 30 minutes. So those types of examples also with outpatients who are coming in for diagnostic testing, they don't need to have a negative PCR test, but yet they're mingling with the same patients who are going for a procedure who have had a PCR test prior to their procedure. So they might be having a lung biopsy, some sort of surgery, whatever. And the regulations stipulate they have to have a PCR test prior to their procedure. But yet in the very next holding bay, there's someone who's going for a diagnostic test who's not held to the same standard. It's just not protective. There's too many gaps. It's a safety net with holes in it. So we have to close those holes. Sorry for the rambling, but there's a lot that comes to mind, and it's kind of a passionate subject.
Yeah, thank you for sharing your experience. So to follow up on that, if there's concern about not having equipment or the ability to do the temperature screening in a consistent way, would facilities have the capacity to do testing that is across the board, or are you talking about having people do testing somewhere else and providing results of that?
Well, some of it, the particular areas or the hospital systems in Western New York we deal with do have the capacity to do testings. One of the larger systems has its own labs and testing and turnaround facilities, which actually Frank is a part of, who had provided testimony. The other healthcare system also, the major healthcare systems with a lot of resources. I do understand that, as technology starts to unfold, we should be contemplating these things, that it will be available shortly, because they've developed over the last 2 years very significant changes in the way PCR testing is done, and they fast-tracked it. So now it's more about capacity, because I know in our labs there's thousands of tests that are being done now. Initially, they only had the ability to do 200 tests, then it grew to 800 tests, then it grew to 1,000 tests, and now it's like 3,000 tests a day, which our lab can accommodate in terms of, with quick turnaround time. Those are 24-hour turnaround times that I'm citing. The immediate ERs, they're able with the Cepheid to get a 30-minute turnaround time. And the capacity is somewhat limited in how many tests they can do at one time, but those are specific to ER patients and those that are coming in through emergently.
Jessica, can I just add two things that was part of your question? One, I think that we have in some large hospital healthcare systems, like the one Bob works at, they have a certain capacity. I don't think that you could say that every single setting in all states and all places, even in New York, in the same state, have that capacity. But there are outpatient. There are many places that people can go to be tested, and so I think that access in some areas is definitely, it will be different than some other areas, which will have to be considered. You also asked about at-home antigen testing, rapid tests, and we would not support that as a way. I just feel like it would not give us any information for a couple of reasons. One is that you still don't know, right? There's still uncertainty. It's like you probably don't have COVID, maybe, but you still can, depending upon when that test was taken. And a person can still be infectious and have COVID and have a negative antigen test. That's one. And two, it's similar to asking somebody a question during screening. It really just depends on what that person says. There's no way to it's not verifiable in any way. So home testing, I don't think that would be applied for the purpose that we're talking about here.
Thank you. So for all of the patients or employees or visitors who you're suggesting need to be screened with PCR testing, and if they're not, we're assuming that they are suspected of COVID, is your recommendation that anyone that is dealing with patients who have not had a PCR test wear a respirator, or what other controls will be put in place for that? And like, how far does that extend to any of the unknown status around a healthcare facility, and whether universal respirator use is the only way to solve that potential exposure?
I think that it's a difficult question. Certainly any healthcare person who may be working with that patient should be wearing a respirator then. If it's unknown, then they could be infected. Whether or not every single person who may be where that patient passes, we don't have a policy on that. That would certainly be the most protective. Right.
Sure. I would welcome you to consider that in your post-hearing comments, and provide any recommendations you have about how we would deal with other areas of the hospital where we have concerns potentially.
But the best thing is to know the person's status and then be able to protect accordingly, right? Otherwise, then you're in the position that we've that we've been in, of either not being protected or having to, having to use other kinds of controls that, that might not be necessary otherwise.
Excellent. And if you could elaborate in your post-hearing comments about, what you would think if it's really only the PCR testing that would provide that definitive indication of COVID status, that we could then make that decision of controls based on, or if there's some other mechanisms that we would use to assess that COVID status in a way that would be protective of workers. So
Sure, absolutely. And we're hoping, I hope that the technology continues to improve, and maybe one day we'll see, breath testing with the result in minutes. We're just not there.
Right. Thank you. And just one final question for Mr. Andrusko before I turn it over to my colleagues. You mentioned cleaning equipment and the room between patients. Is the cleaning that you described in your testimony earlier standard cleaning, or was that heightened cleaning for COVID purposes?
It was absolutely heightened. And in fact, initially, with lack of understanding of the virus, there was times, so if we had a definitive positive patient, like in a CAT scan or any room, actually, if they were in an MRI, we would shut that room down for 30 minutes after we cleaned it. So we had time for the disinfectant to take hold, kill whatever virus there is, and also prevent the droplets that were created, the aerosol, from either utilization of sprays or wipes to settle in the room. And there's a lot of, if you tape off a room, any room, I guess, in a hospital or a CAT scanner, there's a lot of ventilation going on. So that is swirling around, and we've come in contact it continuously. So it was absolutely heightened. And as antimicrobial agents dried up and certain bleach products were no longer available, God knows what we were using, because it was like mixtures of different chemicals that we were getting and spraying on different surfaces, wiping them down. At some points it was paper towels. Now there's a lot more antimicrobial wipes that are available, but folks are still using like a normal household sprayer, and you're getting mist, right? So as you're wiping down these surfaces and wiping things down, you're constantly in contact with it. And it's every patient, every time, so definitely heightened. There's certain people that have gotten more lax, but procedurally speaking, that's what we were instructed to do, and it makes sense in a lot of respects, because you're utilizing equipment, people are touching things, and dozens of people are.
And is there cleaning that you would have normally done prior to COVID in between patients in that circumstance?
We'll do a quick wipe down if there's any blood or body fluids or whatever. Not always, no. So there's protective material on certain tables. Wheelchairs are not routinely cleaned between patients. Certain chairs aren't routinely cleaned. We cleaned everything. Countertops, and we have portable computers and everything. Everything was wiped down. All the, we'll wipe down blood pressure cuffs now between patients, or I should say previously between patients and the cords. We were wiping down everything, the whole modules, the poles, the hanging poles, everything to try to prevent the spread of this disease.
Given our evolving understanding and the importance of airborne exposure, do you believe that these enhanced COVID cleaning measures are still necessary to protect workers?
I think that there's evidence that it's the disease does, the virus lives on surfaces, and it can be aerosolized. So, going to the subject of high flow oxygen, a lot of these particles are dispersed. And when we had, actually, there was a shortage of high flow oxygen at one time too. So that's better now. But yeah, I believe that you do need strict cleaning standards.
Thank you. I'm going to turn.
I spoke to an ER doctor who recently told me, I took ACLS, and he said that it lives on your shoes for originally they were saying that it lives for 30 minutes. It lives on your shoes for a day or two. And he's done his own testing. He owns a lab. And so that's a significant amount of time. I think one of the other panelists indicated earlier today that she got undressed in her garage. Ditto. In my garage, right down to my nothing, made sure I threw everything, including my sneakers that I wore to work or shoes I wore to work, in the washing machine to disinfect it. So it's serious stuff.
Thanks. Any specific evidence you have to demonstrate all of that would be really helpful for us to have in the record. So if you could submit anything that you have in the post-hearing comment period, we would appreciate it. I will turn it over to my colleague, Robert, and thank you all for your answers.
Thank you very much.
Thank you, Jessica. I'm Robert Stone. I'm an OSHA economist, and I also want to thank the members of this panel for testifying today. I sort of have an overview question for all of you, any of you. I know you all testified very specifically about detailed provisions of the ETS and procedures that might be needed. But my question is more general, and that is, to what extent do you think that the labor shortages, particularly in the healthcare setting, that have been observed during the pandemic, have been alleviated by the ETS and would be further alleviated by a final rule? Thank you.
So thank you for that question. I think that that's a really difficult one for us to answer because of how many things are related to labor shortages. And there were issues, Bob or Frank can talk about this as well, issues before. Short staffing has always been, and for a very long time, been a concern in a variety of facilities. So I think that the pandemic has certainly exacerbated some of that, but it didn't create labor shortages. And so I think it's really hard for us to say whether there was a specific instance where the ETS prevented it. But as I said earlier, when you protect workers with, just with relation to COVID, when you protect workers, when they don't get sick, then you don't make a staffing shortage worse, then they can continue to work. It's been the backsliding or the ignoring worker exposures that has, that can increase spread of the virus to other workers. And that doesn't just affect worker shortages, it has affected workers' lives, and in some cases, workers have lost their lives because of that. So I think that some of the things that we spoke about in terms of exposure notification and so on, although it would require some time off, can only help with a shortage because it would prevent workers from getting sick.
I agree. I agree. It's a complicated, you would have to do a lot of different analysis to come up with any specific, whether it would almost be like you would have to do a singular study as opposed to the myriad of things that are going on, because obviously there's market and wage pressures that are taking people out of the system in terms of working. And I don't know if you had a specific job title in mind, because obviously there's differences in terms of whether it's registered nurses or pharmacists or, unit secretaries. But I know that, for EVS workers and dietary workers who work very hard in the hospital, a lot of folks left the work area in hospitals. One is it was unsafe, but there's other opportunities in terms of higher wages outside of healthcare, where they're not at risk, but they're earning more money and actually the work is better. So a lot of the folks that we know have left are for better salaries in non-healthcare environments. So.
And Robert, I would also add that anytime you are short-staffed, then it places a huge burden on the worker that is there, the healthcare worker that is there. And so all of the things that Bob has talked about, that Frank spoke about, it makes it that much more difficult. Hours may be extended, so add both the stress and exhaustion on top, and how that affects people's work. So again, I think anything that helps to protect workers, and is a positive thing. I don't know that even a permanent standard, how much of an impact, because this is so much a part of healthcare, how much that will impact the staffing issue. Just as a side piece, in a CWA local union that is close to where Bob and Frank are, that local union was bargaining a contract recently during the pandemic and actually had to go out on strike, which was pretty significant during this pandemic, in order to get language in the contract about staff to patient ratios, because it was so extreme.
Let me try to either follow up or conclude what I'm hearing from you, because I know you're indicating the difficulty in analyzing or responding to my question. But on the other hand, what I'm hearing you saying is that that having workers better protected both keeps them on the job so they're not out sick, but beyond that, it reduces their overall risk and makes it perhaps less likely that they will feel the need to leave the industry, or either leave working or leave the industry. Could you respond to my summarization?
I think that is fair. I think that, a lot of harm has already been done to healthcare workers from the beginning of the pandemic. So, people have felt, and not that they felt abandoned, but they were abandoned. They were left to, their lives were put in danger. So I think it is going to take a long time to build up to a place where, workers feel safe. We feel strongly that a permanent COVID-19 standard in healthcare will definitely help with that by establishing standards that an employer does have to follow. So for workers who may still be considering leaving, that may help in knowing that there will be some protections in place. Right now, there just aren't. There just nothing enforceable in terms of protection.
If I could just respond I can't answer your whole question. I can tell you that people were seeking out adequate protections, and they still are. So yes, there are some people that don't believe in the COVID virus, right? So, but there's others, and I will tell you, it was heart-wrenching as we went through this. There were so many young females who were pregnant and fearful in 2020, and we didn't have answers for them. And they were told, a lot of them left the workforce. Some sought different vehicles to leave the workforce, such as disability and things of that nature. But I know several that just stuck it out, and they just wanted the best protections. And some of them were not adequately fit tested, so they needed PAPRs. So that's like the full, respirator where you're wearing a pack in the back, right? And so the hospital only had 2 of them, right? So they would have to run to get their PAPR if they thought they could get it. And they were working on the first designated COVID floors in the surge. There's so much unknown. And so your heart has to go out to people. They're fearful. They want to do their job. They're pregnant. They want to have healthy babies. There was so much unknown at the time. I mean, these things could have staved off a lot of that anxiety, fear. And I think that some things are irreparable. I mean, the violation that occurred at the time, some people will never come back. They left, they're not coming back. they feel violated. Others, this is their career. They're going to stick it out. They want to stick it out. They want to assure that their support, not just in protections, staffing, everything else comes into play, right? And obviously compensation, but it does start with safety, and that, the employer can't say, no, sorry, we only have 5 masks today. We have 10 people, figure it out. That's not acceptable.
Okay. All right. Again, thank you so much for your testimony.
Thank you.
Thank you.
Thank you, everybody.
Are there any further questions from the OSHA panel?
This is Amy Tryon from the Solicitor's Office. I have just a couple of quick questions for Mr. Juergens. Mr. Juergens, we are sorry. Thank you for your testimony. We are sorry to hear about your work-related COVID infection. Do you know whether your employer recorded the infection as part of their OSHA record-keeping obligations? And we'd also welcome any additional information or data you have about other colleagues who have become infected on the job.
So it was very sporadic. So with my infection, the county actually got my result. So and they did not tell me that they found it through Kaleida. They found it by vetting it out, and they called and tracked and traced and did all the appropriate measures. Kaleida didn't call me one time, not once.
Sorry, what is Kaleida?
I'm sorry, my hospital that I work at, they never called me one time. The county is the one who called and tracked and traced me. And I think a lot of that went on early on. We didn't get much information from our hospital. A lot of it was from the county.
Could I add to that? So we recently requested the logs because we did want to verify information. Our understanding was that many of the employee health facilities or departments within hospitals were tracking it, but it did vary. And so we've recently requested a lot of the OSHA logs to see what information's there.
Well, I was next going to ask if you have access to any illness logs, any OSHA logs. We would appreciate your submitting them to the record. Sorry, Mr. Juergens, did you say you know whether your particular case was recorded or not?
It wasn't recorded through my hospital.
Okay.
Our county government tracked it.
Okay. Did you report it to your county government?
They called me, so they had access to it.
I see. Okay. Thank you very much. That's all I have.
Okay. Thank you.
Can I just add that in my conversations both with this local 1168 and with other locals across the country, we have been working to collect both OSHA, the COVID plans, OSHA logs, and the COVID logs. And so in this particular case, they were just received. I think we're still waiting for the COVID logs, and to see if we can sort of make that connection, to see for the illnesses that we are aware of, that the union is aware of, if they are actually appearing on either of those items. On an OSHA log, it will be easier to tell. On a COVID log, obviously we don't get that with names or titles, but we may be able to figure out, sort of time frames of certain people who have come forward and that we know about who were ill.
Thank you. Well, again, we'd appreciate your submitting any logs or any analysis that you have done of the logs in the post-hearing comment period. Thank you very much.
Thank you.
Right. Anything further before we take our attendees' questions?
No further questions from OSHA, Your Honor.
All right. Thank you. We have 3 folks who have raised their hands. Theo Allen, Rebecca Reindell, and MK Fletcher. If we could promote Mr. Allen for him to ask his question.
He has been promoted.
I'm going to mispronounce your names, but I'm asking this to the healthcare workers. during and after this standard, have you been noticing your workers and everyone complying with pre-COVID and hygiene, such as removing or putting on gloves and between patients?
Yeah, compliance is particularly during, so it's kind of a strange phenomenon. So as the surges intensified, so there was several surges, compliance was at all-time highs during those times. And as you know, obviously the population, so we get reports daily of how many inpatients, for instance, in a hospital or in the community, how many people are positive. As the numbers dropped precipitously, people started taking less protections. In terms of hospitalizations, when we were at all-time highs, you would walk down and people were basically, you know, they had their N95s on, they had their eye protections, they had headgear on, then they had a face mask, the clear face masks that were donated by several large companies for at least in our area. And then they were just garbed up all the time. And so, you know, people, it was very serious. People took it seriously, but as anything, you know, as the risk goes up, people took protections, and as they've gone down in terms of numbers, right, community numbers and hospitalizations and how many people we've seen, then the protections lessen.
Right. Thank you. Thank you for your question, Mr. Allen, and thank you for the answers. If we could promote Rebecca Reindell.
They have been promoted.
Hi, thank you. This is Rebecca Reindell. My question is more geared for Mickey. And it's about, you had talked a bit about ventilation in many of these settings. And I was wondering if you could elaborate on more specifically on some ventilation improvements that are feasible that employers can take. Thank you.
Sure. So I mentioned a few earlier, and I want to give an example of we have a hospital in New Jersey where we represent members, and at one point during the pandemic, they did not have enough airborne infection isolation rooms, and they created a temporary airborne infection isolation room from their PACU, their post anesthesia area. And the local union felt that it was put under negative pressure, and they sort of built their own. The hospital built their own, and the local union felt that it was not safe, that they couldn't verify whether it was safe or not. There was an OSHA complaint filed. OSHA by the time the investigation was complete, there was no longer a need for that particular location, so there were never any citations. However, OSHA, the Region 2, did forward that complaint and the information that had been provided to OSHA's Directorate of Technical Support and Emergency Management, their Office of Occupational Medicine and Nursing. So this is a very specialized group within OSHA that has a lot of expertise. We were really happy that they did this. And so that office, this was back in, I have to check the date, but that office did an analysis, provided information. And one of the interesting things that came out of that analysis that they put into that report was that the CDC and the CDC provisions that might apply were not effective. And they made a very strong recommendation and reference to what they called were the authoritative experts in that area. And that was both ASHRAE and the U.S. Army Corps of Engineers, who had put together a document for temporary ventilation measures during the pandemic. Because if you remember, things were being built all over the place. So, we can certainly enter that into the record as well as the report. But my points are that, one, it would have been possible to have built a safe temporary airborne infection isolation room. There are resources that exist. There is expertise that exists within OSHA to help guide that. And again, if the CDC was not, their guidance was not at all helpful in that regard. So that's one example. And I think the rest of the ventilation issues, as I said earlier, are much more complicated. But there are a number of different options. We haven't even spoken about ventilated headboards for patients, and which type of ventilation measure is implemented, or how an HVAC system could be improved. That will really be very site specific, and then even within sites, department or area specific, part of the assessment that would need to be done.
Any other comments from the panelists before we move on to the next questioner? All right, thank you for the question there. If we could have MK Fletcher promoted, please.
They have been promoted.
All right, thank you. You may begin.
Thank you so much. And thank you all for sharing this now afternoon. My question is more for Frank. During your testimony, you shared that a nursing home phlebotomist who was infected with COVID was told to work in a patient care center instead of their normal job. Why do you think the employer directed this? Could it be because there wasn't a standard?
Correct. They're saying that that employee was not infectious anymore, even though they were still testing positive for COVID. They were not, quote unquote, infectious, and there was no standard to say otherwise.
Thank you.
You're welcome.
All right, thank you. Thank you, everyone. We have come to the conclusion. I appreciate the testimony of the CWA and the thoughtful questions posed by our attendees. At this time, we're going to take a lunch break, and post-lunch, we have 5 panels, shorter than this morning, but I'd like for everyone to come back at 1:30, and we will proceed then. We'll take a break after the first 3 panels that we hear, a very, very short break, and then come back for the remaining 2 longer panels. So we are in off the record and in recess until 1:30 Eastern. Thank you, everyone.
Good afternoon. This is Lauren Phillips Thorne from Apt Associates, OSHA's contractor. It is now 1:30 p.m. Eastern Time, and we are rejoining OSHA's informal rulemaking hearing for occupational exposure to COVID-19 in healthcare settings. As a reminder, if you are speaking today, you will receive a notification on your screen that you will be automatically promoted to the panelist group a few minutes before it is your time to provide testimony. We ask that you do not unmute or turn on your camera until your name has been called and you have been asked to start your testimony. Speakers connected by telephone should unmute their phones when called to testify. If you submitted a presentation in advance, we will share the file and advance the slides. Please cue us by saying next slide when you need us to advance. If you have a presentation to submit for your testimony this afternoon or for a future date, please send it to both public_hearing@aptassoc.com and ets@dol.gov. Presentations submitted at the time of your live testimony will be submitted to the public record, but it will not be shared on screen during the testimony. After each individual or group provides testimony, the administrative law judge will open the floor for questions. If you have questions for the individual or group who just gave testimony, please press the raise hand button. If you have called in from your phone, press *3 to raise your hand. We will do the best to call on you in the order of hands being raised. If you are having technical difficulties, please send an email with your name and phone number to public_hearing@aptassoc.com. I will now pass the floor to our administrative law judge for introductions.
Good afternoon and welcome back, everyone. We are back on the record in this informal public hearing on the Occupational Safety and Health Administration's proposed rule on the COVID-19 healthcare standard. We have 5 more panels this afternoon, and we begin with the American Federation of Government Employees, who have 20 minutes to present. If I could have them promoted, please. We have Millie Rodriguez and Mary Jean Burke.
Unfortunately, I do not see Mary Jean in the attendee list. If you have joined under a different name, please press the raise hand button to indicate your presence and I will promote you. Thank you, MJ. I'm now promoting you to panelist.
Excellent. And because there's 20 minutes for the panel, each speaker, I hope that you can keep track of your time, and each can have 10 minutes or however you have determined to split that up among yourselves. And you may begin.
Good afternoon. My name is Millie Rodriguez, and I'm a health and safety specialist at the National Office of the American Federation of Government Employees. AFGE, which represents more than 700,000 federal and DC government employees, including more than 260,000 healthcare workers across the nation, fully supports OSHA's rulemaking on occupational exposure to COVID-19 for healthcare settings. We commend the work of the OSHA staff, who AFGE proudly represents, along with other Department of Labor employees, and the leadership of DOL and OSHA for all the work that has already been done, and for taking the next steps toward a final standard. When OSHA issued the ETS in June 2021, we welcomed it as a much-needed protection for healthcare workers. We were disappointed that OSHA did not cover all workers with potential exposures to COVID-19, however. In written comments on the ETS submitted in August 2021, AFGE urged OSHA to strengthen the standard and include requirements for employers to, 1, further investigate whether workplace conditions contributed to the case and to put measures in place to prevent future cases, to require notification of exposure regardless of PPE use, to require employers to not only keep a log, but also to notify OSHA of any outbreaks, to require employers to include employee and employee representative participation in employer COVID-19 workplace safety plans and not only encourage their participation. Because we were under an administration that opposed union involvement when the pandemic began, our local leaders and health and safety representatives were effectively locked out of briefing meetings on how the agencies where they work were addressing the oncoming pandemic. Although the current administration is supportive of workers and their unions, full participation has been slow going. We feel strongly that workers and their representatives can make valuable contributions to their workplace COVID plans, and the standard should require their participation. Otherwise, employers will continue to resist employee involvement. The ETS gave workers a systematic way to be protected at work by requiring healthcare employers to put in place measures to mitigate exposure. The provisions of the standard gave workers the strength of an enforceable standard to ensure that their facilities followed the requirements. Still, many AFG locals had to file OSHA complaints to get their employers to address their COVID concerns. Regarding the changes OSHA is considering, I would like to highlight a few points from our written testimony. We oppose OSHA aligning with CDC recommendations for healthcare infection. Infection control practices are different from exposure prevention controls. They do not follow the hierarchy of controls. OSHA standards outline employer responsibilities for reducing and eliminating exposure to workplace hazards. OSHA must not delegate this authority and its responsibility for worker health and safety to the CDC. For healthcare workers, the CDC return to work guidance was difficult to accept because they were often fearful that returning to work too early would put their patients and their coworkers at risk of infection. Workers who are infected should not be in the workplace. At a time when healthcare workers are experiencing elevated levels of stress and anxiety due to COVID-19, they should not have to be burdened with the fear of putting others at risk if they return to work too early. Record keeping and reporting requirements should be maintained, and logs should be kept for longer than 1 year. While there have been issues with the accuracy of the logs and with access to the logs, in general, the COVID-19 logs have been a useful source of information. They can help in preventing the spread of infection and prompting employers where there is a need to implement more control measures. Surveillance is an essential element in identifying clusters of cases, locations of cases, and ultimately helps in controlling workplace hazards. Employers should be using the information as they do the OSHA 300 logs to identify patterns and to look for ways to further reduce exposure. While we all hope we do not have to deal with COVID-19 in the same urgent manner in the future, all signs indicate we will be dealing with it and/or other airborne viruses in the future. The logs can also be useful for researchers to study to help us understand COVID-19 and its impact on the workforce. For exposure notification, the requirements should not be relaxed regardless of vaccination status. Exposure, even among vaccinated individuals, can lead to infection, as we have seen with reports of breakthrough infections. In addition, a healthcare worker who is vaccinated but exposed at work may infect others at the workplace and expose vulnerable family members at home. Workers need to know if they have been exposed so they can make and take appropriate precautions. In the final standard, OSHA should include paid medical leave for workers who become sick or who must quarantine after an exposure. They should not be at the workplace, and they should not suffer financially when they have to stay home because they are sick. The pandemic has taken a toll on all of us. We have had to make changes and adjustments in our everyday way of life, both at work and at home. Mental health has suffered and until recently has gone largely unaddressed. For those on the front lines, these changes have been compounded by the need to continue to work, to continue to be of service while experiencing illness and death in those they care for, and fearing for their own health and the health of their families. While the standard does not address mental health, having these protections in place would reduce some of the stressors healthcare workers experience. In closing, a standard to protect healthcare workers from exposure to COVID-19, grounded on the airborne transmissibility of SARS-CoV-2, is still urgently needed. The final standard should improve on the ETS and provide additional protections based on the experiences of the last 2 years. We urge OSHA to move quickly to issue a final standard. Healthcare workers need these protections and the strength of an enforceable standard to back them up when they take a stand for workplace health and safety. Thank you for the opportunity to speak today.
Thank you for your testimony. Mary Jane Burke?
Yes, thank you. Can you hear me?
Yes, we can. Go ahead, please.
Okay. My name is MJ Burke, and I'm the first executive vice president of the AFGE National VA Council, and I'm a physical therapist at the Indianapolis VA Medical Center. AFGE National VA Council represents approximately 260,000 healthcare workers throughout the nation. And I would like to start with the support for a permanent COVID-19 standard. Additionally, what I think is important for this hearing is to remind OSHA of its original congressional intent, which is to assure so far as possible every working man and woman in the nation safe and healthful working conditions and to preserve our human resources. So how I think about COVID as a recognized hazard in responding to this potential final rule or interim final rule is first to examine what we know about the effect of COVID has had on our healthcare workers, and two, what OSHA can do to preserve our human resources. It's not lost on me or any other healthcare workers that the labor market is tight. I first would like to talk about the effect of COVID on the healthcare workers. In the initial year of the pandemic, reporting by Kaiser and other investigator reporting stated that the average death of a healthcare worker was under the age of 60 compared to mortality of COVID of non-healthcare workers being in the 70s. So the adverse impact is that we are losing healthcare workers at younger ages, likely due to the workplace exposure. Additionally, European pandemic research demonstrated that healthcare workers were 7 times likely to have severe COVID-19 and were 10 to 12 times higher risk of testing positive than their community peers. Both data points signal to me an increased occupational risk for healthcare workers without a doubt, a risk that healthcare systems would rather downplay, pointing either to a nexus of one or two things. One, you can't prove you got it at the workplace, and if you did get it, when the community infections rise, the notion that you got it out there. However, the increased statistical risk doesn't bear those out for certain occupations. COVID risk, especially for mortality, has been significantly lowered for vaccines, and workers operating in tight spaces such as prison workers do carry higher than community risk for those occupations. OSHA must all do what it can not to let history repeat itself. I have, as a union rep, and you have, purpose in remembering people like 3 out of our 11 individuals at my facility alone who died of COVID. 3 in the first month. Like most of all healthcare institutions, we were plagued by PPE inadequate supplies despite having agency-wide emergency response plans for pandemics. People join a union because they want safety and security, increasingly because they want respect. In regards to the effect of regulation, I recall in my labor career hearing Cecil Roberts, the president of United Mine Workers, talking about the lives of coal miners saved by DOL regulation. This is a fact based on statistical evidence of death and injuries of coal miners before and after implementation of safety regulations. I recall reading about the reasons why Congressman Patel, who assisted in creating the OSHA Department of Legislation for Environmental Healthcare Latency of Workers who were once exposed to cotton dust, his effort through regulation also saved lives. So OSHA regulations do save workers' lives. This is a fact and will be no different when OSHA promulgates and enforces interim final rules for COVID. Those rules should not be deprioritized in favor of healthcare business interests, mostly related to worker shortages. Despite our nation's polarized beliefs about masking and vaccination, I too believe OSHA can prevent harm and save lives. It is through this lens that I lend my remarks to the OSHA interim final rule. A1, alignment through CDC recommendations, healthcare infection control practices, A1 through A4 and A7. Employers must realize the basic premise, OSHA law trumps CDC guidance. In saying this, obligation of employers regarding a known recognized hazard, which is COVID in this case, at a minimum, are required to perform hazard assessments related to potential exposures of workers to that hazard. It does seem that airflow cleaners are underutilized and plexiglass in non-crowded spaces are less useful. However, CDC isolation changes through the pandemic from 14 to 10 to 5 did not lend workers to trust the government from a worker's perspective. Starting with the publishing of guidance for the use of bandanas as a last resort for PPE and the continually dropping of isolation day, it felt like from a worker's perspective, the CDC recommendations and guidances were more based on the ramifications of reality of either worker or PPE shortages, rather than the true science of NIOSH, Institute of Medicine, or the larger best safe practices, which should be the default for OSHA regulations. For example, it was always known that 5% of chronic immune compromised patients who are infectious could be infectious beyond 20 days, but up until ETS, no option for volunteer respiration standard was stated within the CDC guidance for respiratory protections. So at a minimum, rules like the TB OSHA standard that use isolate and respirator protection if suspicious for TB to default to a worker safety seems similar to what we should be doing for COVID-19. Healthcare workers seem to understand by now that when you come in contact with the person under investigation, that you need to wear a respirator and all the gear. But for the worker, sometimes you don't really know when that provider may think a person is under investigation. As such, I would support enforcement guidance similar to TB CPL 0202078, which addresses subject to suspicions within TB and what kind of symptoms may lead an investigator to believe when a provider should believe TB or COVID is suspicious. I think a similar approach for a COVID enforcement rule would be helpful, especially investigating outbreaks related to hospitalizations and fatality. I support mandating after action investigations for COVID outbreaks. This would at least attempt to have employers identify potential means of routes of COVID exposures and to improve the workplace for safety. It does not make logical sense to me to have an OSHA healthcare TB standard and not have OSHA COVID standard, given the amount of COVID mortality and the days lost for workers, as well as the long-term effect on the immune compromised workers and minorities related to COVID. Therefore, I do not support it. In regards to a counterpoint of CDC guidance, I don't know healthcare facilities that completely follow the guidance, especially the language for informing patients and healthcare workers when a facility was using contingency or crisis staffing for optimization. They were required to do so. But I don't know any facility that did this either formally or informally. Therefore, I think at the very least, OSHA needs to continue to have written employer notification of exposure to employees, both vaccinated and non-vaccinated in the final rule. I believe this could be within 48, 72 hours of close contact, consistent with CDC guidance. I believe the OSHA could keep the employee requirement of positivity reporting to the employer. Additionally, add employer required communication for workers on what they mean by contingency and crisis staffing if they are optimizing workers for outbreaks, which means 2 or more in a work unit. I think this is important because the majority of pregnant healthcare workers that I knew in the acute side of the hospital always ended up with COVID. So many were forced to use this leave, and I will discuss this a little bit in C23A a bit later. The definition of well-defined work area for exception rules for notification are fine, but additionally, employee representatives like myself need clarification, interpretation on what they mean for employees who cross-covered COVID and non-COVIDs alike when they stick a COVID and a non-COVID in the same room, if they're on the same shelf, or subsequent days for exemption notification rules. I support a minimum of employee notification regardless of vaccination status. I believe the notion of tracing regards to one person within a work unit versus two in a work unit within a 14-day period. I believe is essential for two or more in a 14-day work period, especially on all inpatient wards, extended care facilities, dialysis units, and areas where you have immune compromised workers and patients. I am in support of putting employee representatives on written notice on what staffing data they rely on to forego isolation or quarantine related to transparency. When a community transmission and hazard assessment, they entertain the idea of CDC guidance utilizing transmission rate for risk stratification. But under previous known situations, like at the beginning of the pandemic for PPE, optimization, as they call it, that didn't risk well for workers because in reality, they were basing hazard assessment based on what their inventory was. So I'm not supportive of this. I am supportive, however, the CDC standardized composite metrics such as vaccination rates, 85% or higher. If waste stream water analytics is available to use that, ED, hospitalization, COVID presentation, transmission rates will be helpful for allowance and relaxing masking requirements where healthier populations tend to reside. A7, maintaining all copies of COVID logs and plans has been helpful to me and has assisted me in doing my job when employer conditions have changed. Additionally, I believe it could help inspectors decipher if retraining has occurred for employees related to policies such as patient flows during surges, COVID surges. 1910-502R. I believe it would be helpful to include standardized elements of review for determining work-related causation for COVID recordability. I agree all with B1 through 10. C1 through 2, C1.2, if utilizing exemption notification rules for teleworkers, vaccination status for the calculation of those percentage. I believe those teleworkers must work at least the majority of time on site. Otherwise, it should not be included in the vaccination calculation as a percentage. C2.3A, I think OSHA should minimum gather data on employee medical removal policies related to forced sick leave regarding reporting outbreaks and fatality hospitalization investigation. We support medical removal that is paid leave for COVID-related illness or quarantine. As noted, I have no doubt about COVID susceptibility increases with pregnancy and affect minorities more adversely. Specifically, having choices that force pregnant healthcare workers to use on sick leave when infected with COVID essentially lessens that time what that worker has with a child, and that should not be in the interest of any healthcare employer. It is also wrong for employers to claim that in healthcare, we have an interest in health and allow asymptomatics or even symptomatic carriers in your work unit without isolation. It makes sense to support employer medical leave for isolation and quarantine. And C3 and C5 to benefit data sources. I support OSHA seeking information and data on cases, illness, hospitalization, fatalities that are subject to the final rule. Since VHA workers are the federal and a very large cohort, I believe it would be helpful for OSHA to include employee data collection to include VA-specific illness, hospitalization, fatalities surrounding the frequency and severity of distribution. I thank you so much.
Thank you very much for your testimony. Right, as for those of you who haven't been here, and what we will do now is the OSHA panel will have approximately 15 to 20 minutes, and the OSHA panel will first ask questions, and second, if any attendees wish to ask a question of these panelists, please raise your hand in the chat function or push *3 if you're on a telephone. So if the OSHA panel may begin now.
Thank you, Your Honor. This is Dave O'Connor with OSHA. And thank you, Ms. Rodriguez and Ms. Burke, for your testimony this afternoon. I'd like to touch on some of the comments you included in your written comments. You indicated that AFG believed that there should be a requirement to investigate whether workplace conditions contributed to a case. And I was wondering if you had some specific measures in mind that employers would be required to implement to address that, or whether it was a general review of the effectiveness of their COVID-19 plan.
Millie, I could, are you going to take that? Go ahead.
No, go ahead. Go ahead. You can go ahead.
Well, sorry, Mr. O'Connor. I think specifically after action reports, and that's what I'm calling it, like investigation, especially for outbreaks, is very, very important when you have 2 or more in a given work area. Because like that's the point of safety committees and so forth, is to see if you can mitigate risk. Specifically. And so things like when you have an outbreak, if you were an OSHA inspector, if I was an OSHA inspector, for example, if the facility wasn't testing or decided to optimize, not optimize staff, had you had an outbreak in that area before? Secondly, if you failed to isolate and the community transmission, for example, was like 25% or whatever it is. A lot of employers, particularly, I have noticed, don't actually sit down and do the math and say, well, what are the odds? Basically, if the community transmission is like 25% and I have like 20 workers in a given work area, I feel like the CDC guidance kind of lended itself to just throwing up their hands and saying, well, we just don't have the workers. When in fact, I think OSHA needs kind of to force that conversation a little bit. You may not have the workers, but you don't have 5 workers that could do an administrative task for 5 days, is what you're saying. That kind of thing. I think that would be helpful, specifically for preventing future outbreaks. Millie?
No, I think you hit it right on, MJ. So our thinking was more along the lines of being part of a overall hazard assessment to see how effective programs are, so that as things are being counted, we're not trying to say that only things that are work related would be counted in any kind of way. It would be more of a general overview and assessment of whether the measures that are in place are actually being effective. And so I think that's it goes to the points that you just made, MJ. Thank you.
Thank you. And Ms. Burke, you indicated you had utilized the COVID-19 logs. Were those helpful in identifying outbreaks? How did you approach use of those logs?
Yeah, for me, it had more to do with returning back to the COVID plan. So originally, I think a lot of, I don't know, in this is it's just my feeling as a worker. And I've gone to a lot of OSHA trainers. I always look kind of at the way the analytical framework, like why did the rule exist? You know, I think the rule exists like when you talk about unhelpful working conditions for employees to report these things. What the idea is that the employees should facilitate a safe working. You know, we're partners in this whole business, and so when I talked about the logs, I did use the logs specifically because I wanted to see in certain work areas if we had more prevalence. And if we did, what we could do as an after action to lower that. And for the VA, we look at 1 day loss or more as related that. So that was helpful. I mean, we did create some after action plans for our doctors, and specifically as we surged, we had, even though we had a lot of exposures and people out, what I use the logs for specifically is to create, hey, you know, like on this unit, we had 7 or 8 around this 14-day time frame. That followed some changes in policy. Was it the policy change did we have good worker knowledge through this? Particularly, did we have doctors, for example, when you have a surge, Mr. O'Connor, a lot of times your ED gets full, and so it's in the interest to keep these patients moving up to the floor. But when they do that, a lot of times these people are pooey and they don't put them on restriction, and there's like a lack of communication there. And so we had a couple of outbreaks, and the doctors went back and said, we got to make this a learning point, and then we didn't have any more outbreaks. So I think that was helpful for me, at least.
Thank you. You also indicated that OSHA should require employers to include employee participation in workplace safety plans and the development of those workplace safety plans. And I was wondering if you could explain why you think that's important, particularly with regard to COVID-19.
Oh yeah, because I think for me, the employee knows faster than the employer knows when someone's become infected. And so it can be anything. They know the practices on the work unit specifically. For example, just before we came on the last panel, you were talking, or there was a panelist that was discussing issues of what happens if they don't have any rooms and they prematurely move people who are positive, and there's a question in the end user mind, i.e. the healthcare worker, if they should be doing that or not. So these are the situations in regards to, like, for example, at our monthly meetings, COVID meetings that I bring up. I was like, okay, we had an employee report. This is a safety issue. Why are you moving this person when there's other beds available? You know, or what's the harm of just keeping this guy under, or girl under, respiratory protection for a few more days if they're not moving at a higher level of care? So I think it's important. We have caught at least 4 of employees reporting issues up through me as a safety rep, back through the COVID plan, that were labeled by the safety committee as serious, because our employees, I feel, are actively engaged.
Thank you. We've heard testimony to the effect that there are varying practices with regard to employee screening, patient and resident screening, and visitor screening in various facilities. Could you tell us what your understanding is of current practices, and also what AFG would recommend with regard to requirements for employee, patient, resident screening, and also any screening of visitors?
Sure. Currently, VA has screening, like either a little bit different in every facility, but all CLCs screen, which are their nursing home units. They get the 5 CDC questions, fever, chills, and cough, and do a temperature check. They also do testing of a swab once a pay period for the workers. And as a result, I think that's been helpful. In regards to other areas, we currently have verbal screening. Now, different hospitals have started to kind of phase out that a little bit. I think other hospital systems, not VA specifically, have moved to just like sometimes a phone app, defaulting, other things like that. I'm not so sure. I think people become numb to just saying, yeah, give me the sticker, or yeah, or passing the sign, etc. But basically the rule has to be, you can't be symptomatic when you go into immune compromised areas. So I don't know how you exactly enforce that with visitors, especially going into these areas without like a person like doing a confirmation. But I think that's in the interest of everybody.
You mentioned testing of employees once a pay period. Is that every 2 weeks?
Yes.
Okay.
And it's only in their CLC units.
Okay, thank you. In the emergency temporary standard, OSHA included a requirement for a designated safety coordinator. That being a requirement for the employer to designate one or more workplace COVID-19 safety coordinators to implement and monitor the COVID-19 plan. And that person needed to be someone who is knowledgeable in infection control principles and practices as they related to that workplace. And was just wondering what your perspective was with regard to that requirement. Is it something that OSHA needs to retain in a final rule? Does that serve any useful purpose, or is it something that could be generally applied as a responsibility to the employer without a specific requirement for a coordinator?
I think what becomes important is, like most hospital systems, and have safety committees. And so for us, it wasn't any big deal that the COVID safety committee reports back up to the main environmental care committee. I don't necessarily, if you look in the private sector, the Joint Commission requires environmental care committees, but I don't think necessarily it needs to be a designated person. The same principles would, if you have safety issues specifically regarding MRSA or CDC, I'm just trying to think of anything like Legionella or anything. Everyone has to be wary about what hazard they're dealing with, and just it's most important to be knowledgeable of what the hazard is, I think. And I think it's more important to get your employees involved. And the thing that may not seem good, relevant to OSHA, that I found very relevant, was anytime you modify that policy or plan, you got to retrain your folks. And I thought that was helpful.
And if you had a workplace that didn't have a safety committee, an existing safety committee as you had, would you see a need either to establish such a committee or to have a designated coordinator?
I do think that would be important. Mm-hmm.
Okay, thank you. Your Honor, that concludes OSHA's questioning for the AFGE panel. We appreciate you taking the time to speak with us today.
Right, thank you. We have one individual who's raised his hand, Theo Allen. If we could promote Mr. Allen, and so that he may ask his one question.
He's been promoted.
One question now, some more for the record. And did the code reporter get all that?
Apologies, Mr. Allen, what did you say?
I was just wondering, because I'm not seeing my voice come through.
I can hear you and see you, so I think
Thank you.
Go ahead and ask your question. It'll be.
So my question is, if OSHA were to only protect healthcare workers in this rulemaking, would that, combined with other strategies, be sufficient to solve the problem of burnout and increased violence against nurses and other healthcare workers?
Well, I think, Mr. Allen, this was only about the COVID-19 final rule. So, of course, I'm supportive of workplace violence regulation because it, kills like 50% of workers. But we were allowed, the scope of this testimony, from my knowledge, only had to do with COVID-19.
Yes, thank you. All right, I believe that is our final attendee question. So I'd very much like to thank the panel for your participation and Mr. Allen for your question. Thank you very much. Our next panel, I believe the slide will come up so that everyone can see it. And we have the Manufacturers COVID-19 Prevention Coalition with 2 speakers allotted 10 minutes between them, so 5 minutes each, however the group has apportioned it. We will be, if we could have them promoted at this time, I'd appreciate it.
They've been promoted.
All right. And if the first speaker could identify yourself for the record, and you may begin your testimony.
Good afternoon. My name is Mati Chindori Chininga. I seem to be having a little bit of trouble with my video.
Yes, and we're going to need you to either get closer to a microphone or speak up.
All right, let me see if I can get closer to a microphone.
That's much better.
All right.
Much better.
I will try again to start my video with no luck. I hope that is okay.
That is okay.
All right. Thank you very much, Your Honor. And thank you to OSHA for this opportunity to testify. I will begin now. My name is Mati Chindori Chininga. I am Associate Director of Regulatory and Scientific Affairs of the American Chemistry Council, or ACC. I have been with ACC since the very start of the pandemic in 2020 and have worked ever since to help our industry respond to this pandemic in a manner that helps keep workers safe while allowing for organizations to remain operational and fulfill the critical infrastructure needs of the American public. I'm joined today by Eric Kahn of Commercial Carey, who will not be providing a statement, but is available to answer questions. So for a little bit of background, ACC represents many of the leading companies engaged in the business of chemistry. ACC is committed to improved environmental, health, and safety performance. ACC members apply the science of chemistry to make innovative products and services that help make people's lives better, healthier, and safer. ACC members extend their commitment to the health and safety of their workers through adherence to responsible care programs. So, responsible care companies have an employee safety record nearly 5 times better than the average of the U.S. manufacturing sector as a whole, and almost 3 times better than the business of chemistry overall. From 2010 to 2020, responsible care companies have annually averaged less than 1 OSHA recordable injury or illness per 100 employees. Together, responsible care companies have reduced their recordable injury and illness incident rates by 30% from 2010 to 2020, making significant progress towards the overall industry goal of no accidents, injuries, or harm to human health. ACC is a member of this coalition and is speaking on behalf of chemical manufacturers and similarly situated manufacturers and industrial work sites with embedded medical clinics and internal emergency response teams. Our coalition is a diverse group of national employers and trade associations representing many industries with millions of employees throughout the nation. The common thread amongst us is that we are employers who care deeply about our employees' health and safety. When OSHA issued its healthcare ETS for COVID-19, our company's medical clinics and operations were exempt from the ETS under what we call the screening exemption, which exempts non-hospital ambulatory care settings where all non-employees are screened prior to entry, and people with suspected or confirmed COVID-19 cases are not permitted to enter those settings. We understand that OSHA has reopened the comment period in part to solicit comments on the removal of scope exemptions, including the screening exemption. As explained in our comments submitted to the docket, and as I'll explain here, we do not advocate for such an approach. And we urge OSHA to preserve the screening exemption in any permanent COVID-19 standard. Let me start out by saying that fundamental to all of this, there is a critical distinction between the universe of patients serviced by healthcare personnel in embedded clinics from those serviced by healthcare personnel in hospitals. While nurses, doctors, and emergency technicians working in embedded clinics, for example, in manufacturing facilities may be professionally equivalent to their hospital counterparts, there is a fundamental difference between the clientele treated. Hospitals are designed to accept COVID-19 patients. Embedded clinics are not. In fact, precisely the opposite. Employers have had systems in place for over 2 years now to prevent employees from reporting to work if they have or are suspected of being infected with the coronavirus. So the healthcare personnel at embedded clinics are providing care to a universe of employees who already have been identified as unlikely to have COVID-19. Of course, this does not mean that employees who are infectious with COVID never enter the workplace. We recognize that workplace policies designed to keep infectious employees out are not 100% effective, particularly because asymptomatic or pre-symptomatic employees can be unaware of their COVID-19 positive status. But this situation remains very different from hospital settings that draw people with COVID-19 in. And beyond that, even when COVID-19 does make its way into the workplace, the services provided at embedded medical clinics are fundamentally different than those that are provided at hospitals. Embedded clinic healthcare personnel simply do not treat COVID-19, whereas healthcare workers in hospitals do. So with that, I'd like to share some of our key positions. To start, we want to emphasize that the screening exemption is effective in excluding suspected and confirmed cases out of our embedded medical clinics. Our screening and bearing data show that far fewer employees in medical clinics contracted COVID-19 than employees outside the medical clinics, which is also true of the emergency medical personnel in medical clinics. We gathered information on screening methods, and these included, but were not limited to, self-assessment checks, no-touch temperature screenings, COVID-19 testing, screening signage, and paper and electronic questionnaires. We understand OSHA is very, very interested in data, so I'll share some of that with you. Which we also include in our comments. Our one employer reported that for one of its sectors, which is about 25,000 employees, of which there are about 15 total staff in health services, that from March 20 to April 2022, it had approximately 4,000 total confirmed positive COVID-19 employee cases, with 0 total medical personnel who contracted COVID-19 from the workplace. This is despite almost 7,000 total number of visits to the medical clinics during this time period. The employee has been screening and barring using a questionnaire that includes questions about COVID-19 symptoms, and exposure, and has refused entry due to failed screenings almost 20 times. Within a different sector, at another site, the site reported that it had between 4 to 7 employees or contractors during the pandemic, with 0 exposure to a COVID-19 case or any positive cases amongst the medical staff. Another employer, one doctor, who's a contractor for one of the largest sites of a major manufacturer, reported that there have been 0 work-related COVID-19 cases amongst his medical staff in over 4,000 encounters at his two embedded medical facilities since OSHA issued the healthcare ETS in June 2021. In fact, the doctor reported that he has stacks and stacks of completed screening checklists, and despite many employee clinical visits, he believes no COVID-19 cases came through his clinic. The site
I just want to interject here for a minute. You have 1 minute left.
Fair enough. The site has not had any health professional have a positive case due to a workplace exposure. So I guess just moving along, another point that we want to make is that there's no scientific basis for elimination of the screening exemption. We understand that OSHA may be considering eliminating the screening exemption based on a concern that screening does not detect the entire universe of potential infectious persons, because it may not identify asymptomatic or pre-symptomatic individuals who are unaware of any recent context. However, when OSHA issued its healthcare ATS in June 2021, it was already aware of this potential risk. And while certainly the Omicron variant has shown to be more transmissible than previous variants, there does not appear to be any scientific evidence to suggest that it caused more asymptomatic or pre-symptomatic cases. The effectiveness of screening now is essentially the same as it was back in June 2021. Another point that we want to raise.
You're out of time. I'll let you wrap up right here in the next 15-20 seconds.
Sure, no problem. So I guess one of the most important issues that we want to raise is that there is no significant risk of COVID-19 transmission in embedded clinics. We understand that OSHA may be considering eliminating the screening exemption, but it is not at all clear that OSHA would have legal authority, the significant risk standard to impose compliance with the permanent healthcare COVID-19 standard on embedded medical clinics and not healthcare standards. A resounding common thing amongst many members of our coalitions is that our embedded medical clinics are not traditional healthcare facilities. So therefore, we feel like the clinics simply should not be subject to the same rules that hospitals are, because the population served by the clinics is generally limited to employees, and the population around the clinics is limited to selected authorized visitors as well as employees. And
all right, thank you.
Thank you.
We appreciate your testimony.
Thank you very much.
You're very welcome. At this time, I will invite the OSHA panelists to ask questions, and anyone from our attendees who would like to raise their hand or press *3 may do so to get in line for questions. Thank you.
Thank you, Your Honor. This is Dave O'Connor with OSHA. Thank you, Ms. Chindori Chininga, for testifying this afternoon. You had indicated that employers are using a range of different measures to screen employees, including self-assessment checklists, temperature screening, COVID-19 testing, signage, and questionnaires. I was wondering if you had any sense of the frequency of each of those various methods of assessment, and if so, if you could share that. And also with regard to any self-assessment checklists, questionnaires, things of that nature, if you had any information about the specific questions that are being posed there that you're able to share with us.
Well, we're always happy to provide additional information, and I invite my my peer here, Eric Khan, to answer as well. But I think that we'd be more than happy to provide additional information in that regard. Eric?
Yeah, I think that's, we can go back and do some surveying among the participants in our coalition. It's hard to say sort of the balance or the percentage that use, you know, the temperature screening versus a questionnaire. Some that use a questionnaire via an app on a cell phone. Others use, you know, signage at the entrance. But we'll try and get a handle on sort of the percentage that are using which types of screening.
Okay, thank you. And with regard to the screening, there are a number of fairly non-specific signs and symptoms associated with COVID-19, things like cough and fever. If a worker reports one of those non-specific signs and symptoms, what is the typical response to that? Are they going to the embedded clinic to be tested or for further evaluation, or is there some other measure that's taken in those instances?
That is probably the biggest distinguishing factor, David, among these embedded healthcare clinics at a manufacturing site and the types of healthcare facilities that I think this standard was designed for, is those people would not be reporting to these clinics, right? We, in general, even before the pandemic, the purpose of these clinics is to treat occupational injuries, right? Is to somebody who's got an abrasion, or a particle gets into their eye, or a strain or something like that, to be evaluated, basically triaged at these medical clinics to see if they could receive first aid or some minor treatment to be able to return to work, or to make a determination about what type of more substantial treatment is needed. We're not treating sort of general health issues like colds and flu and things like that. Those folks, even before the pandemic, were not intended to report to these clinics. During the pandemic, especially, those were made sort of mandatory rules that those folks don't report to the clinic. If you are experiencing something that is akin to a COVID-19 symptom, and it is not at all related to an injury at work or an incident at work, you are not permitted to report to the clinic. And that, by policy, you are sent to either get tested or to get treatment at a more traditional healthcare facility that treats general illness.
So would I be correct in understanding that with regard to the embedded clinics that you're speaking for today, none of them are providing COVID-19 testing?
That's right.
Okay, thank you. That is all I have. I will turn it over to my colleague, Charles McCormick.
Hey, thank you. So I really just had a very quick question. I just wanted to ensure that the study that you mentioned on embedded clinics in the chemical industry, where you're finding 0 cases among all the healthcare workers, if you could make sure that that study, along with any data or data tables with it, are put into the record for us. Thank you.
And just for clarity, I'm not sure that Maddie was talking about a study as much as data reported by individual members of the coalition or individual members of their trade association. But we've collected a lot of data from our employer participants, and we'll share what we're able to.
Thank you very much.
Thank you.
Hi, this is Amy Tryon from the solicitor's office. I can't even say the name of my own workplace. I have just a couple of questions. I want to follow up a little bit on this. If somebody shows up at the embedded clinic with a sore throat or a runny nose, and they are, at the door, tell me if I'm saying this correctly, or share with me what does happen. They're at the door to the clinic, and before they go in, they are asked to take this self-assessment, and they check off, I have a sore throat. What happens then?
So in general, most of these types of facilities that we're talking about, large industrial sites, big manufacturing facilities, are doing screening before employees show up to work, period, not just before they show up to the clinic. And in most instances, there is a double screening that happens. So you're screened before you enter the workplace, period. And then secondarily, if you're reporting to the clinic, there is an additional screening to be permitted to enter the clinic. And in those instances, everyone's been informed that you're not to report to these clinics for sore throats, runny nose, things that are, cold and flu type symptoms. But if they did, and we have some examples where employers did report that they did screen people out and turn them away, if they reported any of those symptoms, they would be turned away from that clinic and instructed what to do. And that would generally be to go get a COVID-19 test at a healthcare facility, or a home test, or at a pharmacy, and to seek treatment and to speak to either a clinic or a healthcare professional outside of the workplace to address that. It's not to be handled by these occupational clinics in the embedded clinics in a manufacturing setting.
Okay, so you're saying that the screening occurs when people arrive to work for the day, not when they go into the clinic specifically?
It's double. I would say this, that almost every one of the manufacturers that we're working with have screening before you enter the facility at all. All of them have additional screening before entering the clinic, because that was part of because of the healthcare ETS that set that to avail yourself of that exception. So in most cases, there's double screening.
Okay, and then so they would be physically turned away from the clinic if they have a symptom and sent
Yes.
someplace else. All right, thank you. I have another unrelated question. Well, I mean, it's all related. To Ms. Chininga, you had mentioned that there were these thousands of positive cases that none were work related, and we were wondering if you could share how were cases traced in order to rule out them being contracted to work. How did you demonstrate that they were not work related?
Sorry, can you hear me?
Yep.
Yes.
Excellent. I wasn't sure. Computer issues. However, we would be more than happy to provide data to outline exactly how it is that we came to that conclusion. If that will work for you.
And I can provide a little bit more context. I think the report of the thousands of cases were among the general employee population. What was remarkable about that data point was that despite this is a very, very large employer with thousands and thousands of employees, tens of thousands of employees that had those cases among their general population, I think what Maddie reported was that there were none, but not just work-related, but no cases among the embedded medical staff at one of those facilities that had, a meaningful number of positive cases among employees, but none among the medical staff. So it's not about work-relatedness or not. In that context, they just weren't getting infected. And that was the point, was that this is not a high-risk exposure in these medical clinics, because just look, they seem to be safer in these medical clinics than they are just in the general population.
Right. Okay, thank you. That's helpful. But then in that case, it wouldn't matter whether the general population, all that matters for the purposes of the healthcare workers in the embedded clinics is whether they might encounter positive cases among the employees. It doesn't matter where those employees contracted it.
Whether they encounter it, and then whether by virtue of those encounters, whether they are contracting it. And in this instance, we think the screening is very effective, despite the numbers among the general population. We don't think they're getting into the clinics, but even if they are, transmission is not happening for other reasons that we identify in our comments. We think we've screened those folks out successfully, but we all know about asymptomatic and pre-symptomatic cases. Despite that, because we're following good, smart protocols that are, I'm certain, less rigorous than a hospital-centric standard like the healthcare standard, but adhering to CDC recommendations for the types of brief interactions that our embedded clinic medical professionals are having. The transmissions are not happening, regardless of whether those asymptomatic or pre-symptomatic cases are getting in. We don't think they are, but to the extent they are, we're not seeing unusual or material transmissions to the medical professionals. And that's why it is so different than what's happening in the hospitals.
Thank you. I don't have anything else.
All right. Is that the final, pardon me, question from the OSHA panel?
Yes, that concludes OSHA's questioning of the panel. Thank you.
All right, thank you. Before we have one question from Mr. Allen. Before I have you promote Mr. Allen, I'd like to ask if Charlie Hardig is in the attendees, but not listed under that name.
I think Charlie is not able to join me for the next panel. Apologies.
Okay. All right. Then we will move to Mr. Allen. If we could promote Mr. Allen so he could ask his question.
He's promoted.
Thank you, Mr. Khan. Thank you, Your Honor, and thank you, Mr. Khan. My question does not pertain solely to manufacturers, but you can also explain it with regards to your other clients. If we have the screening exemption, why would we need special exemptions such as embedded clinics or dental offices, etc.?
Well, the position of the manufacturers that I represent in this coalition is that the screening exemption should be preserved. The outpatient ambulatory care exemption for screening out patients. They're not asking for a complete exemption from the standard, just preserving the screening exemption that was promoted and used successfully in the ETS.
All right. Thank you. So next, we will move on to the Retailers COVID-19 Prevention Coalition. Mr. Khan, you are part of that panel, or you have become?
Your Honor. Yes, Your Honor, and I'll present the statement. Charlie was not able to join us.
All right, thank you. You may begin, and you have 10 minutes.
Thank you, Your Honor. My name is Eric Kahn. I'm the chair of the OSHA practice at Kahn Maciel Carey, and I'm counsel for the Employers COVID-19 Prevention Coalition. I'm proud to be here today speaking on behalf of members of our coalition in the retail industry that operate pharmacies or provide other healthcare services within their retail locations. Our members represent the largest chain retail pharmacies, national grocers, and other independent grocers. These organizations, as well as small regional pharmacies and grocers as well. These organizations, as well as their trade associations that are part of our coalition, represent thousands of stores in every state in the country, with a combined workforce measured in the millions. The retail pharmacy industry has played an instrumental role in the fight against coronavirus since its inception. Pharmacies have administered more than 234 million COVID-19 vaccines to date. In fact, 2/3 of every COVID-19 vaccine administered today are provided at a retail pharmacy. Critically important to the protection of the underserved community, more than 40% of those vaccinated at pharmacies were from racial and ethnic minority groups. And the pharmacists themselves are vaccinated. Since the rollout of the safe and efficacious COVID-19 vaccines last year, the pharmacy industry has become one of the most vaccinated industries in the country. The vast majority of pharmacists, upwards of 90%, are fully vaccinated. In addition to the tireless work of pharmacists to get the nation and themselves vaccinated, retail pharmacies have become a bedrock of the nation's COVID-19 testing program. Pharmacies provide more than 20,000 COVID-19 testing sites nationwide, many of which represent the only place available to get a test in many rural or other underserved communities. The retail pharmacy industry strongly believes that OSHA should not apply its COVID-19 healthcare standard to retail pharmacies. While these retail pharmacies provide vital healthcare services every day to millions of customers, this workforce is not exposed to the coronavirus in any way equivalent to those healthcare workers at hospitals or nursing care facilities for whom that standard was designed. OSHA's COVID-19 standard is designed to protect workers who are in close contact, providing direct acute patient care to known COVID-19 patients over an extended period of time, and those patients who are experiencing severe symptoms of the illness, such that they required inpatient admission to the hospital. This kind of exposure is simply not present in the retail pharmacy setting. Certainly not for pharmacies that just offer vaccinations, whether they be COVID-19 vaccines or any other, and not even for pharmacies that offer COVID-19 testing. Therefore, we request that OSHA expand the existing exemption that precludes coverage for the dispensing of pharmaceuticals in non-hospital settings, an exemption that was in the ETS, to expressly also preclude all retail pharmacy activities from coverage of the standard. At the very least, we support the position that the manufacturers raised at the very least about maintaining the existing exemption for ambulatory care settings where known or suspected COVID cases are screened out. I'm going to talk about just a few of the reasons why we think this exemption is important and appropriate. First, the healthcare-related services provided in the retail pharmacy setting do not pose a sufficient risk to trigger coverage under OSHA's hospital-oriented standard, including whether it's the administration of vaccines or the providing of COVID-19 testing. These activities don't pose a risk of exposure to COVID-19 at a level anywhere commensurate to the risk of healthcare workers in hospitals. Accordingly, applying the breadth of this COVID-19 hospital-based standard with its requirements that were designed for long-term acute care, inpatient service to severely ill patients to retail pharmacies would not be appropriate. There is nothing inherently risky about providing vaccinations. Indeed, there's no greater risk of COVID-19 transmission in the delivery of vaccines than the exchange that occurs between a pharmacist and a customer when handing over and dispensing prescriptions, or even the interaction between that same customer and a point of sale clerk once that patient leaves the immunization area and checks out after having shopped for generic retail products in that same store. The CDC has made crystal clear that people with suspected or confirmed COVID-19 should not get vaccinated until they have completed their applicable isolation and quarantine periods. Those requirements are communicated to vaccine seekers through every vaccine appointment system in the country and every set of paperwork that's been generated for walk-up vaccine clinics. Every individual getting a COVID vaccine knows that they are not to arrive and present themselves for vaccines if they are COVID positive or suspected COVID positive. Despite that, the screening does take place for vaccination services. For that reason, those interactions are no more likely to involve exposure to a COVID-19 positive individual than any other interaction in a retail setting or any other interaction between any employee and a member of the general public in any work environment, retail or otherwise. Second, big difference between what happens in delivering vaccinations and the type of care that's provided in a hospital is that this service takes generally 5 minutes or less. The entire immunization process, including answering questions, preparing the bandage, administering the shot, filling out the card, and excusing the patient from the room. It is a very brief interaction with someone who's no more likely to be COVID positive than any other interaction in any other work setting. Third, the CDC has issued very thoughtful, tailored infection control guidance for pharmacies to follow for administering vaccines. Across the board, every pharmacy and grocery member of our coalition, which represents essentially the entire industry providing this service, reports that they adhere to those CDC's recommended practices applicable to administering vaccines, including masking and other protocols. But to be clear, those recommendations are, for obvious reasons, a lot of which we're talking about today, are less rigorous than the hospital-centric requirements of OSHA's COVID-19 healthcare rule. We'll talk a little bit about testing as well. In terms of testing, the retail pharmacy industry has worked hand in hand with the Biden administration to develop and implement COVID-19 testing programs across the country that have helped millions and no doubt saved thousands of lives during the pandemic. We do appreciate and we recognize that unlike the population that presents itself for vaccination, the universe of customers who present themselves for COVID-19 testing likely includes a higher percentage of individuals who are potentially infected with COVID-19. But notwithstanding that risk, or notwithstanding that fact, the risk presented to the pharmacy staff that administer testing does not come anywhere close to the risk presented to healthcare workers providing extended direct patient care in hospital settings to severely ill COVID-19 patients. First, the entire time it takes from start to finish to administer a COVID-19 test, the entire interaction between the tester and the individual being tested is less than a minute, and on average is closer to 30 seconds. Second, the tester is, like the individuals administering vaccines, protected by the equipment and protocols recommended by CDC for that specific task, including at a minimum gloves and a surgical mask, and typically, in addition to that, face shield or goggles. And the proof is in the pudding. There simply has not been an epidemic of infections and outbreaks involving pharmacy staff. Regardless of any analysis of work-relatedness, like we discussed before, just taking every case as an equivalent case, every retail pharmacy member of our coalition that tracked infection rates by job function reported fewer infections and lower infection rates among their pharmacy staff than among their general employee population. And indeed, data from one of the largest national retail pharmacy chains in the country reveals that general customer service associates have been infected, whether work-related or not, at rates 4 times greater than pharmacists. Just as remarkably, pharmacists among our coalition members consistently saw lower rates of infection among their pharmacy staff than compared to the general infection rates in their surrounding communities. So in other words, the pharmacy staff administering vaccines and conducting testing have been safer in those roles than the general population. That is no doubt the reason why OSHA excluded retail pharmacies from all of the target lists in the various iterations of its COVID-19 National Emphasis Program. Those lists were filled with healthcare NAICS codes and filled with retail NAICS codes, but conspicuously absent from every iteration of that was retail pharmacies. The reason is because it is not a high-risk location. These are not high-risk services, and the data bears that out. The last point that I want to make here, in addition to encouraging the agency to consider our written comments, is that many, but not all for sure, but many of the retail pharmacy members of our coalition, particularly those in smaller regional or even one-off pharmacy locations, report that if they are faced with the hard choice of coming into compliance with a hospital-centric regulation at their retail store or suspending their COVID-19 testing programs, they would opt out of the testing service. A smaller but not immaterial percentage of those responders indicated concerns about even continuing to provide vaccine services if that meant being covered by OSHA's COVID-19 standard that was clearly written and intended for hospitals and settings like that. So we would just say here that please, OSHA should not take any action that disincentivizes or hampers this vital industry from continuing to provide these incredibly important services that are essential components of the nation's path out of the pandemic. So I encourage the agency to consider our written comments as well, which get into greater detail about these points, as well as an explanation of why the rigorous hospital-centric requirements of this standard would be technologically and economically infeasible if applied in a retail pharmacy setting. And I thank you again for the opportunity to provide this oral testimony today. And I'm happy to answer any questions or to take your questions and requests back to our coalition and provide detailed responses in a post-hearing written submission. Thank you.
All right, thank you. Testimony. I'll first invite the OSHA panel to ask any questions, and then if any of our attendees wish to, please use the raise hand button and we will call you in turn. All right, you may begin.
Thank you, Your Honor, and thank you, Mr. Khan, for your testimony. Just wanted to better understand your position with regard to a request for an exemption for COVID testing performed in retail settings. That is based, if I understand correctly, on a belief that the exposures that occur in those settings are low risk, and that you also had evidence that infection rates were low among pharmacy staff. Is that correct?
There's a variety of reasons. Those are certainly chief among them. In addition, we think there are some major bars, technological and economic bars, to being able to implement the full breadth of the requirements of the standard. Distancing among them. These are settings that are not conducive to significant distancing and barriers. The requirements around more substantial respiratory protection, N95s, which would kick in many circumstances under the standard, is different and more substantial than what the CDC has recommended for these tasks. And a variety of other those would be challenging to implement in the retail setting, but as a reason why that should not be extended into these settings, that's exactly right, is that the reason why we have developed this standard, and we understand completely why OSHA developed the emergency standard and is working to make that a permanent standard, is that there is great risk of transmission in that hospital setting where you have extended duration and close contact exposures with seriously ill patients. That interaction just isn't happening in this context, even in the context of testing, where that test interaction is 30 seconds or less, well-protected test taker in a brief interaction with perhaps a symptomatic individual, but not so symptomatic that they are in need of admission to a hospital, or otherwise they would be at the hospital and not at our pharmacy.
And you indicated that the duration of the test administration is less than a minute. Is that the total time of interaction, or do the pharmacy staff spend additional time in the room or in the vicinity of the individuals being tested?
That's how it was reported by the pharmacy participants, that is the entire interaction with the testee. That there, may be forms that they're filling out on their own, but the interaction between the pharmacy staff, the interaction in the pharmacy setting, is less than a minute.
And what protections are in place when these tests are being administered? What personal protective equipment or other measures are in place to protect these employees?
Yeah, consistent with CDC recommendations for this type of task, the pharmacists generally are in surgical masks. Some voluntarily would wear more protective face coverings, N95s or KN95s, but at the very least, surgical masks, gloves, and typically a face shield and/or goggles.
And is this typically performed in a separate environment from the rest of the retail setting? I know in certain cases they have drive-up windows, but are there separate rooms or other facilities that are in place?
Yeah, it's a very much a mixed bag, and depending on the the type of pharmacy, the type of community that pharmacy serves, many have set up outdoor access to both testing and vaccinations, but many could not do that. Many have sort of an individual small patient room for those tasks. Others have set up sort of barriers that create a demarcated area for vaccination or testing, although it may not be a floor-to-ceiling wall. So it is different in every setting, but it is, to answer the question, yes, they are taking steps to isolate those tasks from the store, as well as from other areas of the pharmacy, for example, where they're dispensing pharmaceuticals. Now, whether that's a room with a closed door or a separate setup with barriers that may not go floor to ceiling, they are intending to and have designed some effort to isolate those tasks from the rest of the store.
Okay, and you wouldn't have a situation where you had a line of people who were waiting to receive the testing? Is there some separation of those individuals from other individuals in the retail setting or others who are attempting to be tested?
You certainly could have that, and we have many of our members have set up, I'm sure you've seen this, with the markings on the floor to try and encourage and require distancing between customers who would be waiting in line to get the testing, and efforts have been made to the extent it's feasible by the design of the store to keep that line or that potential line separate from the retail area. But efforts are made to encourage distancing, usually with signage or floor decals. But staff would not be, that's not in the pharmacy staff area, or those interactions would not increase the period of time between those interactions between customers and staff. Pharmacy
okay, and it wouldn't be a situation where it would generally be possible to, for example, have these people waiting outdoors or anything of that nature?
I certainly, some of my clients and some of the members of this coalition encourage that, and they have systems where they can retrieve somebody, go outside to call a name. But just as often, these folks are not waiting in line; they're doing their shopping. Right? We see that when the name is called, that it's your time for the vaccine or for the test, that you find them with a basket, with a cart, with some of their shopping. So they're not, we're not forcing them outside, but we're seeing that that as well.
Okay, thank you. And I would add that OSHA would welcome any evidence you have regarding the rates of infection among pharmacy staff relative to other staff or to the community at large. That would be very helpful to us.
Thank you.
That concludes questioning from the OSHA panel. And again, thank you, Mr. Khan.
Thank you.
Right, thank you. We have one raised hand, and that's Mr. Allen. If we could have him promoted, please.
He's promoted.
Thank you, Your Honor. And while I have some other questions for you, Mr. Khan, I understand that your pharmacies vary, but can you do a survey or something, and including your post-hearing comments, how long for the testing, not the vaccinations in particular, the customers wait to get tested, the testing results, finding out, and get treatment, explain options, etc., and are inside the pharmacy?
Yeah, so we've gathered some information from our pharmacy participants on that issue, and the interaction between pharmacy staff and the testee has the consistent responses we got were an average of 30 seconds. Some indicated a minute, so somewhere in that range of 30 seconds to a minute. I'm not aware of any of our participating pharmacy participants who have testees wait around for results there in the store. These are generally PCR tests that we're talking about, and those results are, that I'm aware of, I think 100% communicated by way of an electronic, an email or access to some portal to get those results. That you don't have individuals waiting around for test results, but we'll certainly confirm that and update. That is not accurate. I'll update that in a post-hearing submission.
Right. Well, thank you very much for your testimony here and for your question as well, Mr. Allen. And what we're going to do now is take a brief 10-minute break before we go into our last two panels, which will be approximately 30 minutes each, exclusive of questioning. So if everyone would please be back here at 3:10. Thank you. All right, welcome back. We will next hear from a panel, the North America's Building Trades Unions. We have 4 panelists and 30 minutes. So if the speakers could please remember to try to time themselves and keep to approximately 7 minutes, I would appreciate it. Or however you've distributed that time amongst yourselves. So you, is this Ms. Boer?
This is Chris Kane.
Chris Kane, will you be beginning?
Yes.
All right, you may begin.
Thank you, Judge Bland. Walter Jones won't be joining us today, but I will be speaking as a representative of North America's Building Trades Unions. I'm their Safety and Health Director, followed by Travis Parsons from the Laborers International Union of North America, and rounded out by Rosa Greenberg, who is an analyst at CPWR and is also here representing NAB2. Vicky Boer is NAB2 counsel and is available if we get questions that she can help us answer. And with that, I'll get started. I just want to thank OSHA for the opportunity to testify and also urge OSHA to expeditiously issue a final rule protecting healthcare workers from COVID-19. It's of the utmost importance. We do want to talk a little bit about how we think this applies to construction work in healthcare facilities, and that's why we're here today. And I'm going to make a few points that reiterate some of the issues raised in our written comments, and then turn it over to Travis to talk a little bit more about some things particularly that have been raised already in the hearing. So one of the things I think is central to our concerns about construction work in healthcare facilities is that COVID-19 is airborne. We know that, it's unequivocal. We've known that from the beginning, but it's been a long time until it was recognized as airborne. And the physicians who testified earlier in this hearing made that crystal clear. They demonstrated how areas that have been occupied by an infected person can remain a hazard over time, even after an infected person has left that area. And that really supports that there's evidence of risk for individuals who may be in some type of proximity to infected persons. And it's really not about this applying to the construction industry as a whole. You know, we think this applies in a very limited and narrow scope to construction work carried out in areas where the risk exists in healthcare facilities, and that's not the entire healthcare facility. Our concern is really when we have construction workers and contractors in patient area or patient occupied areas, or where there may be other individuals that are infectious, and where they're sharing the same air. That could be in the hallway where they're replacing, say, an electrical outlet, working on piping systems in the hospital, both that carry water and wastewater, as well as medical gas, and in the HVAC systems, the ventilation systems of hospitals. Construction contractors are often brought in to work on those areas, and where they're not completely isolated in that no airflow exists between where we're concerned is when we have airflow between areas where there are potentially infected and patients or other individuals, and the workers performing those construction tasks are the highest priority, we think. We acknowledge, the same way NECA raised in their testimony yesterday and in their comments, and that, you know, when we have workers in a completely new construction project, could be a wing that's unconnected through the HVAC system to existing hospital space, or a parking garage outside of a hospital area, and workers are not in proximity to workers or to people who are infected, that this standard, as it's written for healthcare facilities, shouldn't apply to that construction work. So we think that the universe of work that it does apply to is not large, but it's important. One of the things that really this hinges on is excellent communication. You know, when the ETS came out, there was a requirement that essentially the host employer or the owner of the healthcare facility or who's ever operating the healthcare facility needs to be in good communication with the contract employer. And this communication really does have to extend to where the risk exists, where the hazards exist in a healthcare facility, and where they don't. So when a host employer can communicate and demonstrate that the area where the work is being done is truly isolated from this airborne hazard, then the standard should not apply. But where workers have to be in areas where it can't be isolated, the standard should apply to construction employers. Obviously, construction employers don't necessarily have to do all of the work and patient screening and that type of thing that host employers would have to do in medical facilities. So there does have to be that communication and understanding of what parts of the standard actually do apply to construction employers. And just before I wrap up and turn it over to Travis, one thing that is really important is that construction workers need to be notified when they've been exposed to someone who has COVID so that they can take measures to monitor for symptoms and do whatever else needs to be done. That communication, that reporting, as well as record keeping for construction employers who are covered under this standard. These things are occupationally contracted diseases in settings where the exposure occurs. So in work settings where the exposure occurs. So that needs to be part of the coverage for construction employers in the final rule. And with that, Travis, I'm going to turn it over to you. Travis is going to talk about some of the concepts that were floated yesterday related to how some different types of work are done in hospital settings and healthcare settings, and what are some of the rules that govern that work. So, Travis?
Okay, can you hear me?
Yes, and for the record, this is Travis Parsons.
Yes, Travis Parsons with the Laborers Health and Safety Fund of North America. Thank you, OSHA. Thank you, Chris, for your framing the subject for me very well. I'd like to thank OSHA for the opportunity to testify today on this important standard for the healthcare industry and its entire workforce. My name is Travis Parsons, and I am the Associate Director of Occupational Safety and Health for the Laborers Health and Safety Fund of North America. I am also a member of the NAB2 Safety and Health Committee, where I work with Chris Kane, who just testified, and 13 other building trades unions. My background is mainly in industrial hygiene and worker safety and health. The Laborers Health and Safety Fund of North America is a joint labor management fund that supports the members and signatory contractors of the Laborers International Union of North America, LIUNA. LIUNA members are performing construction, demolition, renovation, and maintenance activities inside hospitals across this country every day. I am speaking today on behalf of LIUNA and NAB2, the Safety and Health Committee. We strongly support the previous comments from Chris Kane, this panel, and my other union colleagues. I would now like to hit some additional high points, and in the interest of time, I'll be as brief as possible. We support OSHA's proposal to expand the coverage under any promulgated final rule to include construction work taking place inside the healthcare setting. The standard should apply to construction employees working in areas which there is a potential for exposure to contaminated air of any kind by COVID-19, even if the exposure is brief. Just like other healthcare workers, construction workers that are performing work indoors inside hospitals, that setting will share air and need adequate protections from COVID-19, as Chris just portrayed. This type of construction work is specialized and totally different from a typical construction industry setting that we're used to. The workers we speak of today are potentially exposed to COVID-19 through suspected or confirmed COVID-infected patients, other hospital staff, co-workers, visitors, and contaminated air through shared ventilation. As pointed out several times in previous testimonies, and we can't say enough, it is recognized that SARS-CoV-2, the virus that causes COVID-19, is airborne, meaning it's highly transmissible through the air and through ventilation systems. As we heard yesterday, there are recognized industry practices such as the well-documented infection control risk assessment process that are typically followed when performing construction work in a hospital setting. To us, that's a good thing, and we think the construction contractors and workers working in healthcare settings are familiar with having to do and adhere to infection control precautions and procedures through the ICRA process. In my opinion, This will help with compliance with this OSHA rule. ICRA precautions are enforced through the Joint Commission, what's known as the Joint Commission, formerly known as JCO. They administer voluntary accreditation programs for hospitals and other healthcare organizations across the country. They do have a large base of hospitals, but not every hospital is covered by ICRA processes. ICRA, again, I got to reiterate, is a voluntary industry practice, and it's a very useful tool, but it is not by no means a substitute for enforceable OSHA regulations. Just as the AFL-CIO testified earlier to the importance of having OSHA regulations to protect healthcare workers rather than relying on CDC guidelines. Guidelines are just unenforceable when it comes to the law. It's critical that construction employers working in these facilities also be assured legally enforceable protections. As pointed out earlier by Chris Kane, the ICRA process's intent is to protect patients, not necessarily workers. And it is OSHA's duty to ensure safe and healthful working conditions through promulgating enforceable standards. So ICRA came about several years ago to really protect patients from what's called nosocomial or hospital-acquired infections. It's not really meant to protect the workers. That's OSHA's job to protect the workers, and then they need to work with the ICRA process and the hospital administration.
Mr. Parsons?
Yes.
I'm sorry, I don't want to interrupt you. We just need you to slow down a little bit for the court reporter.
Oh, no problem. I'm almost done, so thank you.
Okay.
In closing, I would like to reiterate that construction work within healthcare facilities is generally specialized work and therefore performed by a limited number of specialized contractors that should have in my opinion, have no problem complying with the standard as written. Thank you, and I'll take questions.
All right, thank you. Who will be speaking next?
I'll be speaking next.
Is that Ms. Greenberg? Okay, if you would just identify yourself for the record and then please begin.
Thank you. My name is Rosa Greenberg. I'm a research analyst with CPWR, the Center for Construction Research and Training, and appearing on behalf of NAC2. Thank you for the opportunity to testify today. We believe that construction workers face significant risk of exposure to COVID-19 when working in healthcare settings. First, as discussed, we are concerned about construction workers in areas where they are potentially exposed to patients and staff with COVID or to contaminated air. Because COVID is airborne, there's every reason to believe that employees performing construction in areas of potential exposure bear risks, just as anyone else working in those areas does. Second, as discussed in our comments, there are demonstrated examples of COVID-19 outbreaks among construction workers in healthcare settings. Moreover, these examples are almost certainly an undercount of the true toll due to limitations in publicly available workplace outbreak data. In our research, we found that amid the states that provided sector-based workplace outbreak data, only a subset reported on the construction industry, and even fewer reported sufficient detail to allow the identification of construction worksite locations. Although the data were inadequate, in states that did report this level of detail, such as Colorado, we were able to identify relevant construction and healthcare setting clusters, which supports our assessment that construction workers do face significant risk. The current gaps in workplace outbreak data also underscore the importance of requiring employers to record incidents and their locations. Including location data is especially important for construction, since many workers' physical work sites do change regularly. This data would strengthen our ability to track critical trends in COVID morbidity and mortality, and thus protect worker safety. This concludes NAC2's presentation. Thank you for your time and your consideration, and we are happy to receive questions.
All right, thank you. As previously, we will first take from the OSHA panel and any other individuals of any attendees, if you'd please raise your hand in the meantime, and we will take you in order. So the OSHA panel may begin.
Thank you, Your Honor. This is Dave O'Connor with OSHA. A question, and this may be for Ms. Greenberg. In NAC2's written comments, you had mentioned the 3 examples of COVID outbreaks on healthcare construction projects. And I was just wondering if you had any information you could share either now or in a post-hearing submission that would reflect on the nature of those activities, whether they were projects that involved construction worker interaction with other people at that facility, healthcare workers, patients, residents, or interaction in common spaces, anything that would reflect upon the nature of construction worker exposures in those environments.
Thank you for that question, and we will address that in more detail in our post-hearing comments.
Thank you. We have heard other testimony in this hearing indicating that communication between healthcare facilities and their construction contractors is established practice with regard to safety and health measures in particular. That it's incorporated in contracts just wondering if this is consistent with your experience.
I'll answer that. This is Chris Kane. I believe that is consistent. Typically, contracts that are let by healthcare facilities are very formal, and there's plenty of work rules that go along with that. Information is shared about where contractors are to do the work, what areas they're supposed to be in, how they're supposed to do the work, and that's often incorporated into the written contract. I think that's standard procedure, and it's reinforced, I believe, by the testimony by the National Electric Contractors Association yesterday. So part of that is often, what are the hazards that you're walking into, as with any kind of host employer, contract employer situation. And it allows for construction employers to, develop the plans and create the plans they need to execute that work appropriately. Travis, was there anything else that you wanted to add about that?
Yeah, and I apologize for my video not working. Earlier it was working fine, and then when I got promoted, I kind of just disappeared. But I got a nice background, so anyways. But yes, I'd like to add a little bit to that. With multi-employer work sites in construction, we're used to this information sharing and the multi-employer rule. So this is very important. And yes, it is in contracts, all established up front before the work happens. So just reinforce what Chris said, and especially on multi-employer work sites.
And it's not only in the contracts, but it actually happens in practice?
Yes.
Yeah, they have meetings, pre-construction meetings, before they go to work almost every day.
And is that typical of all healthcare facilities that you've worked with, not just hospitals?
I would say it's typical of a construction job.
Okay, thank you. Yesterday, we heard from electrical contractors who indicated that construction work in hospitals is typically sealed off so that the construction operations are basically being performed in airtight enclosures or segregated from the air that is in the healthcare facility itself. Is that your understanding of how these construction operations are typically performed? And is that going to be sufficient to protect construction workers in these environments?
This is Chris. I'll answer part of it. One of the things that we wanted to differentiate about construction work in healthcare facilities, and perhaps particularly hospitals, is we think there's a big difference in a large construction project that's building, say, a new wing or a new healthcare facility or an addition onto a healthcare facility. And typically in a job like that, the site is turned over, so to speak, and it's done more so independently of the host employer. It's not work within the populated facility. So in those cases, we believe that in most cases, this standard wouldn't apply because it wouldn't have operational HVAC systems between patient-occupied areas and the construction work. And there wouldn't be interaction between, say, hospital staff taking care of those sick patients and the construction workers. So that's one side of it. The second part of it is work within occupied areas in a healthcare setting. And that's where it gets a little bit more difficult. I would say that typically the small jobs that require, say, servicing an HVAC unit, working on piping our existing HVAC systems in a hospital, even, probably less likely in patient occupied areas, but maybe close to patient occupied areas, painting operations or reflooring operations, those are a different situation. And in that situation, the healthcare facility may require that these ICRA requirements come into play that Travis summarized. But there are different levels to this kind of protection schema that's called infection control risk assessment. This mechanism or this kind of scheme that's designed to protect the patients in a healthcare setting from hazards introduced by the construction work, and hopefully reduce the incidence of hospital-acquired infections. That's really what ICRA is about. And some of that is done in really high-level air separation containment, but not all of it. So I don't know, Travis, you can kind of take over and talk about how ICRA works and the different levels of ICRA.
Yeah, I'll be happy to do that. Basically, it's a classification system that you end up with 4 different classifications, 1, 2, 3, and 4. 4 being, the most isolated, and 1 being hardly isolated at all for like those smaller jobs that Chris just mentioned. So yeah, you have negative air and you're isolated in barriers in class 3 and 4, especially in class 4. But that's not guaranteed in class 1 and 2 operations, and that's a lot of operations throughout the hospital work we do in renovations. And the ICRA process, just well, you may know, but it's based on risk and type of work that you're doing. So the risk to the patients, the type of patients you're around or not around, and the level of work you're doing and how intense that is. And it's filtered into this matrix that puts out a very prescriptive process of protections and controls. So unless you're in class 4 work or 3, you might not have everything sealed off like was spoken about yesterday.
So, and if you think about the way that dust containment is typically done in construction, a lot of it is about keeping the dust that's generated inside of a construction area from entering the surrounding area. And I think if Travis can't describe this, we can think about it and elaborate it on the post-hearing. But the ICRA system is not about keeping the hospital air out of the construction site. It's about keeping the construction site air out of the hospital when you get to that highest level of containment. So it may be by design that the negative pressure that the construction workers are working under within a level 4 containment is actually drawing in air from the surrounding patient occupied areas. And I might be speaking out of turn, so give Travis an opportunity to correct that idea.
Yeah, I think you're correct, Chris. It really varies in between the classes, and a big percentage of the work is in class 4, where you have that isolation. A lot of it is 1 and 2, and somewhat 3 and 4. And you do a risk assessment based on, like I said, the population you're working in or around, and based on the type of work you're doing to get in those classifications. And I'm happy to share all that information if you don't already have it in the post-hearing briefs.
Thank you. And with regard to the classification under ICRA, when you're looking at those higher classifications, 3 and 4 versus 1 and 2, would the lower classifications, meaning 1 and 2, typically be things that OSHA would consider maintenance or repair operations as opposed to construction?
Yes.
And this is Chris, I'm not absolutely certain about that. I mean, I think it'd be good for us to go back and look at the different activities and also look at the definitions as applied by OSHA that differentiate maintenance and construction work, because sometimes they're similar, but there is a gray area that you have to apply the regulation to make sure.
Yeah, I can give you some examples real quick. So there's a type A work, which is removing ceiling tiles, painting, wall covering, electrical trim work. Then there's a B type work, which is smaller scale, but includes but not unlimited installation of telephone and computer cabling, access to chase spaces, cutting of walls. Then there's a type C, which gets into more renovation, like sanding of walls, removal of floor coverings, minor duct work, major cabling. And then there's a type D, which is major renovation and construction and demolition. That's the 4 different types of work, and then you match those up with the risk according to, like I said, the patients you're near or not near, and then that matrix spits out, or whatever you want to call it, a very prescriptive list of controls to do in that work. And it's all laid out. Like I said, we will share all that with the post-hearing briefs.
Okay, terrific. Thank you very much. You may be aware that the Centers for Medicare and Medicaid Services issued a rule regarding vaccination requirements among healthcare workers. And the CMS vaccination rule addresses construction work in its preamble, indicating that facilities can require construction workers to be vaccinated. They distinguish between a masked plumber making an emergency repair, wearing a mask, who may not need to be vaccinated, but they also indicate that, on the other hand, a crew working on a construction project whose members use shared facilities, such as restrooms, a cafeteria, or break rooms during their breaks, would be subject to the CMS requirements due to the fact that they are using the same common areas used by staff, patients, and visitors. Would you see that as an appropriate criteria for OSHA to apply? Should we have a similar distinction to apply to construction work in healthcare facilities?
This is Chris. I think the examples you cite should be taken into consideration. When you're considering covering what are normally considered construction employees. However, because I'm not familiar with the rule, I'd have to think about it a little bit. I would, when you take away the vaccination conversation, you know, the bringing in a contracted employer to bring in a specialty trade person for an emergency repair, I don't think should be excluded. I don't think that should be a reason to exclude that contractor from a rule, and exclude those employees from coverage, and from the protection that coverage under the OSHA standard would allow. So I believe that plumbing issues, heating issues, medical gas issues, electrical issues arise in any operation in any healthcare facility, and they should be anticipated. They're not a surprise. So having employees coming into patient occupied areas, even on an emergency basis, they should be afforded protection under the OSHA standard, in my view.
Yeah, and I'll just chime in and say I'm glad you asked that question, because I think we need to look closely at these distinctions and what they mean.
And did I understand then that your view was that in general, construction workers who are in a healthcare facility and are sharing portions of that facility, be it break rooms, cafeterias, restrooms, with the healthcare worker population or the patient or visitor population, should be covered?
Yes, that's our position.
Okay, thank you. That's all I have. I will turn it over to my colleague, Charles McCormick.
Yes, good afternoon. It's Charles McCormick for OSHA. I've got I think just one question, and I'm going to address it to everybody. Panel, and that's simply if you have any additional data or data sources or surveys addressing construction and healthcare facilities, please submit them to the docket, because we'd like to read what you have. So thank you very much.
Will do.
Concludes questioning by the OSHA panel. I'm sorry, did I interrupt someone there?
No, I was just saying, well, do. She said exactly what I was going to say.
Okay, thank you. And we very much appreciate the NAB2 panel's testimony this afternoon. Thank you for sharing your views with us.
You're welcome.
Yes, thank you, everyone. I do not see any hands raised for questions, so again, we thank you for your testimony. Oh, wait, we might have one raised hand. Mr. Allen, Theo Allen has a question for you. So if we could promote Mr. Allen.
I'm promoted, Your Honor.
All right, go ahead, Mr. Allen.
I have a couple of things for the record, but I have a question which is very similar to when I asked another panelist earlier. In your experience in healthcare settings, do your workers that you represent wear respiratory protection for extended periods of time without complaining on a frequent basis?
This is Chris. I'm not sure if I know what would be typical. I know that in different jobs, construction workers do wear respiratory protection for extended periods of time, and it's a normal course of business. N95s are pretty common, in particular in construction, due to a lot of other respiratory hazards that that exist on construction sites. We don't have any specific information about mask wearing attitudes as it relates to the pandemic and construction workers in our information. So
Yeah, I would just add on and say, yeah, we're very used to wearing all types of PPE, including respirators in our industry, for all types of hazards, including airborne hazards like COVID-19. So yeah, it's very common for us to be wearing respirators, and it happens every day on our work sites.
All right. Well, thank you for providing that information. Thank you for your testimony, Mr. Allen. Thank you for your question. One moment. Do we have another speaker? I believe we may have another individual trying to ask a question by telephone. Am I correct?
No, I think we're all set with questions.
Okay. All right. All right. Well, thank you again. Our next and final panel will be from the Construction Industry Safety Coalition. It's my understanding we have Randy Kaiser and Melissa Peters here. If they could be promoted, please. And again, you may begin. You are allotted 30 minutes between the two of you.
Thank you very much. Can you hear me okay?
If you could bump up your volume a little bit, that would be helpful.
All right, one moment, please. Thank you.
I'll ask everyone to speak slowly and enunciate for the court reporter. Thank you.
Yes, Your Honor. Does this sound okay?
Yes, definitely.
Okay, great. Thank you. Hello, my name is Melissa Peters, and I am a shareholder with the law firm of Littler Mendelsohn. I am a core member of Littler's Workplace Safety and Health Practice Group, and prior to joining the law firm, I worked as an attorney for Cal OSHA for 6.5 years. Today, I am speaking on behalf of the Construction Industry Safety Coalition and its members. We appreciate OSHA's consideration of CISC's written comments as well as the testimony we are providing here today. The CISC is comprised of numerous trade associations representing virtually every aspect of the construction industry. Workplace safety and health is a priority for all members of the coalition, and our members are committed to creating safer construction job sites for workers. Sick and injured employees cannot work. And as a critical infrastructure industry, the construction industry has been at the forefront of efforts to implement protective measures for workers specific to COVID-19 since the beginning of the pandemic. Just 3 days ago, in an interview with PBS NewsHour, Dr. Fauci stated, "We are certainly right now in this country out of the pandemic phase." Yesterday, Dr. Fauci clarified his statement after receiving much criticism by explaining that the US has transitioned out of the accelerated component of the pandemic and into what is hopefully a more controlled component in the stage of the pandemic. Given the current state of the pandemic, the process taken by OSHA in promulgating this rule, the low risk posed by COVID-19 in the construction industry, and the nature of the proposed rule itself, the CISC respectfully opposes OSHA's proposal to expand the coverage under the rule to include certain construction work in any permanent standard. Put simply, the CISC's position is that any attempt by OSHA to expand the ETS to cover construction is not supported by the evidence and would be impermissible under the Occupational Safety and Health Act of 1970. OSHA has not provided sufficient notice to support applying the rule to the construction industry. Despite CISC's efforts to engage with OSHA throughout the pandemic, the agency provided only a 30-day comment period on this proposal with no prior notice or indication of its intent to expand the scope of the rule to include construction. OSHA is prohibited from extending the ETS to include construction in any permanent standard because OSHA has not conferred with the Advisory Committee on Construction Safety and Health, or ACOSH, on the standard. OSHA's very own regulations require that the Assistant Secretary consult with ACOSH whenever occupational safety or health standards are proposed. Further, OSHA has not convened a SBREFA panel. The Small Business Regulatory Enforcement Fairness Act requires OSHA to notify the U.S. Small Business Administration's Office of Advocacy and convene a Small Business Advocacy Review panel whenever a proposal is expected to have a significant impact on a substantial number of small entities. This has not happened. Given the general makeup of the construction industry, which is dominated by small employers, the CISC believes a permanent standard with an expanded scope, including construction employers, would have a significant impact on a substantial number of small entities. OSHA designated the construction industry as low risk early in the pandemic. Factors contributing to this designation, including the fact that construction workers have minimal occupational contact with the general public or coworkers, have not changed. The construction industry is focused on efforts to keep its workers safe in all environments and protect them against recognized hazards, including COVID-19. Workers in the construction industry have physical jobs, which require them to be healthy in order to perform those jobs. No one is more invested in keeping construction workers safe than the companies employing those workers. For example, the CISC developed a COVID-19 exposure prevention preparedness and response plan in March of 2020, which has been made available in both English and Spanish and provided at no cost to the entire construction industry. The CISC updated the plan 4 times to account for changes in guidance from the CDC throughout the course of the pandemic. Overall, it is inappropriate to apply a healthcare industry rule to construction for several reasons. The first is that the ETS is specifically tailored to the healthcare environment, and the rule cannot be applied beyond those settings. Section 29 U.S.C. 1910-502A addresses the scope and application of the ETS and specifically acknowledges that the standard applies where an employee provides healthcare services or healthcare support services. The section then narrows this application, carving out certain work that is tangential to healthcare services. These carve-outs are appropriate and recognize that, like construction performed in healthcare environments, these settings do not present the increased risk of exposure to COVID-19 that exists in other healthcare settings. Due to its scope, most of the requirements of the ETS are directly based on and applicable to healthcare settings where indoor, unrestricted, direct patient care occurs. Secondly, work cannot be likened to maintenance or custodial work occurring within these facilities. Unlike maintenance and custodial work, construction is generally not performed in public areas within a healthcare setting. While maintenance and custodial workers are often required to go in and out of patient rooms and walk through areas frequented by hospital staff and the public in order to perform these jobs, construction workers generally are not. This is because, for safety reasons, mostly, construction work generally does not occur in areas accessible to or frequented by the public, patients, or healthcare staff. Construction workers are almost always given their own entrance and exit to the facility and use barriers to ensure others do not enter the construction work site. Negative pressure is used to remove dust and pathogens, and the use of these machines not only protects the construction workers, but prevents irritating or harmful substances used by the workers from traveling to the patient treatment and general public areas at the facility. It works both ways. Due to the nature of their industry and applicable existing regulations, construction employers already implement thorough worker safety and health policies that may not be undertaken by employers in less specialized industries, including maintenance and custodial workers and employers who employ those workers. Construction employers, supervisors, and workers undergo significant hazard recognition training on a regular basis. This is part of the industry. Crews that are designated to perform work at sites located within healthcare facilities receive specialty training on additional hazards that may be present. They also coordinate closely with the healthcare facilities to ensure that the site employer's premises, safety and health policies, and other requirements are followed. Further, OSHA's own definitions of maintenance and construction distinguish between these two types of work. OSHA's regulations define construction work as construction, alteration, and/or repair, including painting and decorating. And that is in 1926.32G and 1910.12B. In determining whether work constitutes maintenance or construction, OSHA looks to the scale and complexity of the project, whether the work is routine and done on a regularly scheduled or periodic basis, and whether the work is focused on improvement versus maintaining the existing state at the facility, among other factors. Given these distinctions, it is not appropriate for OSHA to make a comparison between construction and maintenance or custodial work for the purposes of applying the same requirements to each. Finally, any expansion in the scope of the ETS would go beyond OSHA's authority under the Occupational Safety and Health Act, in that OSHA's proposed expansion is an attempt to regulate the hazards of daily life, over which OSHA we know has no jurisdiction. This is something that was raised in NIFB v. OSHA by the Supreme Court in their decision, where they made clear that permitting OSHA to regulate the hazards of daily life simply because most Americans have jobs and face those same risks while on the clock would significantly expand OSHA's regulatory authority without clear congressional authorization. Contractor requirements should be managed primarily by healthcare or other primarily covered entities. Our very last point is that contractor requirements, including COVID-19 protocols and training requirements, should be managed by the hospital or other contracting entity where the work is performed. It is unnecessary to add regulations requiring efforts by construction employers when appropriate safety protocols and controls are already implemented by the facility. Multi-employer work sites are not a new concept in the OSHA world, and construction employers have always worked closely with the host employer to ensure compliance with its safety protocols. Further, construction employers often have designated crews who perform the work at healthcare facility locations. These specialized crews are trained to implement and follow precautions specific to the healthcare industry. For these reasons, any requirements for construction employers should really be focused on facilitating a dialogue with the contracting or host facility regarding COVID-19 and other safety protocols and enforcing same. At this time, I'm going to turn CISC's testimony over to Randy Kaiser. As the National Healthcare Director for Turner Construction, Mr. Kaiser has extensive experience with safety and health issues specifically related to construction and healthcare settings. Mr. Kaiser?
Hello, just for the record, I am Randy Kaiser and the National Healthcare Director for Turner Construction. We, as a company and me personally, have a significant amount of experience building hospitals. We as a company started building hospitals in 1926, and me personally have been working on hospital jobs my entire career at Turner for 41 years. We're the nation's largest healthcare builder and do about $3 billion worth of work. So I say all of that just to give a little bit of context of expanding on some of the things that was discussed earlier today. So I want to talk about the safety precautions that are already in place. In addition to the fundamental safety practice for construction to establish a clear work zone that is separated from the patients, staff, and visitors, the construction industry has numerous infection control safeguards in place to reduce the potential spread of infection. Construction at healthcare facilities requires additional planning and have added layers of protection in place depending on the nature of work. Projects can range from construction of new standalone facility in which there's no interaction with the public, patients, and healthcare professionals, to the renovation of space within an active healthcare environment in which job-specific plans are developed to protect the construction workers, and patients, and the staff. And that, is that infection control risk assessment that Travis and Chris talked about earlier. A great deal of planning is required when we work on these, on the hospitals. Construction zones are established and activities closely coordinated with the healthcare institutions to limit the impact of work on the patients and visitors. In addition, CMS, through their deeming agencies, such as Joint Commission and et cetera, requires hospitals to develop a job site specific infection control plan. Detailed requirements are spelled out. For example, the Joint Commission has an environment of care guidelines, and these guidelines vary as I think Travis talked about earlier, depending on where they're at in the building. But in general, whenever we do work, we're behind a wall that's sealed up to the deck. We have negative air machines, and we create this barrier between construction and patients. So with the fact that we are doing specific infection control plans on all of our jobs, and it's our recommendation that we just follow and work with the individual hospital requirements that are developed by weighing the risk and of where you're doing the work, and include what safety protocols we put in place and fulfill requirements as addressed by the Joint Commission or EOA guidelines. So it's our opinion the hospitals develop their own requirements for vaccination and mask requirements specific to their unique circumstances. And this would be documented in all our infection control risk assessment plans. I do want to add one last thing, is that that since early 2020, the start of COVID, we have completed a considerable amount. We as a company has completed a considerable amount of contact tracing for our construction workers who've tested positive for COVID-19. In general, when someone tested positive, it was traced back to a minimum of 4 days, and we trace that through an interview with the worker. And in back to activities that we trace that contact back to activities that were not job related, such as social gatherings, home environment, ride sharing, etc. So that being said, our information is not pointing to a job site spread, but more related to social activities in the home environment. So thank you for your time.
All right, thank you. It's my understanding that has Rachel Stull joined us, and will she be speaking?
Yes, she should be here. And
yes, I'm here.
All right, you may begin.
Thank you. Good afternoon. My name is Rachel Stull, and I am the Senior Safety Administrator for Power Solutions, LLC, a large electrical contractor based out of Bowie, Maryland, and doing work in Maryland, DC, and Virginia. I am also the chairwoman for Washington, DC chapter of NECA's Safety Committee. I am speaking today as an employer representative of NECA and the Construction Industry Safety Coalition. First, we would like to thank OSHA for scheduling this hearing to allow stakeholders to speak to the agency regarding the proposed permanent healthcare ETS changes. NECA is the voice of the $171 billion electrical construction industry that brings power, light, and communication technology to buildings and communities across the United States. NECA contractors are the technical professionals responsible for the most innovative and safest electrical work done in the United States. During the pandemic, we monitored best practices in areas of health and safety with a goal of protecting industry workers. NECA is a member of the CISC, and as you heard during Melissa Peters' intro at the beginning of our time today, the Construction Industry Safety Coalition is comprised of approximately 30 construction industry trade associations representing contractors in practically all trades. In total, the CISC members represent hundreds of thousands of contractors throughout the country. Today, we would like to ask the agency to consider the following as they deliberate over changes to the healthcare ETS that would affect the construction industry. Hospitals and other healthcare facilities are experts on controlling infectious diseases and the possible spread of disease, bloodborne pathogens, viruses, and more. When working in these facilities, we are required to follow the policies, procedures, and protocols of that facility. These procedures include basic site entry rules, areas of operations we would be allowed access to, security badging, activity hazard analysis, or AHAs, job hazard assessment requirements, JHAs, both of which would involve reviewing the work tasks at hand, step by step for daily work, and the hazards we would encounter while doing that work. Then the controls or the abatement required to reduce or remove those hazards, with a goal of following the hierarchy of hazard controls and removal or elimination of risk where we are able, and then reducing risk where it cannot be completely removed. When working in healthcare facilities, we would be in separated, cleared, sanitized, barricaded, or authorized areas away from patients or more hazardous environments, mostly with a specified entrance and exit area or staff escorts throughout the building. Many of us, as Melissa spoke about earlier, employ specialty teams or groups trained to operate in the specific environment of hospitals or healthcare facilities for either electrical maintenance or other construction type work. During the pandemic, the construction industry has been on the front lines, keeping our workers safe, developing exposure plans, training, and updating our processes to follow CDC guidance, along with local, state, and federal regulations. OSHA and the construction industry quickly developed resources to help contractors stay informed, safe, and in compliance. Resources such as the NECA coronavirus website, the Virginia Standard for Infectious Disease Prevention, the AIHA's Focus on Construction Health COVID-19 Guide, the CISC's COVID-19 Exposure Prevention Preparedness and Response Plan, along with many other OSHA resources and guidance on for the construction industry. COVID-19 certainly added more risk and hazards to our work. However, before the pandemic, we've been working safely in healthcare facilities, which pose risks such as bloodborne pathogens, viruses, aerosol transmissible, and other diseases. Following the healthcare facilities protocols, we then developed training, site-specific orientations, activity hazard analysis, job hazard assessments, which Randy spoke about earlier, and also Travis and Chris Kane spoke a little bit about earlier as well. and other safe work procedures to avoid, lessen those risks, and we've been able to keep our workers safe and continue to do our work during these times. It would be our recommendation that we continue to follow the direction of the hospitals and medical facilities as we continue to work safely under the facility's requirements. Construction contractors should not have to develop additional plans and programs for workers in healthcare facilities. Compliance and oversight should be on the healthcare facilities in developing and managing that compliance. We would like to again thank OSHA for the opportunity to speak at this hearing today and for their continued diligence and efforts in health and safety for industry workers. Thank you for your time.
Thank you. Will there be any further speakers from the Construction Industry Safety Coalition?
There will not, Your Honor.
All right. All right. Now we'll take questions as before. We will first hear from the OSHA panel. If there are any of our stakeholder attendees who would like to ask a question, please either raise your hand in the chat button, or if you are on a phone, press *3. So please do that while we listen to the questioning from the OSHA panel. So if the OSHA panel would like to begin, please do.
Thank you, Your Honor. This is Dave O'Connor with OSHA. Ms. Peters, Mr. Kaiser, Ms. Stahl, thank you for your testimony this afternoon. You had testified to the effect that there are a number of protections in place for construction workers who are performing their activities in healthcare workplaces. And I was just wondering, with regard to those protections, you indicated they're generally separated from the patient care areas, public areas, that there are barriers in place. But in situations where those protections are not in place, where they're not separated, where there aren't barriers in place, for example, and the work is being performed in areas that are shared with healthcare worker staff, potentially with others in the facility. Would you agree that that is fundamentally different from the other construction activities where protections are in place? And if so, what protections should be afforded to those workers?
Randy, I don't know if you wanted to say something. I could see you about to speak. Randy, I think you're on mute.
Sorry, Mr. O'Connor, I'll try to address that the best I can. In my opinion, when I work with a hospital, we sit down, and whenever we have a job, we go through the infection control plan. It's documented. If we have a painter, we don't have a painter out in the middle of the hallway painting and patients walking by. Because of the smell, and they may get something on them or whatever. Whenever the hospitals that I worked on, I think at the minimum you're going to have at least a plastic barrier or something up that may not be as robust as if you're doing a big job and you got a wall that goes all the way up to the deck. But I would say that if you ever had something in which somebody had to go out and do some work in with these patients, I think that's more like a maintenance type of deal. When we do the construction, we are typically behind barriers. And I'm trying to scratch my head of a time that I've seen recently in which any of our construction workers are out in that general public doing that work without at least getting behind the door, closing the door, and we put some tape on the bottom of the door so we're not letting any of the dust or any of that go through. Now, the only exception would be if there's no way of getting to that job site without having to walk down the corridor, and then could be a time in which somebody walked down the corridor and a patient may be, like down at the other end of the corridor or something. But we're not inside exam rooms. We're not inside, a patient room laying in a bed. We just don't walk inside that and be mixed up with those patients. And I don't recall of a hospital that even lets us set in their cafeteria and have lunch with them. It used to be common, 5, 6, 7 years ago, but nowadays that is all gone away. And even before COVID, the hospitals, they do a very good job of putting together plans that's separating those workers from their patients.
I'd like to add to that if I can.
Please.
Go ahead, Rachel. I almost cut you off.
Thanks, that's okay. So I just want to add some maintenance examples. And I think there were some great examples given yesterday in some of the testimony by Wes Wheeler. And, when we're in a building doing maintenance type work, even if it's replacing a receptacle or replacing backup batteries, general maintenance, we have to, put up barricades and separate ourselves, because sometimes the work that we're doing also poses its own hazards and its own risks. So we would, whether it's a expandable barricade, or whether it's that we're working in an electric room, or whether it's we are on a roof that only has authorized access, that a building engineer or building maintenance would have to take us up, to that area. For the most part, we would be separated, or we would separate ourselves. Some examples given yesterday were, we may be walking down a hallway and passing, or we may be in an elevator for a minute or two going to a different floor, but, it would be a very short amount of time. It would not amount to, more than the allotted exposure times, you could say. I hope that helps a little bit.
Yes, thank you. And would construction workers typically be sharing restroom facilities with the staff at healthcare facilities?
I'll answer from my point of view. That the hospitals I work in, they just say you guys got to set up your own restrooms. That you typically are not going in and using their facilities, because a lot of our guys, we're got mud on their shoes or whatever, and they just don't say, come on in and help yourself to it. And Rachel, I don't know if you can think of a time in which maybe you do have something that goes on that is a small reno somewhere and you just don't have access to a restroom. But I don't see it.
I think it would depend on the size of the renovation. If it's a full floor, the answer would be a definite no. I can't speak for every occasion, but for the most part, it would be a no.
And the measures that you described that segregate construction work at hospitals, are those generally in place at other types of healthcare facilities too? When you're doing construction work there, places like nursing homes, for example, or doctor's offices?
That was a very good question, Mr. O'Connor. I tried to track down that answer. I was thinking you may ask that question. And when I asked a Joint Commission inspector yesterday, they said it depends, and it depends on, from his opinion, I'm not an expert on the CMS requirements, but his opinion, if it's owned by a hospital in an hospital setting, that all those infection control procedures follow under that. But if it isn't owned as a licensed hospital, because this all falls under CMS, and the CMS giving the hospital a license to operate. On a occasion, like if the person that spoke a couple of times ago that was in the local drugstore, that probably would not would not apply as it relates to that environment of care rules and the walls to the deck that I was speaking of.
Okay, thank you very much. I will turn it over to my colleague, Charles McCormick.
Actually, Mr. O'Connor, if I may, I just wanted to add something briefly.
Oh, please do.
No problem. Thank you. All I was going to say is, one of the points that we made, and I wanted to emphasize again now because I think it's very relevant with the questions that you asked. Like I said in my testimony, the multi-employer theory of liability and working on multi-employer work sites is not a new concept to OSHA, right? And this is something, our position is really that these are details that are going to be covered and worked through with the site employer, with the host employer, correct? Before the project is started, you sit down, you come up with a plan, and you troubleshoot these things. Also, the construction contractor, often it's not up to them, right? So it's, they don't have the control. It's the controlling employer is the site employer, and they're the ones who are going to sort of make these determinations, which is part of our point that, certainly the construction industry is already heavily regulated. There are tons of safety regulations and measures that are taken, certainly in the specialized work, where any of this work is being done in healthcare facilities. But it's really going to be working with the site employer and the healthcare employers and making sure that the protocols that they come up with, they are enforcing. And then, of course, the construction contractors have no problem following suit. They want their employees to be safe. They want everyone to be safe. So I just wanted to add that, sir.
Thank you. And now I'll turn it over to Mr. McCormick.
Yeah, thank you. Yeah, it's Charles McCormick from OSHA. And I've got a little bit of a long question here, but it's essentially a request for data. If you could please submit any data or reports on the number of construction workers who work in operating healthcare facilities. We'd like data which is as specific as possible, including the types of healthcare facilities where construction workers are found. If possible, we would like you to distinguish between projects in CMS and non-CMS facilities. We're primarily interested in work on existing facilities versus new construction. So please submit those data or reports to the docket, and thank you very much.
Thank you, Mr. McCormick. Duly noted. We will do so.
And OSHA has no further questions for the CISC panel. Thank you again for your testimony.
Right, thank you. We have one question from Mr. Theo Allen. If he could be promoted, please.
Thank you, Your Honor. Mr. Kaiser, and I do have some other questions, but for Mr. Kaiser, unfortunately, over the last, actually just before the pandemic and rather recently, within a couple of weeks, my home has been undergoing some renovations, including paint, and I can tell that it has actually negatively impaired me, possibly getting me sick over the past week. So I'm wondering, in a healthcare setting, what sort of precautions would you take to make sure that that doesn't happen? Because it happened recently to me when they were painting basically outside my home.
Yeah, I'm not so sure I'm quite prepared to answer a question similar to that. I was more prepared to talk about the construction inside of a hospital that and what the precautions that we take on inside that hospital setting.
And that's fine. If there's not an answer, there's not. So thank you. Anyone else? I'm not sure that. Okay. Thank you. All right. Thank you, CISC, and thank you, Mr. Allen. And seeing no other hands and no indication that anyone on phones have requested to ask a question, we will conclude the panel of CISC. So thank you. Right. It is approximately 4:20 and we have completed all of our panels for the day. So this is the end of day 3 of this hearing. I'd like to remind stakeholders that if we were unable to take any questions during the allotted time, I'm not sure that that happened, but in any case, you can submit your questions to ets@dol.gov, and the questions will be added to the hearing record, and panelists can choose to reply in their post-hearing comments. Please submit all of those questions by 5 p.m. Eastern, Monday, May 2nd. Also, stakeholders may submit additional evidence or statements relevant to the proceeding within 21 days at the end of the hearing, which will be May 23rd, 2022. At that point, the record for this rulemaking will close. On behalf of the Department of Labor, I wish to publicly thank all of those people who gave their time and testimony and questions to contribute to this hearing today. To all of the participants, thank you for your interest in this important matter. This hearing is hereby adjourned for today. We will reconvene at 9:30 a.m. Eastern on Monday, May 2nd.